flow, measuring 3 into 2 into 2 centimeter. She further underwent guided FNEC of the thyroid nodule. I will invite Dr. Anurag sir on the stage to discuss the cytopathology of the same.
Good morning to all of you. I am presenting the pathological part of this case. For present case, patient went for right lobe thyroid fine needle aspiration cytology, ultrasound guided. This is the smear from right lobe thyroid nodule. The smears are visually cellular and so papillary fragments and clusters of tumor cells disposed on hemorrhagic background. There was no necrosis in the background and neither matured lymphocytes or reactive lymphocytes are seen in the background. This is the higher power view of the smear, displaying the tumor cells which are disposed in clusters and tumor cells are overlapping with each other. Further higher power view showing the tumor cells having enlarged nuclei, conspicuous nuclei at the periphery, and moderate to abundant amount of eosinophilic cytoplasm. Few nuclear pseudo-inclusions are also noted in the tumor cells. This is the further higher power view, displaying the nuclear pseudo-inclusions and nuclear grooving among the tumor cells. So, conclude the cytomorphological findings of the present case. Present case showed the richly cellular smears and cohesive group of cells along with finger-like papillary fragments of cells. Tumor cells are displaying nuclear crowding and nuclear enlargement along with pale chromatin, internuclear cytoplasmic inclusions along with the grooving. So these features are characteristics of papillary thyroid carcinoma. However, few of the smears show columnar-like tumor cells. These tumor cells are having basal nuclei and abundant amount of eosinophilic cytoplasm. This is the further higher power view, displaying the columnar type of cells which are elongated and having basal nuclei and apical abundant amount of granular cytoplasm. These cytomorphological features giving the clues about the tall cell variant of papillary thyroid carcinoma. However, a differential diagnosis is very difficult on fine needle aspiration cytology smear because it overlaps with the classical PTC and columnar cell variant of PTC and oncocytic variant of PTC. These are columnar-like cells having apical cytoplasm and basal nucleus. However, it is very difficult for the pathologist to make a variant of PTC on cytomorphology because it overlaps with the classical PTC and they should be mistaken for columnar cell variant or oncocytic variant or Verdine-like PTC variant. Usually, columnar cell variant of PTC is associated with necrosis and there is very subtle nuclear inclusions or nuclear grooving inside the tumor cells in columnar cell variant. And in oncocytic variant, these tumor cells are not such tall as in columnar variant of PTC. And in Verdine-like PTC, usually the background contains numerous lymphocytes. Hence, a diagnosis of papillary thyroid carcinoma suspecting for tall cell variant of PTC. Now, I would like to invite my endocrine colleague for further discussion.
So we had a diagnosis of right solitary thyroid nodule, Bethesda 6. And since it was a well-defined lesion with less than 4 centimeter largest diameter, the patient was scheduled for right hemithyroidectomy. She underwent same. We can see here the specimen. We can see here in the specimen a well-defined solitary thyroid nodule, which measured approximately 3.5 into 3 centimeter. The final histopathology of the same will be discussed with Dr. Anurag. I invite him on the stage for the same.
For the same case, we received a right hemithyroidectomy specimen and cut surface of which showed grayish white solid nodule. This is the photomicrograph of the hematoxylin and eosin stain section, displaying the numerous tumor cells disposed in form of papillae, and these papillae are having fibrovascular core along with the scant amount of colloid inside the thyroid follicles. This is the further higher view of the same, displaying the nuclear clearing. This is the nuclear clearing among the tumor cells and nuclear grooving inside the tumor cells. This is the further magnification view of the HE stain section, displaying the tumor cells over the papillae. These papillae are having fibrovascular pores. This is the core of tumor cell, core of fibrovascular, and these are tumor cells arranged over the fibrovascular core. These tumor cells are elongated and having basal nucleus. It is the cytoplasmic membrane of tumor cells and clearly evacuated. Hence, the diagnosis of Gall cell variant was given in this case because more than 30% of tumor cells are Gall cell and having columnar appearance and along with the abundant amount of eosinophilic cytoplasm. And Gall cell is a type of columnar-like cells which height is more than 3 times of width of the tumor cells. This is the
I think we
width
can
of tumor
take
cell.
questions once the case discussion is over.
This is the width of tumor cell and it is length of the tumor cells, and length of the tumor cells is more than 3 times of the width. Hence, a probability of hence a diagnosis of Gall cell variant PTC was given in this case. Why it is important to report Gall cell variant of PTC? Because of clinical and prognostic importance. Gall cell variant tumors are aggressive than classic papillary thyroid carcinoma tumors. These tumors have higher rate of extrathyroidal extension, vascular invasion, and lymph node metastasis, and higher recurrence and higher mortality rate, and lower disease-free survival. Considering the more aggressive therapy for the tumor in form of radioactive iodine and closer follow-up is advised in these tumors. These tumors are usually associated with BRAF mutations, which may guide the targeted therapy in the Gall cell variant of PTC cases. When the tumor cells have 30% or more of PTC cells whose height is more than 3 times of the width and so abundant eosinophilic cytoplasm with prominent cell membrane, then it is considered Gall cell variant of PTC. These tumors are associated with older age, larger tumor size, and extrathyroidal extension. These are more aggressive than the classical PTC and usually have BRAF V600E mutation in the tumor. These are the differential diagnosis of Gall cell variant, which includes columnar cell variant of PTC, oncophytic variant, and Vardhan-like papillary thyroid carcinoma PTC. Columnar cell PTC have pale eosinophilic to clear cytoplasm, prominent nuclear pseudostratification, and subnuclear vacuoles. And in columnar cell variant, characteristic feature of PTC like nuclear pseudo-inclusions and nuclear grooving is usually absent or very subtle. However, their length is not more than 1 to 1.5 times in columnar cell variant. However, in Gall cell variant, length of the tumor cells is more than 3 times of the width. In oncophytic variant, there are tumor cells having oncophytic cytoplasm and papillae and nuclear features are same as the classical PTC. In benign-like papillary thyroid carcinoma, papillae are present which have fibrovascular core, and in these fibrovascular cores there are numerous lymphocytes and plasma cells are present. And benign-like PTC usually have chronic lymphocytic thyroiditis or hashimoto-thyroiditis in their background. Now I would like to invite my endocrine colleague for the further discussion.
Thank you, sir. The patient, the post-operative period was uneventful, and the patient was discharged on post-operative day 3. She is further planned for completion thyroidectomy and whole body radioiodine scan along with the need of radioactive iodine ablation or therapy is to be considered. Her first response assessment will be done 3 months after the surgery. I will now be inviting Dr. Divya Priyadarshini to the stage to further discuss the clinical implications.
Well, that was the pathology discussion was very detailed, and thank you, Dr. Anurag, for the same. I'll just briefly touch upon some already known factor about tall cell variant of papillary thyroid carcinoma. As we have already known, that's an aggressive subtype having more extrathyroid extension with the more invasion, lymph node metastasis, and having BRAF 600 mutation positive. So that translates into high risk of recurrence and aggressive behaviors clinically. So this needs more aggressive treatment in terms of thyroidectomy more than lobectomy. Along with that, also this type of tumors needs more adjuvant therapy in form of radioiodine therapy or ablation. And this kind of patients needs rigorous follow-up. In the new ATA classification, this has been categorized in the intermediate group having a intermediate to high group having a recurrence rate of 16 to 30%. That is why they have mentioned that this kind of patients needs adjuvant radioiodine therapy along with TSS operations. So here is a projection of the difference between tall cell variant of papillary thyroid carcinoma and classical papillary thyroid carcinoma. As we all know that these kind of patients needs more frequent follow-up and careful follow-up. So they should be follow-up like classical papillary thyroid carcinoma with TG, anti-TZ, TSH, and a ultrasound with every 6 to 12 weeks. Along with that, this kind of patients needs adjuvant, should be sent for adjuvant radioiodine therapy or ablation. Along with that, the most important thing is TSS operation to keep in control the cancer. So these kind of patients, our tendency should be to keep the TSH towards the suppression side from 0.1 to 0.5 if falls in intermediate category. And if it falls in high risk or is there any structural recurrence, that should be less than 0.1. Coming to the surveillance part, similarly with classical papillary thyroid carcinoma, for the initial 2 years, we should follow up the patient with biochemical and ultrasound NEC for every 6 to 12 months. And if needed or if structural disease is present, a diagnostic whole body iodine scan or a BZ PET, if indicated, should be done. And if they are area refractory, as we have already known that these kind of patients are having BRAF positive, so a systemic therapy can be considered in form of targeted therapy for this kind of patients.
So, thank you. And now this case is open for comments and discussion from the floor. And Dr. Anurag and Dr. Divya would be taking up the questions. And if any distinct intervention is needed from senior pathologists, we have among us Professor Manoj Jain, who needs no introduction, and Dr. Pallavi Pusha.
Good morning, myself, Dr. Pradeep. Actually, our pathologists usually say that reporting tall cell and columnar cell variant is difficult on FNAC. And in this case, it has been reported. It's good to see that report. The second part of the observation is that in spite of having a report like that, you went for a hemithyroidectomy instead of a total thyroidectomy. Should have been the treatment in this case. So my question is to both of pathologist as well as the managing surgeon.
Sir, tall cell variant is reported on histopathology. Only a possibility of possibility of tall cell variant was considered after FNAC. But it is very difficult to say it is tall cell variant. Tall cell changes can be suspected. However, tall cell variant, exactly giving the diagnosis of tall cell variant of PTC is very difficult on FNAC. Even on histopathology, sometimes it is very difficult to say it is tall cell variant or it is tall cell changes inside the classical PTC.
No, but in your final report of the FNAC report, do you mention that there is a possibility?
Final histopathology report does not contain about the variant of PTC. Only it is given.
In the description, do you mention that you have seen cells
Yes.
like that?
If in definition it is written that oncocytic cytology inside the.
So when it is given in the description, when you read through the description,
But-
that there is a possibility of tall cell, then our tendency to go towards a protein becomes more. So we are likely to go in for a.
But oncocytic changes can be seen in classical PTC as well as an oncocytic variant of PTC and columnar cell variant of PTC.
Dr.
Sometimes
Pradeep,
it is very non-specific in the classical variant of PTC.
Dr. Pradeep, actually, Dr. Sabha here. This patient had come to me with the diagnosis of colloid nodule outside, actually. One FNAC outside was colloid nodule, and she was very interested in having a microwave ablation done, actually. So the first FNAC done here was AUS, Bethesda 3. The second FNAC, because microwave demands 2 FNA, the second FNAC was suspicious of PTC. There, the tall cell was not very clearly mentioned, oncocytes were mentioned. And we did discuss this with the patient, and then we took a decision of hemithyroidectomy. Did it answer your query?
Yeah, okay. Thank you.
So in this case, radioactive iodine ablation can be directly given, or should we do a scan before?
Before we have done an hemithyroidectomy.
No, I mean after completion therapy is anyway planned for this case.
If indicated, like this kind of patients, if we find any central compartment lymph nodes during the surgery. So, and also if we in the final histopathology, if we find there is any other foci in the contralateral lobe, we'll send the patient for the.
No, sorry, I missed. Is it tall cell variant, right?
Yes.
So it comes in intermediate. So
Yes.
it depends on institution whether you do a scan, uptake scan first, or some go ahead with remnant ablation, or in case of central compartment lymph node positive, then they see that what is the number of nodes
Yes.
and the,
Yes.
so depending on that. So radioiodine is indicated. Only thing is, yeah, it depends on institution whether they do it a pre-scan and
Yes.
then ablate, or
Or
they
the-
go with an empirical dose. That's all.
Sir, just to add to Pradeep sir's question, sir, on cytology, we had mentioned it as a PTC with oncocytic changes. It is now that we are presenting this case, and on review, we try to find those cells so that for the completion of the case, we highlighted those columnar cells. But that was not picked up, and it is, as you mentioned, it is difficult on cytology to pick those cells. That is why they proceeded with him.
And I believe in this thing, final histology also, they have a cutoff criteria that at least 30%
30%.
cells should be tall cell. Otherwise, they would not be labeling as tall cell subtype. It would be just PTC with tall cell area. Is it that?
Because in cytology, we don't get the whole tumor. The whole tumor will get in histopathology only, and the criteria for tall cell variant is more than 30% of the tumor cell should have tall cell morphology. And in FNAC, we get only a small area from where we are getting the cellular clusters. In those cells, we cannot judge whether this is representation of the 30% of the tumor cells or not. That is why it is very difficult to give tall cell variant on cytology alone, unless and until we have all the cells showing tall cell variant.
The Bethesda 2023 recommends AUS and then suspicious of malignancy, high-grade malignancy, and risk of malignancy they have mentioned in their table. So in cytology, until unless you are seeing the whole florid tall cell, one should refrain. Otherwise, 30% criteria will be made as a stop.
So what is the criteria for oncocytic changes versus oncocytic variants of PTC?
Yeah, oncocytic is just a morphological expression. You see granular cytoplasm, lot of cytoplasm that जो है, that can mimic with this tall cell also, and independent that can be seen. Even Warden like also they can be seen. जो है.
So any fixed criteria like in tall cell is told about the 30%. What
Yeah.
about the oncocytic variant of papillary thyroid cancer?
Oncocytic more than 50. More than 50% should be. Yeah.
Okay. Thank you.
Yeah. So thank you. Sorry. In this case, now invite for the second case, जो है, another interesting case of thyroid. Presenter Dr. Prachi and discussing Dr. Ojas Gupta from pathology department and Dr. Espanna from endocrine surgery department. So as we know, the WHO 2022 classification of thyroid endocrine pathology, they have risk stratification between benign and malignant. In between group they have kept, which is important for risk stratification. So we'll be highlighting those areas.
Thank you, sir. So this case is of a 63-year-old lady who presented to us with chief complaints of anterior neck swelling along with the occasional shortness of breath for past 1 year. And she also developed a recent onset dry cough for last 1 week. On examination, she was found to have, as we can see here, dilated veins were there in the neck and the upper chest region. On palpation, she had a multinodular goiter, and the left lobe was larger in size as compared to the right lobe, and the lower border of the same was not palpable, implying that it was having retrosternal extension. The trachea was deviated towards the right side. Since she was having shortness of breath, recent onset, she underwent chest X-ray, which revealed a radio-opaque soft tissue mass in the upper chest region, along with deviation of the trachea. To characterize this thyroid lesion, she also underwent ultrasonography of the neck, which revealed multiple nodules and bilateral multiple nodules, which were TIRADS 4. The largest was present in the left lobe, measuring 55 into 80 millimeter. However, she was not having any significant lymphadenopathy. Since she was having retrosternal extension, she underwent contrast enhanced CT of the neck and upper mediastinum region, which here we can see as was evident in the ultrasonography. Both of the lobes were having multiple nodules, and the left lobe was extending retrosternally and was almost reaching the arch of aorta. She underwent guided FNAC of the thyroid lesion further, and I will invite Dr. Ojas sir to the stage to discuss the FNAC of the same.
Thank you, Dr. Prachi. Good morning, everyone. I'm Dr. Ojas, Assistant Professor in the Department of Pathology. I'll be discussing the pathology part. So for this case, USG guided FNAC was done from the right lobe of thyroid lesion, and the smears were moderately cellular, and we can appreciate that there were clusters and some singly scattered tumor cells. The further higher power view of one of the cluster is showing repetitive microfollicles with overlapping of the nuclei, and we can appreciate that there is hyperchromatic nuclei. However, there were some of the cells which were showing nuclear grooving. In addition, a few of the additional passes show papilleroid clusters, and again, these cells were also having abundant cytoplasm. And on higher power view, we can appreciate that these cells were showing intranuclear cytoplasmic pseudo-inclusions. They were having clear chromatin, as well as some of the cells were showing nuclear grooving. So considering this moderately cellular smear papilleroid fragments with presence of nuclear grooves, intranuclear cytoplasmic pseudo-inclusions, a diagnosis of papillary thyroid carcinoma, Bethesda category 6 was given. I'll invite Dr. Prachi for the further clinical discussion.
Thank you, sir. So we had a diagnosis of papillary thyroid carcinoma, CT3A N0M0, and the patient underwent total thyroidectomy. Along with the patient underwent, first we had a plan of doing frozen section biopsy of any suspicious lymph node that were found in the lateral compartment. However, the frozen section biopsy of bilateral jugular lymph node were found to be negative for malignancy. So the patient underwent total thyroidectomy along with the central compartment lymph node dissection was planned. However, there were no significant lymph nodes present in the central compartment. Only loose areolar tissue was found, so that was removed. We can see here the left lobe is larger than the right lobe and it was extending retrosternally. The largest nodule in the left lobe measure 15 into 8 into 5 centimeter. And the final histopathology will be discussed by Dr. Ojas. Sir, I invite you to the stage.
Thank you. So this is the first image. So for the reference, normal thyroid usually weighed less than 25 grams, whereas this total thyroidectomy specimen weighed 330 grams. The outer surface show multilobulation. It was multilobulated, and all the lobes were enlarged. Both the right and left lobes were enlarged, and there was presence of enlargement of the isthmus as well. The outer surface was well encapsulated. There was no capsular breach. There was congestion. And the right lobe measures maximum dimension of 13 centimeters, left lobe was 7, and isthmus measured 3.5 centimeters in the maximum dimension. The cut surface of these lobes were showing grayish brown discoloration, grayish white firm inconsistency. The center of these nodules were necrotic, and we can appreciate that there are multiple nodules, and the necrosis was present both in the center as well as in between these nodules. So to further highlight this is the scanner power view of these nodules. So this blue looking area is the tumor part, and this intervening area is the necrosis. So we can appreciate that these are the two nodules and there is presence of necrosis in between these two nodules. So this is a scanner power view of one of the largest thyroid nodule, which was measuring 6.5 centimeter. We can see that the capsule is thickened and there is presence of a cellular tumor beneath it. And on the low power itself, we can also appreciate that there are some intravascular tumor invasion within the capsule. We will see higher power view sections of these invasive foci as well. But let's move on first to another section where it is displaying the presence of tumor cells with a thickened capsule, and we can appreciate that there is a degree of capsular breach is present here. If we draw a straight line between these two fibrous capsule, we can see that tumor is bulging out from it. And for comparison, these are the normal thyroid parenchyma, which is peripherally compressed, and this is the tumor nodule. As we can appreciate that there is definite bulge of tumor, which is invasion of the tumor outside the capsule. So this is a feature of capsular invasion in case of thyroid carcinoma. So let's come back to the vascular invasion foci. So we can appreciate this is the one of the vascular lumen, which is filled with the tumor thrombus. It is attached with the lining of the vessel wall and it is lined with the endothelial cells. So this is a vascular invasion in this tumor. There was another foci of vascular invasion. As we can appreciate that there are RBCs and plasma within the lumen of this vessel wall, and these tumor cells are attached with the lining. And there are endothelial lining as well present in the around the tumor cells. So let's move on to the higher power view to appreciate the morphology. So these tumor cells were arranged in repetitive microfollicles. The cells were hyperchromatic, although they were showing some nuclear grooving. In addition, there were presence of frequent mitosis, as we can appreciate it that in this higher power view itself, there are two mitotic figures. In addition, few of the nodules were well encapsulated, and like this nodule, this was also well encapsulated. And on higher power view, we can appreciate that this nodule is showing papillary fibrovascular core with tumors lying in the papillary fronts. So this was also papillary thyroid carcinoma. It was showing classical features with the nuclear clearing and grooving, which Dr. Anurag has already highlighted you. So in total, this total thyroidectomy with involvement of both the lobes and isthmus, the histological diagnosis was high-grade differentiated thyroid carcinoma with presence of high proliferative activity, presence of tumor necrosis, and angioinvasion, which was more than 4 vessels. So according to AJCC 8th edition, it was classified as PT3AN0 and stage 2. So a little bit about the capsular invasion and vascular invasion. Why I'm highlighting this? Because it will be also needed in the subsequent cases. So this, if this is the pictorial demonstration. So In the green color, if we take it as a fibrous capsule and the red one as a tumor. So if we draw a straight line between the edges of these tumor, and we can see that the tumor is going outside of this line. So then it is called as capsular invasion. For references, these two histopathological images are showing the same. If you draw a line between these two fibrous capsule, if the tumor is going out, it will be called as capsular invasion. Whereas any tumor which is present within the capsule in the form of mushrooming or present singly scattered, it will not considered as tumor invasion, capsular invasion. Even presence of tumor outside the capsule will also be taken as positive for capsular invasion. Also very important thing is complete resection of the thyroid tumor is important, and adequate sampling is also important to exclude a possibility of capsular invasion. In addition, let's move on to the vascular invasion. For the vascular invasion, the vessels have to be seen within the capsule or outside the capsule. The tumor should be present within this vascular lumen, and it should be lined by the endothelial cells. Also, if the endothelial cells are not lining the tumor cell, then there has to be presence of a fibrin which is attached to the tumor cells. The presence of intravascular invasion is not considered if it is present beneath the capsule. Okay. For histopathological representation, these two images are showing the same, in which this tumor is attached with the wall of the vessel and it is lined with the endothelial cells. And in this second scenario, there is presence of fibrin, which is attached to the tumor cells. So in both the cases, there is presence of vascular invasion. And again, complete resection of the thyroid tumor and adequate histopathological sampling is important to confirm it as a vascular invasion whenever in doubt. So another important feature is the PTC-like nuclear features. So there is a scoring system and 3 features has to be looked on. First is shape and size, where nuclear enlargement, elongation, overlapping, crowding are seen. So for representation, this histopath image is showing nuclear crowding and there is grooving. For nuclear membrane irregularity, we have grooves or pseudo-inclusions. For pseudo-inclusions, there has to be presence of intranuclear cytoplasmic pseudo-inclusions where the inclusion should match with the color of the cytoplasm. Then we say it's a true intranuclear cytoplasmic pseudo-inclusions, or there has to be presence of groove. And the next character is the chromatin characters, that is clearing. So chromatin will move to the periphery. There is also called an orphan antinuclei. So this will show clear nuclear presentation. So when all the 3 features are present, then it is considered as score 3. Wherever there is absence of any of these, that is when the score is 1 or 2, then it's called questionable. And when there is absence, then it is definitely not a PTC-like nuclear features. So let's move on to the cases. So we know that follicular cell-derived neoplasm are categorized into benign, low risk, and malignant neoplasm. Currently, we are dealing, our case, the index case is a high-grade follicular cell-derived non-anaplastic thyroid carcinoma. And there are 2 histological subtypes within it. One is poorly differentiated thyroid carcinoma, and the other is high-grade differentiated thyroid carcinoma. Now, why it is important to differentiate between these 2 subtypes? Why we are discussing so much? Because they both have different treatment. The high-grade differentiated thyroid carcinoma, it is sensitive to radioactive iodine ablation therapy. So histologically, it can this high-grade differentiated thyroid carcinoma will have papillary, follicular, or solid architecture, whereas a poorly differentiated carcinoma will have trabecular or insular-like growth pattern. There will be absence of nuclear features in poorly differentiated thyroid carcinoma, whereas high-grade differentiated thyroid carcinoma will have presence of PTC-like nuclear features. The 2 other important features are mitotic counts, which is more than or equal to 5, and the tumor necrosis, which is present in our case. Apart from these histological differences and the clinical treatment differences, there is a molecular difference as well between these 2 entities. So this high-grade follicular cell-derived non-anaplastic thyroid carcinoma, it shows a synchronous or metachronous progression of a well-differentiated form of carcinoma. For example, this high-grade differentiated thyroid carcinoma, it first have an early driver mutation of BRAF V600E, which is followed by a PTC. Thereafter, it requires TP53 or third promoter mutation. Then it goes to high-grade thyroid differentiated thyroid carcinoma. Whereas in case of poorly differentiated thyroid carcinoma, the earliest driver mutation is RAS activating mutation, which will lead to follicular carcinoma or encapsulated follicular variant of PTC. And later on, it will acquire TP53, third promoter mutation, or alterations of PI3K PTEN AKT pathway. So these molecular alterations and mutations are important. They can act as both as a diagnostic as well as predictive and prognostic biomarker as well. So these tumors are uncommon, and they are seen in less than 7% of the cases, with a mean age of diagnosis of 55 to 65 years, with a slight female predilections. They have etologically found to be in iodine deficient areas with long-standing goiter, and they have got aggressive clinical pathological features. And prognostically, they lies between differentiated thyroid carcinoma like PTC follicular carcinoma and anaplastic carcinoma. So for further discussion, I'll invite Dr. Prachi for the clinical discussion.
Thank you, sir, for that elaborate description of pathology. The patient underwent the surgery well, and the post-operative period was uneventful. She was put on thyroxine supplementation with 125 microgram with a TSH goal of less than 0.01. She was discharged on post-operative day 6, and further whole body radioiodine scan along with the need of radioactive iodine ablation or therapy is scheduled. She will be following up after 3 months of the surgery for first response assessment. I will be inviting to the stage Dr. Spandana to discuss further the clinical implications of such cases.
Thank you, Dr. Prachi. As compared to the papillary thyroid subtype of PTC, as has been described previously, the differentiated high-grade thyroid cancers are categorized by American Thyroid Association as having high risk of recurrence, with the risk being more than 30%. And hence, it is strongly recommended that all such patients receive radioactive iodine adjuvant therapy after total thyroidectomy. Even though differentiated high-grade thyroid cancer and polydifferentiated thyroid cancer have similar prognosis, that is, their 10-year disease-free survival is in the range of 55 to 60%. The main difference between the two is that DHGTC retains its radioactive iodine sensitivity, and hence radioactive iodine therapy is indicated in all patients. However, in PDTC, radioactive iodine therapy may be considered empirically.
Thank you, Dr. Spandana. So we have dealt with a nice case of differentiated high-grade thyroid carcinoma. And the next, I think we have 2 cases for thyroid lined up. We can discuss them together, the questions. So for the next case, I again invite Dr. Prachi to begin with.
Thank you, ma'am. Our third case for thyroid series is that of a 55-year-old gentleman who presented to us with chief complaints of incidentally detected thyroid nodule. And on examination, it was he was having a solitary thyroid nodule in the right lobe measuring 2 into 2 centimeter. To further characterize the thyroid lesion, we had the patient underwent ultrasonography of neck, which revealed Thyroid's 4 nodule in both the lobes. In the right lobe, it measured 31 into 14 millimeter, and in the left lobe, it measured 2.6 into 2.6 millimeter. He further underwent guided FNAC of the thyroid lesion, which will be discussed shortly by Dr. Ojas. I invite you to the stage, sir.
Thank you, Dr. Prachi. So USG guided FNAC was done from the right lobe of thyroid, and it showed cellular smears, and it showed papilloid fragments. This is the pap stain slide. And going on further higher power, there these cellular slides were showing repetitive microfollicles, and there was presence of hyperchromatic nuclei. However, there were presence of intranuclear cytoplasmic pseudoinclusions, and there were presence of nuclear grooves in some of the cells. Hence, it was reported as suspicious for papillary thyroid carcinoma category 5. Later on, we received a total thyroidectomy specimen, which weighed 25 grams, which is up high normal. And the right lobe was measuring 4 centimeters, and the left lobe was measuring 3.5 centimeters. The outer surface was smooth, and there was no capsular breach, and it was congested. The cut surface of the right lobe show a nodule, which was measuring 3.5 by 3 centimeters, which was grayish-white firm. This is the scanner power view to appreciate that nodule. So again, for comparison, this is the normal thyroid parenchyma, and this is the lesion, and both were separated by thin capsular capsule. So if we trace this capsule, we can appreciate that there is a slight breach in the capsule, and there was presence of tumor outside the or in between the capsule. So there was difficulty in telling about the capsular breach. Even we perform further serial sections also in this. There was absence of any vascular invasion. This is the higher power view to appreciate the nuclear details, and it was showing nucleomegaly. There were nuclear groups. However, there were absence of any intranuclear cytoplasmic pseudo-inclusions or nuclear clearing. So it was reported as well-differentiated tumor of uncertain malignant potential. And the left lobe and isthmus were showing flattened cuboidal cells with abundant colloid. These were macrofollicles. So the index case lies in the low risk neoplasm, that is between benign and malignant neoplasm. So this is thyroid tumor of uncertain malignant potential. So in this, we have got two subtypes: follicular tumor of uncertain malignant potential and undifferentiated tumor of uncertain malignant potential. So how to label them? So if we see the terminology for a well-differentiated encapsulated follicular pattern tumors, so there are two things which have to be taken into account. One is invasion, what is PTC-like nuclear changes. So if there is questionable invasion, it falls into well-differentiated tumor of uncertain malignant potential. And if there is presence or questionable PTC-like nuclear alteration, it will also fall into the same category. But if there is absence of PTC-like nuclear features, it will fall into follicular tumor of uncertain malignant potential. Also, high mitotic activity and tumor necrosis should be looked upon in these cases, because then it will fall into high-grade encapsulated follicular cell divide carcinoma. So just a recapitulation of all the nuclear details. So a score of 1 to 2 is taken as questionable. So the index case was of 35 millimeters. So usually these well-differentiated tumor of uncertain malignant potential are smaller. They have got nuclear features of 2 to 3. The tumor capsule is thinner and sometimes incomplete, and they have got a relatively better prognosis. In fact, these uncertain malignant potentials, they have got indolent behavior, and it is seen on large few studies that on longer follow-up, few of the cases have shown metastasis, in which a follicular tumor of uncertain malignant potential have shown a more malignant. Okay. So on molecular pathogenesis, they are usually RAS driven, and NRAS mutation is the most common mutation which is seen in this. Also, it should be looked for TP53 and third progenitor mutation. If it is detected, then it is the carcinoma should be ruled out. And if BRAF V600E mutation is present, then NIFTP is excluded. So they have got a low prevalence of 0.5 to 3%, and the mean age at diagnosis is 50 to 55 years with a female patient predominance, and they are RAS-like molecular alteration. So the take-home messages from these two cases are complete resection of thyroid tumor and adequate sample, including the capsule, is important. Before excluding a capsular or vascular invasion, careful examination of tumor architecture, nuclear features, mitosis, and necrosis should be done. And molecular testing is advised in all the difficult cases. In fact, molecular testing can be done on FNA samples also. It can act as a diagnostic, predictive, or prognostic biomarker as well. So now I invite Dr. Prachi for further clinical discussion.
The patient underwent the procedure well, that is total thyroidectomy, and she was discharged on post-operative day 3. The further clinical implications will be discussed by Dr. Divya.
Discussing about the uncertain malignant potential neoplasms, both well-differentiated and follicular tumors, they are mostly the new kid in the block, and they fall under low-risk neoplasm along with NIFTP. So the new ATA recommendation is that along with NIFTP, this kind of patient, this kind of papillary low-risk neoplasms are having low risk. And the further treatment with completion thyroidectomy and lymphadenectomy or radioactive iodine is not advised routinely for this kind of patients. The optimal approach, however, to post-operative monitoring of this tumor is uncertain, as is the new entity, and there are very few studies with a long-term follow-up. So I'm projecting one study which has come from Kuma Hospital done by Ito et al., which is the clinical outcome of follicular tumor of uncertain malignant potential of the thyroid, having real world data. It was a retrospective analysis from 2010 to 2018, having a number of patients 339 with a median follow-up of 55 months. In this cohort, they have documented that 5 patients out of 339 patients had developed recurrence in terms of distance metastasis. Most of them are bone metastasis, except one having lung metastasis. And though 5-year recurrence-free survival is having 98%, as been projected in the Kaplan-Meier curve here. So they have concluded that follicular thyroid of neoplasm with uncertain malignant potential is generally an indolent disease, but some cases, however, show distant recurrence. Physicians should carefully follow these patients, although it remains unknown how long they should be followed and observed after surgery. So anybody can
So,
give their opinion.
thank you
on
very
this.
much. So we have these two interesting cases, one high-grade DTC and tumor of uncertain malignant potential. At least for the life of I'm not able to understand how to follow up these patients. The questions and comments are invited from the floor. Please.
Thank you for that wonderful presentation. I just want to know how do we counsel such patients?
I think Shashi has to say something. Let him chip in. Maybe he'll give us some advice.
Actually, ma'am, complicate what she has asked. I was about to ask it. Suppose if it is Bethesda 5 as given and it's a small lesion, intrathyroidal, no lymph nodes, and we go ahead with the hemithyroidectomy. Do we go ahead with the completion or not is what I wanted to ask.
The question is open to floor. How many of you would go ahead with hemithyroidectomy followed by completion thyroidectomy? Would you take size criteria into account? If it is 2 centimeter tumor, how many of you would go ahead with completion thyroidectomy? Please raise your hand. Tumor of uncertain malignant potential. Any taker? If it is 4 centimeter, more than 4 centimeter? So I think majority agree if the tumor is more than 4 centimeter, they would go ahead with completion thyroidectomy. So meaning thereby primary or secondary total thyroidectomy. But how to follow up these patients? That would be an interesting question to pose. Any idea? Himagrish, you have to say something?
Thank you, ma'am. In fact, I have a question to the pathologist. So if there is evidence or if there is something suggestive of a capsular breach, we would sort of tend to be more on the more conservative side. If there's a little bit of capsular breach also, okay, I'm going to call this a little more dangerous. I'm going to be cautious and I'm going to give as much treatment as possible to the patient. So maybe it's it's a little adventurous if you give it as an uncertain malignant potential and then go towards hemithyroidectomy should the patient have any recurrence later, because at that point we don't know. It's all in hindsight. So it's my question. If it's my quandary actually.
You are right. That's what this cytology has got limitation, because you are seeing the nuclear feature, but you are limited by capsular invasion. That will be only ultimately be seen the histology with wider sampling. So now these tumors are KRAS and BRAF mutated, and follicular variant of PTC. They are now came into this follicular carcinoma like KRAS mutation type, though nuclear features are there. So the histology ultimately and wider sampling, but there are subtle features just like thick capsule are there, they are more aggressive. So if you are a doubtful capsular invasion, you are demonstrating a nuclear score is doubtful to not 3 nuclear scoring, then it will come in low risk tumor only, and follow up or treatment as more than 4 centimeter has to be taken to. Yeah.
Question is like if it is BRAF mutated, it's all right. Maybe we would expect local recurrence. So we can follow up these with ultrasound. But suppose it is KRAS mutation, I always think whether there would be blood-borne metastasis and how to follow up these cases. Would we be doing annual WBRI? That also we do not know whether they would be taking up or not. So that is, I think, only time is going to tell. But as literature so far says that recurrence rate is not very high. So yeah, Pradeep. Yeah, Christine.
As well as when you look at the pathology reports, there are a lot of uncertainties from the pathology side always. And many of this over the years, I've been here for so many years in this field, and I know that it cannot be rectified. It's going to go on, and we will discuss about it. So I always feel that a little bit of an aggressive surgery always does the trick. And if you can do it without complications, then that's also a problem. The patient is also at ease. And in the second case which you showed, that was a large tumor, retrosternal extension, Bethesda 6. I would have done a central compartment also in that patient, prophylactic. And because you were likely to get into a that was done. Okay, I didn't get it at that time. So because you are likely to get in surprises like that when it came to the final histopathology where it's high grade tumor. So if you do a radioiodine scan in that patient, you will see that if you had not done a central compartment, there will be few uptake there. Thyroglobulin would have been high. So a little bit of aggression is not wrong.
Krishi?
I just thought I'd give a slightly different perspective. I think these areas of grey, and you've beautifully demonstrated the pathology, they're really hard to deal with, which is what you've been alluding to. And perhaps I have a few more things up my sleeve to help differentiate the grey. But before I go to that, I just want one other observation. In these three cases, my observation as a surgeon is that you as pathologists are a little bit more likely to upgrade something, whereas my pathologists are trying really hard to downgrade everything. So a tall cell, they probably wouldn't call it until it was really, really obviously almost 4 times the height, and it'd have to be through at least 30% of the tumor, because we know that that has significant implications for the patient management thereafter. And again, I don't actually remember the last time I saw one of these, because it would have been handed around to every single pathologist in the department and then sent to a different site as well in order to not have a diagnosis that I don't know what to deal with. And we would have also done some immunohistochemistry. Molecular testing is also not very easily available. It's quite expensive for us, so we probably wouldn't have done that, but it is an option. So I think if you can resolve the grey and you know which way your pathologists behave, as well as which way you behave in terms of aggression and how that's going to play out in your practice, then I think they're very important things to consider.
So the message is choose your pathologist wisely.
If you can. You may not be able to choose. Either that or find a different one you like.
Yeah, Dr. Gaurav?
I'm envious that you have pathologists who like to talk to each other and then provide a definitive management plan to the clinicians. Well, I hope in coming days, we'll also have something similar. Another reminder for the presenting team, we can go on until, that's not the correct clock, until maximum of 9:35. Okay, so keep the time in mind. Thank you.
So thank you. That session has generated quite a lot of discussion and controversies. We can carry it over the tea. Thank you so much. Thank you, Dr. Ojas. Thank you, Dr. Anurag, for being there. And now we move on to our second section, which is parathyroid pathology. And now I invite upon a stage from our side, Dr. Sampriti, and from pathology side, Dr. Nandita Chaudhary, who is assistant professor pathology. Over to you, quickly.
Good morning. I'll be presenting first case of parathyroid. A 79-year-old male presented to us with a complaint of generalized weakness, forgetfulness, and proximal muscle weakness for 4 months. On biochemical evaluation, he was found to have hypercalcemia. There was no palpable swelling or lymphadenopathy for this patient. On biochemical investigation, he was diagnosed with primary hyperparathyroidism, having a 22 mm largest diameter hypoechoic lesion, posterior and inferior to left lobe of thyroid. And on MIVI scan, there was an avid tumor posterior to upper pole of left lobe of thyroid gland, likely left superior parathyroid adenoma. So we did a surgeon perform ultrasound, and then focused parathyroidectomy was done. There was a bilobe maroon colored left superior descending parathyroid adenoma of 2.5 into 1 centimeter lesion. And there was a curative fall of IOPTH post excision, which was around the normal range. I would like to invite Dr. Nandita for discussing the histopathology for this patient.
Good morning, everyone, and thank you, Dr. Sampriti, for the kind introduction. So, for the pathology cases, I will be for the parathyroid cases, I will be discussing the pathology part. So, before going into the details of the parathyroid gland, we'll have a quick revision of the parathyroid histology. So basically, we know there are two pairs of parathyroid glands which are located on the posterior surface of the thyroid. The size and the weight of the gland becomes very important because for individual gland, the acceptable size is 6 to 8 millimeter and the acceptable weight is 40 to 60 milligram. And any enlargement or deviation increase from this size and weight, obviously it becomes pathological. When we come to the histological part, we all know that the parathyroid gland is composed of a cellular component which is admixed with fat. So if we come to the cellular component, we have basically 4 types of cells. The first one, as we can see, is the most common one, the chief cells, which appear quite monotonous. They have round nucleus and they have eosinophilic cytoplasm with well-defined cell borders. Another one, which is the second most common, is the oncocytic cells, which are usually known to have abundant amount of granular eosinophilic cytoplasm. The third one is the water cells, which have abundant amount of clear, that is the whitish appearing type of cytoplasm we can see here. And if the cytoplasm falls in between any of these categories, comes in the range of transitional cells. Also, the multiple pattern of cellular arrangement is seen in the parathyroid. The commonest one is the nested arrangement. Here we can see the tumor balls are separated by thin fibrovascular septae. The second one is again a feature of neuroendocrine tumors. We see the trabecular, thick bands of cells which are interconnected to each other. The third one, the follicular pattern of arrangement, which is usually seen in thyroid, and this is this pattern of arrangement by which we usually get confusion whether it is a thyroid lesion or a parathyroid lesion at times. And the second one is the sheet-like pattern. So with this morphology, we have seen the 4 types of cells, 4 types of patterns existing in and all of these cell types and patterns can exist in a single gland. So multiple patterns and multiple cell types always in a net mass point out towards a parathyroid lesion. So proceeding with the index case, we have a 79-year male with left superior parathyroid. Here we can see this is an enlarged parathyroid gland. It has a thin capsule and this is the surrounding adipose tissue. We can see the nodular appearance of the tumor and this is the hilar area. We can appreciate the blood vessels and this is the presence of the rim of normal parathyroid at the hilum. So here we can see the tumor is of moderate cellularity. It has again multiple patterns, nested as well as the follicular pattern and higher magnification, predominantly chief cells with very monotonous appearance. There is no any necrosis, mitosis, no invasive features. This is again higher magnification of the follicular field and this follicular pattern of arrangement and this is the presence of the oncocytic cells. So summarizing this case, we have an enlarged and heavy left superior parathyroid gland and on microscopy it is showing a moderately cellular tumor which is confined within capsule containing variety of cells. The rim of normal parathyroid is present. It does not have any worrisome histological features or any invasive features which are associated with parathyroid malignancy. So in the clinical context of enlargement of a single gland with primary hyperparathyroidism, this is a case of parathyroid adenoma. So I have talked about the worrisome features and the invasive features. These are the features laid down by the latest WHO 2022, where they have specified the worrisome histological features. So these include if the gland is adherent to the adjacent structures, but there is no frank invasion, or if we have cellular nests in thick fibrous connective tissue. So these are the nests of the tumor cells, and this is the fibrous connective tissue forming thick fibrous bands and nodule formation. We can also have tumor nets penetrating within the capsule, but not outside the capsule, just like Dr. Ojas pointed out in thyroid pathology. Otherwise, it will be labeled as capsular invasion. The mitotic activity is very sparse, usually in parathyroid lesions. If it is more than 5 per 10 high power field, which is equivalent to 10 millimeters per 50 high power field, which is equivalent to 10 millimeters square area, then we have to report it. It is again an atypical feature. And the presence of atypical mitotic figures as well as coagulative necrosis should be reported. So if any of these worrisome histological features are present, obviously we are going beyond parathyroid adenoma. But then before going towards atypical parathyroid tumors, but before calling as atypical, we have to rule out any previous manipulation like previous FNSE or ethanol injection to parathyroid gland, which can result in many of these parameters. The invasive features are very well defined. We have already, Dr. Ojas has already let us know the features by which we call it as vascular invasion. Here we can see if any parathyroid gland is having the presence of vascular invasion, perineural invasion, lymphatic invasion, invasion into adjacent structures, or if there is histologically confirmed metastasis. So any of these features are present, it will directly go into the diagnosis of parathyroid carcinoma. So in this picture, this is the picture of vascular invasion, this is a skeletal muscle invasion, and this is a nerve bundle which is surrounded by the tumor cells. This is perineural invasion. So in the index case, we don't have any worrisome feature, we don't have any invasive feature. So this is a case of parathyroid adenoma. We have single gland involvement, and WHO says that even if we have, in cases where we have multiple glandular involvement, then, and the cases are having primary hyperparathyroidism, again that adenoma, it can be, rather than calling it as hyperplasia, we should call it as multiple multiglandular parathyroid adenomas, because these result from multiple monoclonal proliferations. So for further clinical discussion, I invite Dr. Sampriti.
Post-operatively, this patient had an uneventful course and was discharged on day 5 with a serum calcium of 10 milligram per deciliter. On 1 month follow-up, he was normal calcemic and the proximal muscle weakness is improved. I would like to call Dr. Spanna for clinical follow-up of this patient. Thank you, Dr. Sampriti. International consensus and guidelines recommend routine testing of serum calcium weekly for a month after surgery, and it's 6 months where we need to test for calcium, PTH, and vitamin D levels. Routine measurement of PTH is not recommended. However, in patients who have medical disease or who are on treatment and who have documented bone or renal damage, they need to be reassessed at 1 year and then at least every 2 years. In our own experience, we have seen that as compared to the world population, our cohort has do present with more symptomatic disease and have documented end-stage organ damage, end organ damage, and hence they would warrant a longer time for follow-up. Thank you.
So I think we will take question answer at the end of this session. So let us go through all the parathyroid cases first.
Moving forward to my second case on parathyroid, a 57-year-old male presented to urology department with history of recurrent bilateral renal stones for last 2 years. On biochemical evaluation, he was found to have high serum calcium and PTH values. So he was referred to endocrinology department and further to us. His general physical examination was unremarkable, and the biochemical evaluation was suggestive of primary hyperparathyroidism with a significant high level of PTH of 55 picomole per liter, and on ultrasound, but there was no evidence of any parathyroid lesion, but bilateral thyroid spore nodules were present in the thyroid. And on MEB scan, there was a avid tumor inferior and posterior to lower pole of right lobe of thyroid. So with the diagnosis of primary hyperparathyroidism with multinodular goiter having FNAC of Bethesda 3, we proceeded with the surgery where right inferior parathyroid gland was found to be enlarged, but the fat planes with the thyroid was not defined. There was a high suspicion of parathyroid carcinoma. Both the lobes of thyroid was enlarged, so en bloc resection of right inferior parathyroidectomy with total thyroidectomy was done. There were multiple enlarged black-colored lymph nodes in right central compartment, so right hemi-CC-LND was done. The gross weight of the specimen was 33.5 grams, and the parathyroid was measuring 1 into 1 centimeter. For the further discussion of histopathology, I would like to call Dr. Nandita.
Thank you again, Dr. Sampriti. For first to be performed the guided ultrasound guided FNA from the lesion in both the lobes of the thyroid. So as we can see here, we have fairly cellular smears, and we can see the cellular component present in clusters. It was present in follicles and somewhere even papilloid fronts. This is the follicular arrangement of the tumor cells. And we can see in all these images, the background is hemorrhagic. It doesn't show any colloid. So this is again one of the smears where we can see these singly scattered stripped off nuclei or naked nuclei, which we can see. And this is the higher magnification. We can appreciate the cells are quite uniform and they have abundant amount of granular cytoplasm. And few of these appear oncocytic in morphology. So with this background, we have all types of arrangement. We have plasmacytoid to oncocytic cells, a background hemorrhagic, which is devoid of colloid. And the FNA was performed from both the lobes of thyroid. So considering it as of thyroid origin, we consider the possibility of ATP of undetermined significance Bethesda diagnostic category 3. However, again, we have to look back at the clinical context. This patient was having all the features of primary hyperparathyroidism. And if we go back to the parathyroid cytology, which is rarely done, we have very less cases to see. But still in parathyroid cytological smears, it is said that we can have multiple types of arrangement. We can have those oncocytic appearing cells and especially those naked nuclei, which were seen in some of the smears that pointed that this may even be a parathyroid lesion. And this case was reported as category 3 ATP of undetermined significance with a rider that possibility of parathyroid lesion may also be considered in the clinical and radiological context. So then thereafter we received the total thyroidectomy specimen with attached right inferior parathyroid gland and the CCLND. Then the right lobe in maximum dimension, it measured 6 centimeter, left lobe 5.5 centimeter, and in the right lobe at inferior pole, we had a parathyroid gland, right inferior parathyroid 1 into 1 centimeter. So we had taken sections from all of these, the parathyroid gland as well as both the lobes of the thyroid. And the histology was similar everywhere. So as highlighted in the previous case, in this case also, we can see a very cellular tumor. This is the tumor capsule. This is the inked margin. And here we can see this one is the capsule. Now for parathyroid, it becomes a problem to comment on capsular invasion if there is the presence of fibrous bands. We'll discuss it later. So this is the another area where we can see at some places there was a thin capsule. This is the surrounding adipose tissue. This is some amount of intraglandular adipose tissue. This is the tumor capsule. Here also we have the tumor capsule and we can see that it was mushrooming through the capsule. The interface between the thyroid parenchyma and the tumor was very blurred. We can see it was closely juxtaposed with the thyroid parenchyma with loss of any capsule at some places. However, clear infiltration could not be demonstrated even on multiple sectioning. So this is the higher magnification of the same. And in some places we can see, especially from sections taken from right and left lobe of thyroid, the tumor was forming the outer surface as well. So these are the another sections from other areas. This is the thyroid parenchyma. This is the tumor, and we can appreciate that the tumor has crossed the capsule. This is focus of capsular invasion. And these are the foci of vascular invasion. We can see here at least 3 focus of vascular invasion. And this vascular invasion is highlighted on the Orsine stain. This is a blood vessel. The brownish color is the internal elastic lamina, and we can see this tumor thrombus is attached to the vascular lumen. So we have clearly demonstrated 2 to 3 foci of vascular invasion in this case. When we look inside the tumor, we see again it is an admixture of cells. The pinkish one is the oncocytic cells, the bluish one are the clear cells, and this is the follicular pattern of arrangement. As I highlighted before, this arrangement is the one by which we can get confused whether it is thyroid or parathyroid. This is the trabecular pattern of arrangement, and these are the thick fibrous bands which are running inside the tumor and forming multiple nodules. So these are the another areas. We have lot of connective tissue in between with formation of nodules, and this is highlighted on the Mason trichome stain. So the greenish appearance of these fibrous bands is highlighted on this stain. So we had all the patterns of arrangement, as I told you. Then we have predominantly chief cells. Some areas composed of oncocytic cells and some areas composed of clear cells. So it was a clear admixture of all the cell types pointing towards parathyroid pathology. In addition, we had large areas of hemorrhage within the tumor. These are the sections from the adjacent thyroid. We can see the normal colloid-filled follicles. And these are the sections from central compartment lymph nodes. Total 13 lymph nodes were dissected, and all of them were reactive. There was no evidence of any invasion. So again, going back to the criteria, in the index case, we have capsular invasion. We have thick connective tissue forming cellular nests, band-like fibrosis. we have adherence to the thyroid without any frank invasion. But then when we look at the definite features of malignancy, we have one feature, that is the angioinvasion. So with this morphology and with this histology, we proceeded with the diagnosis of parathyroid carcinoma. But then because it was completely intrathyroidal in location in both the lobes of thyroid, we had to prove it the parathyroid origin by IHC as well. So GATA3 is an immunohistochemical marker which is positive in parathyroid, but it is negative in thyroid. Our case showed very nice nuclear positivity for GATA3, confirming parathyroid origin. Then we have markers like thyroglobulin and TTF1, that is the thyroid transcription factor 1, which are positive in thyroid but negative in parathyroid. So our case was negative for both thyroglobulin and TTF1. To rule out the remote possibility of even medullary thyroid, we did calcitonin, which was also negative. Our index case did not have any increased too much mitotic activity, so it was only 1 to 2 per 10 millimeter square area, and the Ki67 was also only 2 to 4%. So summarizing this case, we have an enlarged right inferior parathyroid with presence of similar nodules in both the lobes of thyroid, and the microscopy is same from everywhere. And we have a cellular tumor with all types of patterns and all types of cell types. Among the worrisome histological features, we have thick fibrous bands, we have capsular invasion, we have adherence to adjacent thyroid parenchyma, but we have documented one definite feature of malignancy, that is angioinvasion. Because of this, it falls histologically into the diagnosis of parathyroid carcinoma. We have also confirmed the origin of parathyroid origin by GATA3 immunoreactivity, and we have excluded thyroid origin by thyroglobulin and TTF1 negativity. So this case did not have any necrosis or any perineural invasion. A diagnosis of parathyroid carcinoma was offered. So we have, usually it is the standard of care to perform parafibromine IHC, especially when we have diagnosis of uniglandular parathyroid lesions, because in parathyroid carcinoma, usually we see loss of parafibromine. Parafibromine is usually nuclear positive in cases of parathyroid adenoma, while it is lost in parathyroid carcinoma, and it indicates biallelic inactivation of CDC73 gene, which is related to HPT-JT syndrome. So we have, and it is also associated with high risk of recurrence. So that IHC is indicated. Other markers which can be positive apart from parafibromine are PGP 9.5 and galectin-3 in parathyroid carcinomas. So I again invite Dr. Sundari for further.
Okay. Thank you so much. So we would stop right here because Dr. Gaurav is issuing a warning, and we will discuss these two cases, parathyroid adenoma and carcinoma. Any clinical or pathological question is invited from the floor. Any comments? And thereafter, we would be moving to adrenal session. Any questions or comments regarding pathology?
For the atypical adenoma, how they are differentiated. So we'll, I think, Dr. Anita, you can highlight jo hai,
Question?
atypical parathyroid adenoma.
So I had demonstrated some of the features which are laid by WHO 2022. There are some worrisome features, at least 7 to 8 features. So in the clinical context, it is said if you don't have any history of previous manipulation, like the previous FNAC being done in the from the parathyroid gland, still if you get the presence of thick fibrous bands with nodule formation, with lot of connective tissue, or if we have tumor cells infiltrating within the capsule but not beyond it, but then we can have coagulative necrosis, we can have mitosis exceeding more than 50, or presence of atypical mitosis. So presence of, see, if only one feature is present and it is not a close mimic of carcinoma, obviously it can be accepted in adenoma. But WHO says if few or more of these features are present, and the most important part is that if the tumor is clinically mimicking carcinoma, but we are not able to demonstrate unequivocal features of invasion. So that is the criteria when we call it as atypical parathyroid tumor.
So thank you, Dr. Sampriti and Dr. Nandita, for this wonderful case discussion. And now
Ma'am,
we
if I
would
may-
like to.
Ma'am, one.
Yeah, one question.
Yeah,
Yeah,
sorry.
please.
This is for both. Clinically, there are two scenarios I wanted to discuss. For atypical adenoma, it is considered as in situ. It comes under TIS. So two scenarios. If you are in a cost restraining situation, so we follow up or go ahead. Second, If the cost factor is not taken into consideration, we do a parafibromine negative and CDC 73 is positive. Risk of recurrence is high. Do we go ahead and do a central compartment dissection with ipsilateral hemithyrectomy or not?
So that is quite an interesting question. So like this thing currently, sometimes we not only atypical adenoma, but we do get incidental report of parathyroid carcinoma. And the consensus is still evolving, but this thing latest we discuss article from NIH long-term surveillance, and they said it is okay to go ahead with surveillance if the dissection margins are all free. We not necessarily go in and perform central compartment dissection. So I think that should also apply to the atypical adenoma if you are doing the same for. Paul, you have any question or comment on that? Or you are okay with following these patients if there is incidental diagnosis of atypical adenoma or carcinoma?
Yeah, actually, we recently looked at our experience, and in the history, one case which was diagnosed atypical turned out to be a parathyroid. So again, I think the pathologists have to do a fine balancing act, and it's not easy. So we always, as we say, err on the side of being more careful with parathyroid malignancy.
The question is, suppose that you have not performed central compartment dissection and later on it comes at atypical adenoma or carcinoma, what would you do? Would you?
If it's atypical, always follow up. Yeah.
And carcinoma?
Carcinoma, we would probably go back.
You will back immediately and perform central
If we
compartment?
think we have not got gross clearance. Central compartment dissection, I think, should be assessed at the time of surgery. So if you are clear that you have done the surgery and you have not found any significant disease in the corresponding central compartment, then I would not go back.
So Pradeep, maybe. Thank you so much. We are running short of time and Gaurav is literally this thing sending some warning signals over there. Thank you so much. So we move on to third session, and that is our adrenal pathology. So I'll request Rajni to quickly finish the clinical part so that pathologists get enough time for discussion.
Good morning, everybody. For our first case, we have a 8-year male child who presented with recurrent abdominal pain and constipation lasting for 3 months. He also had weight gain and increased appetite with failure to gain height since last 3 years. On examination, his weight was 40 kgs and height was 125 centimeters, which falls between 10 to 25th centile. His systemic examination was within normal limit. This patient was evaluated by pediatric endocrinologist, and revealing the investigation, we found out that the morning and the midnight cortisol were elevated, showing there was loss of diurnal rhythm. Further LDDST was done, in which also the cortisol secretion was unsuppressed, revealing that there was an endogenous source of cortisol secretion. ACTH was suppressed, showing that it was ACTH independent. To further characterize the lesion, as CCT was arranged, which is showing a well-defined lesion arising from the right adrenal gland. Moving ahead with diagnosis of ACTH independent cortisol secreting right adrenal mass with Cushing's syndrome. We planned for an posterior retroperitoneoscopic adrenalectomy, which revealed an oval-shaped tumor arising from medial limb of right adrenal gland, weighing 16 grams and measuring 3.5 into 3.5 into 3 centimeters. On cut section, it was well encapsulated, soft, pale, with homogeneously fleshy parenchyma, and there were no areas of hemorrhage or calcification. This was further sent for histopathological examination. I request Dr. Divya to take us through the histopathological findings.
Dr. Divya Singh is our assistant professor from pathology and recently joined colleagues.
A very good morning to all. So before I discuss the histopathology of the case, I'll just quickly go through the normal histology of the adrenal gland. So adrenal gland, it comprises of two distinct tissues. The outer is the adrenal cortex and the inner central part is the adrenal medulla. The adrenal medulla contains cells that secrete catecholamines, and these are mostly round cells having a blue amphiphilic to basophilic cytoplasm. Adrenal cortex is again divided into 3 zones. The outermost is the thin disc or the discontinuous layer called zona glomerulosa. The middle part is middle zone is the which comprises most of the adrenal cortex is zona fasciculata, and the innermost part is zona reticularis. Again, the cells in the zone, these compartments, they differ significantly in the terms of their size and the amount of cytoplasm they have. So coming to our case, for this case, we received a right adrenalectomy specimen weighing 16.7 grams and measuring 3.4 by 3 by 2 centimeters. It was a circumscribed specimen with a smooth outer surface. So this is a photomicrograph of an etching stain section of the lesion at scanner power. Here we can see that this is the tumor which is disposed in variable size nests, and this is the well circumscribed lesion, and here we can see the normal compressed adrenal parenchyma. At further high power, we can see that these nests are intervened by a fibrovascular, thin arborizing vasculature. And at this power also, we can see that these are comprising of two types of cells. One, the ones having clear cytoplasm, and the other which is having giving the cytoplasm an eosinophilic appearance. Then further high power, we can clearly see the demarcation between the two types of cells. The maximum portion is comprising of these cells having abundant vacuolated and to clear cytoplasm. And the other type of cell is the ones which are oval to polygonal, having eosinophilic granular cytoplasm and a centrally placed nucleus. The nucleus in both of these types of cells is uniform and centrally placed. This is another high power view. Again, we can clearly see the different types of cells and the thin arborizing vasculature which is running in between these nests. So for this lesion, we applied a reticulin stain, and this reticulin stain is again highlighting the reticular network which is running alongside the this vasculature, and we can see that there is no disruption of the reticular network in terms of any loss of these fibers or any fraying. So, depending on the histological features and also the negative features such as no necrosis, no atypical mitosis, or no capsular vascular invasion, a diagnosis of adrenocortical adenoma was given. So there are several scoring systems which are available to assess the malignant risk of these lesions, such as Huff, Weiss, Modified Weiss, Weinicke, Lynn-Weiss, Baslia, Reticulin algorithm, and Helsinki score. Of these, the most common ones that are used for assessing the adult population is the modification of Weiss score, along with the Reticulin algorithm, and for pediatric age group tumors, we use Weinicke criteria. So coming to modified Weiss, it comprises of 5 histological parameters, such as mitotic rate, when it is more than 5 per 50 high power field, then the type of cells, if the clear cells that I showed, if they are comprising more than 25% of the tumor, or if they are comprising less than 25% of the tumor, then again it is given scored as positive. Then presence of atypical mitosis, necrosis, and capsular invasion. So these two scores, these two criteria, mitotic rate and presence of less than 25% of clear cells, these are each given a score of 2 when that is present, and the rest 3 criteria is scored 1 when they are present. And a cumulative score is then calculated, and a score of 3 or more is suggests a high malignant potential, and then it is given as carcinoma. For pediatric age group, as in our case, the Weinicke criteria is used, and this comprises of morphological findings as well, such as weight, which is whenever it is more than 400 grams, it is scored as 1, and size when it is more than 10.5 centimeters. For pediatric age group, mitosis is increased to more than 50 per 20 high power fields. Then presence of any extraadrenal extension, vena cava invasion, necrosis, capsular or vascular invasion, severe nuclear atypia, or atypical mitosis. All these are scored 1 when present, and a cumulative score is calculated, and if it is more than 3, it is suggestive of carcinoma. So if we look at our case, the weight of the tumor was 16.7 grams, and the size was 3.4 grams. So both of these criteria were scored 0. Mitosis were only occasionally present. There was no extraadrenal extension or vena cava invasion or necrosis or atypical mitosis or vascular capsular invasion was present. Hence, it was it was given a score of 0. So it was a benign adrenocortical adenoma. These adrenocortical adenomas are the most common benign neoplasms of the adrenal gland. and they may or may not be functional. The role of pathological examination is in confirming the benign nature of the lesion, and for which we can use Weiss criteria in adults and Weiner's criteria in the pediatric age group, and complete excision is curative. So for further discussion, I would like to invite my
The post-operative recovery of this patient was uneventful. In the 3-month and 6-month follow-up, the patient was done as an actin test and there was adequate cortisol secretion. So he was off steroid supplementation also. At present, the patient has improved weight and height. Before further, I would like to invite Dr. Divya for. This. The second case is of a 19-year male who presented with weight gain, protrusion of abdomen, facial plethora, purple stripe, proximal muscle weakness, and mood swings lasting for 2 months. He had consulted outside where a battery of investigations were advised and a CCT abdomen was done, which suggested a 14 cross 13 centimeter mass, and they thought it was a retroperitoneal mass. Unsatisfied, the patient also consulted GSVM Kanpur, where with the clinical background of Cushing syndrome and the lesion they suspected to be as an adrenal lesion, they referred here for further management. On examination, the height of the patient was 153 centimeters and the BMI was 24.3 kg per meter square. He had all the stigmata of Cushing syndrome. The systemic examination was within normal limit. Further evaluating, we went ahead with a hormonal evaluation in which the serum morning cortisol was startlingly elevated. On dexamethasone suppression, also the cortisol secretion was high, unsuppressed. ACTH was suppressed, revealing that it was not ACTH dependent, and DHEA was also elevated, suggesting that it was a plurihormonal secreting lesion. To characterize the lesion, we went ahead with CCT abdomen, which revealed a 12 cross 10 centimeter mass arising from left adrenal gland. It was well defined, lobulated, and it had maintained fat planes with kidney and pancreas. With the background of this large lesion with plurihormonal secretion, a suspicion of adrenocortical carcinoma was made, and the patient was also advised a FDG PET scan. But because of financial constraints, he could not get a PET scan done. We went ahead with left adrenalectomy, where we could find a firm to hard lesion arising from left adrenal gland, which was abutting pancreas and left renal vein, and it was encased by left mesocolon. The entire specimen weighed approximately 1 kg, and the dimension was 15 cross 13 centimeter. This was sent for histopathological examination, and I would invite Dr. Divya to.
For this case, we received a left adrenalectomy specimen weighing 1046 grams and measuring 16 by 12 by 8 centimeters. Cut surface showed a yellow lobulated growth, which was replacing the entire of the gland, with only a thin rim of approximately 1 centimeter of the adrenal parenchyma was present. And this is the low scanner power of the lesion, which shows that this is the tumor which is present in diffuse sheets, which is also surrounded by these areas of necrosis. Further hyper, we can clearly see that there is a clear demarcation between this necrotic area and these are these tumor cells which are present in sheets. And at this power also, we can see that these are the clear cells which are quite less as compared to the previous tumor that we have seen. So here we cannot see any pattern of the cells are present in diffuse sheets, and individual cells, they are displaying at least moderate grade of nuclear anisonucleosis. And again, this is another area which is a cellular area from the same tumor, and the individual cells can be appreciated. And along with the moderate anisonucleosis and irregular chromatin, we can see that there is this presence of atypical mitotic figures, which was seen frequently in this lesion. We also went ahead and applied the reticulin stain, and here we can see, as compared to the previous tumor, that the reticulin framework is quite disrupted in almost all of the tumor area, and there is this irregularity in the reticulin framework, which again is pointing towards the malignant diagnosis. So this reticulin algorithm is a quite simple algorithm. It is based on applying the simple reticulin stain, where we see whether the reticulin framework is disrupted or not. And when it is disrupted, it is combined with another histological features, which is either presence of necrosis or mitosis or vascular invasion. And if any of these three features is present along with the disrupted reticular network, then it favors the diagnosis of a carcinoma. And this reticular algorithm also has a 100% concurrence rate with the WISE scoring system. So we further went ahead and applied a KI67, which showed a 15 to 20% positivity. So the KI67 labeling index was 15 to 20% in this tumor. So to summarize the histopathological findings, and low power, we see sheath, nest, and trabecle of tumor cells. And high power, we can see that there is moderate nuclear pleomorphism. Prominent nucleoli was not seen infrequently in some of the cells. However, they were present of this atypical mitosis. The mitotic count on a light microscopy was more than 15 per high power field. There were abundant areas of necrosis, and the clear cells were clearly very sparse, but that is less than 25%. So a diagnosis of conventional adrenocortical carcinoma was rendered. And if we come to WISE criteria, and for our case, we are having more than 5 or 50 hypermitosis. So for this criteria, we are giving the score 2. Then clear cells were comprising less than 25%. So again, this was scored at 2. And atypical mitotic figures were seen, scored at 1. Necrosis is again present. So the cumulative score was 6, which is more than 3. Hence, it again correlate with the diagnosis of adrenocortical carcinoma. So the adrenocortical carcinomas, these are rare aggressive tumors of the adrenal cortex. Most of them are functional, and the diagnosis relies on various histopathological criteria such as WISE and reticular algorithm, Helsinki score, and Weinecke criteria in pediatric population. And to most important features to look for whenever we are using a reticular algorithm is mitosis, necrosis, and vascular invasion. Now, other than the conventional adrenocortical carcinoma, certain other variants have been described in literature, which are myxoid variant, oncocytic variant, and sarcoidoid variant. So, myxoid variant will be diagnosed whenever there are extracellular myxoid material is present in tumor cells surrounding the tumor cells. Oncocytic variant will be given whenever the oncocytic cells are comprising more than 90% of the tumor tissue. And the sarcomatoid variant will be given whenever it will look it resembles any of the carcinosarcomas described elsewhere. So these must be differentiated from tumors that metastasize to adrenals. Why? Because the primary adrenal carcinomas are quite rare. However, the metastatic are quite common. The most difficult and most frequently encountered tumor to distinguish from adrenocortical carcinomas are the clear cell renal carcinomas. And for that, we need to take the help of immunohistochemical panel. The IC panel.
So I think, Dr. Divya, we need to stop here. And we really thank our pathology colleague. So only one quick question, if there is any. Okay, so
No question, but just a comment. Linvis Basalia is used only for oncocytic and not others. That's what I wanted to add. For the for student, because they have written all the right.
okay, thank you so much. And I thank my co-moderator, Professor Manoj Jain and Dr. Pallavi, and Dr. Anurag, Dr. Ojas, Dr. Nandita, and Dr. Divya from the Department of Pathology, and rest of us. Thank you so much.
Thank you for the excellent start. We now move on to next session on focusing on thyroid surgery, precision and practice. I would like to invite the chairpersons, Dr. Dilip sir and Dr. Pradeep PV sir, to take the podium.
So good morning. Now we go on to the next session, thyroid surgery, precision and practice. So our first speaker is Dr. Dalapati Sudhacharan. I invite Dr. Dalapati. Dr. Dalapati is well known to all of us here. He is the head of the Department of Endocrine Surgery at Madras Medical College. So Dalapati, welcome.
Presentation for sir. Please upload the presentation.
Morning to my teachers and friends. So the next 12 to 15 minutes we'll be discussing about the safe thyroid surgery, because this topic usually not for endocrine surgeons, basically for a general surgeon, so that will be of use of much use. So when we talk about thyroidectomy, previously the thyroid surgery was with the overall mortality of more than around 50%. So it was even banned during the early attempts. So even Samuel Gross actually had to quote like this, that no sensible man would try to do a thyroid surgery in those times. So then came Theodor Billroth, who was the birth of modern thyroid surgery started from Switzerland, where though still he had a fair amount of recurrent nerve palsy and then tracheostomy and mortality. It was Theodor Cocker who revolutionized thyroid surgery with the intricate and fine dissection with the preservation of nerves, parathyroids, and limited bleeding and thyroxine replacement. So the safe thyroid surgery started more than 100 years back. So still the techniques and the principles hold true, which was started by Theodor Cocker. So we know the indications for thyroidectomy, and we need a robust preoperative preparation, establishing the disease status and the euthyroid status, as well as imaging by ultrasound, as well as biopsy, which is mandatory for all cases. And radiography, like accident CT, is depends on the patient, individualization. And cervical spine disease is very important, so that we must not overextend the neck. Currently, we are doing some study on this, the angle of placement of the neck. So which is safe limit and how much of extension we can keep. So that is very important to have a history of cervical spine disease, which is usually overlooked. And we need to exclude pheochromocytoma in case of suspected MTC. And as we know, we do a FNAC for all cases before proceeding for surgery. And as I told, patient positioning is very, very important. Hyperextension causes serious neck pain and need to be addressed. And regarding the critical steps of thyroid dissection, everybody knows the transverse skin crease incision we would like to have, and subplatysmal flaps and ligation of the middle thyroid vein, and identification of the EBSLN, and skeletalization of the superior port vessels, and identification of recurrent nerve, and removal of all visible thyroid tissue, including the embryological remnants. So identification and preserving the parathyroids with intact vascularity, and checking the color of the parathyroids post-surgery. That's of paramount importance. And we need to have a bone dry field after the surgery. So coming on to the recurrent laryngeal nerve, the routine identification of recurrent laryngeal nerve is the gold standard thing. And we know that palsy can cause hoarseness and cause medical legal issues also. So the right side, we know it winds around the subclavian, and the left side it winds around the aorta. So the course is not symmetrical on both sides, with the left side little more straight and right side little more oblique. So the main part of the nerve which is at risk is the distal 2 centimeter of the nerve, which is intimately related to the Berry's ligament. That is the most common site of nerve injury because of the using of cautery or taking a bite or some bleeding will be there. So try to catch that. So that need to be taken care of. And vocal cord dysfunction, best centers or high volume centers must be less than 1% or less than 0.5%. That's what. So we need to identify the relationship between the rectolaryngeal nerve and the inferior thyroid artery, which is variable on both sides also. So usually the main concern for us would be a neuropraxia rather than majority of us will be able to identify the nerve and preserve the nerve. But the thing is, though we preserve the nerve and post-operatively to our surprise, there might be some sort of temporary vocal cord palsy will be there. This is mainly due to the traction or the traction injury, which can cause the rectolaryngeal transient rectolaryngeal nerve palsy, and we are not sure which patient would develop these and which patient might not develop in spite of a meticulous dissection. This has happened to many of, I think everybody would have had at least one case like this, though we have operated so many cases. So need to be very sure or not even touch the nerve or have a traction on the nerve. That is very, very important in this. And sometimes due to compression of a ligature, clip or surgical instruments also can cause the injury. And another thing is use of energy sources, which we take it for granted using these energy sources near the nerve. So we need to be very careful while using these energy sources, even if bipolar or a harmonic or a ligature, though they claim 7 millimeter, definitely the thermal spread will be more than that. So regarding the non-recurrent nerve, which we try to see on the right side, it will be around 0.5%. And usually when there is a thin rectolaryngeal nerve, then we would like to see for a non-recurrent nerve, or if you are not able to find the rectolaryngeal nerve in its normal course on the right side, then we need to suspect a non-recurrent nerve. So when you have a thin non-rectolaryngeal nerve, so we must not think that might the only nerve, and that might also have a non-recurrent nerve on the right side. So had a share of these experience on these non-recurrent nerves also. So there might be branching between the non-recurrent nerve as well as the EBSLN also, and the rectolaryngeal nerve as well as the EBSLN also. So how to prevent these nerve injuries? We need to have a thorough anatomy and embryology of these things, avoiding thermal sources near the nerve, and need to have the RLN in constant view during the entire dissection, and avoid traction. Again, and emphasis because the traction because everybody will be preserving and identifying the nerve. The thing is we overlook is the traction injury to the nerve. So we need to be very aware of those things. Careful dissection near the laryngeal entry point, because there's a small spurt of arterial twig will be there in the Berry's ligament, which can cause bleeding and can have a messy field in it. So to improve the RLN, we use RLN preservation and we use intraop nerve monitoring devices, which many centers have, but we don't have actually. And in private setup we have, in MMC we don't have. We still rely on our surgical technique rather than IONM. So next will be the EBSLN, which will be identified only in around 2/3 or 3/4 of the cases, because around 20 to 30% will be so high that we will not be able to see the EBSLN. Majority of the time we try to see, but we will not be able to see that. In that case, we think that it is in the type 1, which is so high. So it supplies the cricothyroid muscle. So we need to preserve this. To prevent that, we skeletonize the superior thyroid vessels and tie it individually so that the EBSLN is not included in the ligature. So because that will cause voice fatigue as well as loss of high frequency sounds. And visual identification and of late IONM is being used for this EBSLN identification and preservation also. So as we know, the Cerniak classification 3 grades are there based on the relation between the EBSLN as well as the superior thyroid pedicle. So to have a good visualization of the EBSLN, and if we can transect the sternothyroid muscle, that can increase the exposure of the superior thyroid pole also. That is one technique to have a better visualization of the EBSLN. So, as I told, removing all the macroscopic thyroid tissue is the total thyroidectomy. So we need to be aware of the embryological remnants like the pyramidal lobe and the tubercle of Zucker candle and thyrothermic thyroid rest, which we need to take care of, because mostly this pyramidal lobe and the tubercle of Zucker candle, it will be attached to the thyroid gland and we don't miss. But the one which we miss is the thyrothermic thyroid rest, which might be confusing with the lymph node or a parathyroid or a small grade 1, especially less than 1 centimeter thyrothermic thyroid rest, because that might cause recurrence or regrowth in the follow-up of these, especially when we are dealing with the thyroid cancer patients. So we need to be aware of this. The grading of this thyrothermic thyroid rest, and grade 5 is where it's exclusively within the mediastinum. So this is need to be taken care of, especially as I told, the type 1 to 3 less than 1 centimeter, because majority of the retrosternal goiters are this grade 4 and grade 5 thyrothermic thyroid rest rather than a pure extension of the thyroid lobe. So when it is a thyrothermic thyroid rest, if we don't have a leverage to remove the pure retrosternal goiter, because it will be separate from the thyroid gland. So we need to be aware of those things during surgery. Regarding the tubercle of Zucker candle, which will be close to the recurrent-laryngeal nerve, and it is a pointer towards the recurrent-laryngeal nerve. So identifying the tubercle would help in identifying the nerve in an indirect way. So we need to identify all the 4 parathyroid glands with the meticulous dissection, and rather not only the identification, we need to preserve the vascularity of these parathyroid glands. We need to check the vascularity of these parathyroid glands at the end of the procedure. We need to see any inadvertent parathyroidectomy also. And these are the characteristics to differentiate the parathyroid glands from the thyroid or a fat or lymph node or a thymus. These characteristics are there. So we know the relation between the nerve and the parathyroids. And always we like to have a capsular dissection so that we preserve the parathyroid glands with its intact vascularity. And so the temporary hypoparathyroidism is a sequelae of total thyroidectomy. We can have up to 50% of this time. But the thing is, we must not have a permanent hypoparathyroidism. That must be our motto in our thyroid surgery. So we use a lot of adjuncts to identify parathyroids like infrared autofluorescence and ICG angiography, all these things. So there are various techniques, and it has been used in many of these centers to identify. But basically, we need to identify the parathyroid. That is more important. And these are all adjuncts that help in our technique to preserve these parathyroids. So retrosternal goiters, majority of them would be removed by cervical root, and very rarely sternotomy might be indicated. In those things, before delivering the retrosternal goiter, we need to identify the recurrent-laryngeal nerve. That is because sometimes 5 to 10% the nerve can lie anterior to the retrosternal part also. So that has to be taken into account while delivering the retrosternal goiter. The various minimally invasive approaches with the robotic thyroidectomy, there are various studies comparing the safety with the conventional thyroidectomy as well as a robotic. As far as the quality of life and morbidity of these patients, the robotic as well as the conventional are more or less same. But the current data suggests the robotic thyroidectomy is inferior to conventional in case of longer operative time, but that might come down over a period of time once the learning curve is there. And the expense also is a matter of concern for a robotic thyroidectomy. And especially when we are dealing with papillary thyroid carcinoma with the central compartment lymph nodes, to have a good oncological clearance in the central compartment node, that also depends on individual skill also. But as of now, these things are a matter of concern with the case of this robotic thyroidectomy compared to conventional thyroidectomies. As far as using this sutureless thyroidectomy or using a suture, there's not much of difference in the post-operative complications. it is left to the individual surgeon to decide. But one thing is there will be lesser operative time if you are using all these adjuncts compared to a conventional procedure. So wound closure and drain placement also depends on the individual surgeon. But post surgery, we need to do a Valsalva maneuver and see there is no any active bleed, so that before we close the thing. And using of surgical surgical and hemostatic agents also might help in reducing the post-operative time, but it's not of 100% sure of those things. So post-operative monitoring, like hypocalcemia and hematoma, all these things need to be done in the early post-operative period. The early ablation and the early, nowadays, the day care procedure is being done for thyroidectomy in few centers also. And the neck exercises and massage, neck massage is also advised you in the early post-operative period of these patients. So to conclude, we need to be precise with meticulous dissection, understand their relevant anatomy and pathophysiology, and avoid injury to surrounding structures to have a safe thyroid surgery. Thank you very much.
Thank you, Dr. Dalapati. Safe thyroid surgery is definitely becoming more relevant now, especially those who are well versed with conventional thyroidectomy. They are now trying to do open the robotic as well as the endoscopic thyroidectomy. So there is definitely a learning curve, and therefore there is this concept of safe thyroid surgery is very, very, very relevant. Any questions or comments?
Thank you, Dalapati sir. We'll move on to the next talk. The next talk is by Dr. Suhani, avoiding complications in thyroidectomy. I welcome Dr. Suhani. Oh, it's a video lecture. Okay. So, can you kindly upload the video, please?
Good morning. At the outset, I would like to thank Professor Gaurav Agarwal and Dr. Sabaratnam for giving me an opportunity to present online my talk on avoiding complications during thyroidectomy. And I also apologize to the entire SGPGI team for not being able to make it in person. So in this talk, we will mainly focus on the major complications of thyroidectomy. Coming first to the nerve injuries during thyroidectomy. So this is nothing new. The nerves have been described in Shushruta Samhita, and it has also been described that any injury to any of them produces dumbness and change of voice and taste. So firstly, to the external branch of the superior laryngeal nerve, which may be injured in up to 58% of thyroidectomies. Now, the prime reason why they get injured are because of the poor anatomical knowledge among the operating surgeons and the lack of identification thereof that comes along with it. And that is also the reason that this is also called as the neglected nerve in thyroid surgery. So the first step of avoiding an injury is understanding the anatomy. And in this hernia classification, you can see that there are three types that have been described. So this is the upper pole of the thyroid gland. This is the superior thyroid artery giving branches here. And this is the external branch of the superior laryngeal nerve. So in type 1, the superior laryngeal nerve crosses the superior thyroid artery more than 1 centimeter away from the upper pole of the thyroid gland. In type 2A, the external branch of the superior laryngeal nerve, it crosses the thyroid artery, the superior thyroid artery, within 1 centimeter from the upper pole of the thyroid gland, but definitely above the branching of the superior thyroid artery. In type 2B, we can see that the nerve crosses below the upper pole of the thyroid gland. Now, another similar classification in which type 1, 2, and 3 are same as the classification we just discussed. However, in type 4, we can see that the nerve is crossing the superior thyroid artery after the branching, between the branching at the level or below the upper pole of the thyroid gland. So identification of the external branch of the superior laryngeal nerve definitely helps in decreasing the postoperative complications of this nerve injury. And in this study by Sarnia et al., we can see that it was 0% for seniors who did a routine nerve identification, 12% of seniors without nerve identification, and 28% for residents without nerve identification. So this highlights the importance of nerve identification and also highlights that with experience and nerve identification, the rate of injury decreases. Now, there are certain operating room takeaways that have been described. So the Lindquist stepwise approach is commonly followed. And here the first step is to release the superior pole of the thyroid gland from the overlying strap muscles by retracting them supralaterally. Then you open this space between the upper pole of the thyroid gland and the cricothyroid muscle by giving a lateral traction on the lateral and a caudal traction on the upper pole of the thyroid gland. And here you will also have the superior thyroid vessels. The third step is identification of the superior thyroid pedicle. And it is in this space that we identify the external branch of the superior laryngeal nerve. Now, then you also map the risk with the Sarnia classification, and you anticipate high risk courses, that is the nerve which cross the superior thyroid pedicle more towards the upper pole of the thyroid gland. And this also helps you to adjust the ligation strategy for the branches of the superior thyroid artery. And the use of intraoperative nerve monitoring definitely helps in reducing the risk of nerve injury. So this is a mini algorithm that has been described for the EVSLN monitoring. The first is obviously the setting up of the setup. Second is the exposure of the superior pole of the thyroid gland that we just discussed. Third is before the ligation of the superior thyroid pedicle branches, simulation of 1 to 2 milliampere current is given in the tissue over the superior thyroid vessels, and that helps in identification of the nerve. Once you identify, you are sure that the nerve is not there, then you ligate the superior polar vessels, and then you again do a functional confirmation. So intraoperative nerve monitoring, there is enough evidence to suggest that it improves the outcomes by decreasing the risk of nerve injury. However, intraoperative nerve monitor definitely requires a different setup and increases the cost. Now, the second common nerve that is encountered during thyroid surgery and has grave complications if injured is the recurrent laryngeal nerve. So temporary RLN palsy can occur in up to 13% of the patients, and permanent palsy occurs in up to 5% of the patients. Identification significantly reduces the incidence. Again, the first step of avoiding a complication is understanding the anatomy. So the recurrent laryngeal nerve is a branch of the vagus nerve, and it is known as recurrent because it comes down and then goes up. So as it goes up, it runs towards the larynx in the tracheoesophageal groove. And at this point, it is very closely related to the trachea, the lower pole of the thyroid, the inferior thyroid artery, the carotid artery, and the parathyroid gland. At the level of the Berry's ligament, it enters into the larynx. Now, in 1% of the cases on the right side, you can have a non-recurrent nerve where the nerve branches from the vagus, and instead of going down and ascending up, it directly enters into the larynx at the level of the cricoid cartilage. And there is no looping, hence it is known as a non-recurrent nerve. This happens only on the right side because of the retropharyngeal right subclavian artery originating directly from the aortic arch. Now, one has to be proactive in preoperative assessment. We should be clear in the indication of surgery that what is the indication of surgery, whether it is malignancy, benign, or thyroiditis, what is the size of the gland that we are going to remove, and what is the preoperative imaging that has been done. The commonly done imaging is ultrasound, and even on ultrasound, the presence of a vascular structure in the parapharyngeal and the retroesophageal space helps in giving a cue that it may be associated with a non-recurrent laryngeal nerve. In case a CT is done, then that can one should definitely look for an aberrant subclavian artery on the right side to identify a non-RLN during the surgery. Now, there are anatomic variations that can happen in the recurrent laryngeal nerve. On the left side, in 50% of the cases, this is the nerve and this is the artery. So in 50% of the cases, the nerve goes posterior to the branches of the inferior thyroid artery. In 35%, it is going between the branches of the artery, and in another 15%, it is traversing anterior. While on the right side, in 50% of the cases, it runs between the branches. In 25% of the cases, it goes either anterior or posterior. And ligation of the individual branches of the artery should hence be done to avoid injury to the nerve. Now, certain strategies have been identified to avoid injury to the recurrent laryngeal nerve. The preoperative assessment, as I said, we should be clear with the indication of surgery. The vocal fold mobility has to be assessed. It is assessed either via indirect laryngoscopy or fiber optic bronchoscopy. And in case any palsy is identified, then intraoperative nerve monitoring should be done. And the patient should be operated in a high volume center. Preoperative imaging should be seen, and preoperative ultrasound definitely helps in giving a cue regarding the probability of having a non-recurrent nerve. Need to be identified with the inferior thyroid artery. The Berry's ligament, it is one of the most common site of injuring the recurrent laryngeal nerve, and the supracandal tubercle also should be identified. Now, sometimes the nerve branches externally, and there may be a branch going deep to the Berry's ligament and one going superficial. So in that scenario, dividing inadvertently may cut the branches of the nerve. Hence, the ligament of Berry should not be cut or clamped until one is completely sure that the nerve has been identified. Secondly, there may be certain vessels which may be supplying the thyroid here and accompanying traversing along the direction of the Berry's ligament. It is always advisable to avoid using energy sources at this point because, however, save the energy sources, there is definitely some extent of lateral. Hence, use of ligatures and LiDAR clips is very beneficial in these places. Now, strategies that are to avoid the nerve injury, direct visualization of the nerve should be done in all cases. And gone are those days when it was said that a non-visualized nerve is a nerve that is preserved. Judicious use of energy devices and hemostatic measures, bipolar cautery, ultrasonic devices, clips, ligatures. And once we are beyond the deep cervical fascia, I think monopolar cautery should go off the table. Gentle handling of issues to prevent traction and excessive stretching that can lead to lateral traction injury on the nerve. And this comes with good training and practice. Now, direct visualization of the nerve. So 3 approaches have been described. The first approach is the lateral approach, which is the one that is most commonly used. The thyroid gland is retracted medially. The middle thyroid vein is divided and the recurrent laryngeal nerve is identified somewhere here. So there is a triangle that forms, and medially the boundaries of the triangle are the trachea and the esophagus, laterally the carotid artery, and inferiorly the inferior pole of the thyroid gland. So the triangle that is formed here usually carries the recurrent laryngeal nerve within it. The inferior approach is a good approach for revision cases. For example, when there's a recurrence after the subtotal thyroidectomy for goiter, recurrent laryngeal nerve is identified here in the soft tissue in the tracheoesophageal groove proximal to the inferior thyroid artery crossing point. And the important landmarks at this point are the tracheoesophagus medially, the carotid laterally, and the inferior pole of the thyroid artery. So this triangle is below the triangle that was
Is
distributed.
there an issue with the
Superior
video
approach
that
the
it is
least
running
common approach.
fast?
Here, the advantage is that the nerve is identified close to the cricoid cartilage, and the cricothyroid junction is usually constant in location. So there are certain adjuncts like magnification loop and intraoperative nerve monitoring to identify the recurrent laryngeal nerve. The intraoperative nerve monitoring, the American Association of Otolaryngology recommendations are that if not routinely, it should at least be used for total thyroidectomies, revision thyroid surgery of an external existing recurrent laryngeal palsy. Now, there are certain other soft indications of using an intraoperative nerve monitoring, such as when a central nerve, central lymph node, central compartment lymph node dissection has to be done for a papillary thyroid cancer. However, we must remember that intraoperative nerve monitoring definitely increases the cost of the procedure. Now, these are certain studies that I'm just quickly quoting. Around 30,000 patients in whom intraoperative nerve monitoring was used, and it led to a 2% reduction in the RLM injury. Now, here in this study, a cohort of almost 2.5 lakh thyroidectomies, it was seen that when total thyroidectomy was performed with neck dissection, then the use of an intraoperative nerve monitor significantly decreased the risk of RLN injury. Also, as the volume of the number of cases increased,
As the time is up, how much
benefit-
more of the video is present? Yeah. Oh, that's quite a long. So we are running short of time. I think we will wrap it up and play it during the break. Thank you, Dr. Suhani. Thank you, all these speakers, Dalapati sir and Dr. Suhani. Thank you, Pradeep sir. I think we'll move on to the next session.
Thank chairpersons. For the second part of the session, may I invite Dr. Himagiri Rao sir, Dr. Sasi Mali sir, and Dr. Chetra ma'am to join us as in chairperson.
Yeah. So for the next session, we'll invite Dr. Ashish Kanogia regarding airway management in thyroid diseases.
So, good morning, everyone. First of all, I would like to thank the organizers, especially Dr. Sabaratnam, for giving me this opportunity. So, since the time allotted is very less, so I will be going quickly through this and I will be skipping the routine things and will be covering only the things which are not done routinely or which are updates.
Can we have the presentation, please?
So I'm Dr. Ashish and I will be talking about airway management in thyroid cases. So there may be some pictures or videos which I will be showing. The consent has been taken. So I will be covering only the main features related to pre-op considerations, intraoperative management and post-operative management. So in thyroid diseases, we are concerned mainly of two things. One is functioning of the thyroid, that is patient might be having hypothyroidism or hyperthyroidism. And other thing is the mechanical obstructions due to enlarged thyroid gland, which may lead to tracheal compression, deviation or retrosternal extension. So while assessment, we should focus on any symptoms which are causing compression like dyspnea, dysphagia, hoarseness, which should alert us for the possibility of difficulty in managing the airway. So patient might lose the airway if we induce the patient due to loss of tone. So we all are aware of the routine tests which are done, including examination of thyroid. So I will not be going into those details. So virtual bronchoscopy is one thing which can be valuable in cases of Hughes thyroid malignancies and retrosternal. So quickly we'll go to virtual bronchoscopy. So this is a non-invasive test which can be done by CT images. And these are volume rendered images, which gives you a bronchoscopic image, just like the actual bronchoscopy, which we do. But the good part is that we do not need to insert the bronchoscope in patient's airway. So it is a non-invasive, it is safe, and it can be very useful for seeing the compression, any intratracheal infiltration, severity of compression, and so on. But the limitation is that we can't assess the dynamic changes in the airway diameters as we do in the actual bronchoscopy. But it can be a useful tool while deciding the airway management strategy. So another thing which can be done is 3D reconstruction and 4D reconstruction. This can be useful not only for airway management to decide what size tube, what type of airway management strategy you will plan. It also helps to decide the surgical planning. So if we combine it with 4D, then a dynamic airway assessment up to a certain extent is also possible. So while deciding airway management, we have to decide whether we want to go for awake or with sedation and general anesthesia. And if general anesthesia is chosen, whether we want to use muscle relaxant or without muscle relaxant. And then whether we want to go conventional with the direct laryngoscopy, video laryngoscope, or flexible optic bronchoscopy. In some cases, patient might not be able to lie down, so we have to decide whether we want to secure the airway in supine position or in sitting. So we have to weigh the risk and benefits of general anesthesia and awake. There are various techniques which are available for managing airway in thyroid cases. So it may be direct laryngoscopy, video laryngoscope, flexible fiber optic intubation, or hybrid technique. So the choice of technique will depend on the presence of compressive symptoms and worsening while lying down. So if patient doesn't have any compressive symptoms, which we discussed earlier, we can straightway go with the general anesthesia with muscle relaxant and intubation with direct laryngoscopy or video laryngoscope. But if patient has a history of dyspnea, but that is not worsening on lying down, then we can choose general anesthesia with or without muscle relaxant, and intubation can be proceeded with the video laryngoscope or flexible fiber optic intubation. But if patient has dyspnea, which is worsening on lying down, or patient has a critical narrowing on the CT scan, then awake intubation with flexible fiber optic or video laryngoscopy is advisable. But there are some cases where patient has severe dyspnea and he or she is not able even to lie down. Then we have to secure the airway even in sitting position. So I will be showing one case where we secured the airway in sitting position. So along with standard techniques of video laryngoscopy or fiber optic, we can combine these techniques, that is video assisted flexible intubation or combined technique or hybrid technique. And tracheostomy whenever needed can be considered at any stage. So depending on patient available resources and experience of the anesthesiologist, we have to formulate our plan A, B, and C. So if we have decided awake tracheal intubation, the awake tracheal intubation guidelines should be followed. A pre-intubation checklist should be followed, and all equipment should be kept ready. Oxygenation must be ensured throughout the procedure, and thorough topicalization should be done, and maximum lidocaine dose which can be used is 9 mg per kg. And number of attempts should be limited 3 + 1. So 3 attempts followed by 1 by experienced operator. And then tube placement must be confirmed with capnography before induction. So this is a case of 27-year female weighing 41 kgs. She had a neck swelling for 8 to 9 years, which was gradually increasing in size. She has a history of weight loss for 10 kgs in last 2 years. She was admitted in the our hospital for the surgery, but suddenly she developed dyspnea and she was not able to lie down. So she developed intratumoral bleed, due to which she suddenly decompensated. So we have secured the airway in sitting position, awake tracheal intubation in sitting position. So due to lack of time, I will be skipping the video. So once the tube was secured and it was confirmed doubly, one is with bronchoscope, another is with capnography, then patient was induced and placed in the supine position. So this is post-op period. Due to tracheomalacia, she was tracheostomized. This is another case of 55-year female with a large thyroid swelling for more than 30 years. She was having difficulty in breathing, which was progressively increasing in size. She used to sleep in the lateral position, and she has developed difficulty in swallowing for 6 months and recently developed a change in voice for 2 months or so. So she has this much huge deviation or trachea and tracheal compression. So we intubated her with the hybrid technique or video assisted flexible intubation. because of this huge thyroid, even with the flexible bronchoscope, it is difficult to negotiate because flexible bronchoscope will not be able to lift up the thyroid. So we couldn't record the video at that time, but to give you an idea of hybrid technique, this is another video. So in hybrid technique, we use two endoscopes. One is video laryngoscope and another is flexible bronchoscope. So once you visualize the epiglottis, the flexible bronchoscope is inserted through the glottis and you follow till the carina. And then endotracheal tube is inserted under vision to minimize the trauma. So this is the video laryngoscope, which is designed and patented by me. So extubation algorithm for major neck and upper surgeries has a very good algorithm. So to decide the risk, whether it's a low risk or high risk, we have to focus on the three things. One is the swelling in the airway, bleeding, and vocal cord paralysis. So if patient doesn't have these three things, patient falls into low risk category. And then if patient was not having difficult airway, we can extubate the patient after patient's efforts come and you have reversed. But if patient has high risk category, then after full reversal, patient's spontaneous breathing, we can extubate depending on whether patient was having any difficulty during intubation or not. If patient was not having any difficulty, we can extubate graded extubation, that is on the airway exchange catheter. And if patient was having any respiratory issues like OSA, then CPAP can be resumed. And in difficult cases, we can do cuff leak test. If cuff leak test is present, then it is indication that we can extubate if bleeding is not there. But if cuff leak test is not present, that is an indication whether patient might be having edema or patient might be having nerve injury or tracheomalacia. Or if there is significant swelling or active bleeding, we have to defer the extubation and we have to re-evaluate after 24 hours and we have to see again cuff leak, swelling and active bleeding and decide accordingly. So in post-op issues, patient might be developing tracheomalacia, especially after long standing compression, or patients having malignancy. So one must be ready for any emergency related to hematoma and should be ready for hematoma evacuation and should see for vocal cord palsy, and extubation should be planned with caution. In post-op care, patients should be nursed in 45-degree head-up position. Steroid can be given, which will help not only to decrease the chances of nausea, vomiting, will reduce the neuropraxia and also help to reduce the analgesic requirement. Multimodal analgesia can be given, and ultrasound guided superficial cervical plexus block is a good choice to reduce the opioid consumption. Hypocalcemia is another concern after total thyroidectomy, and proactive planning should be done for patient safety. So these are the guidelines for Difficult Airway Society and British Society of Endocrinologists and Thyroid Surgeons for the close monitoring of the post-op thyroid patients. So we have to monitor closely for DSATs, that is any difficulty in swallowing, swelling, anxiety, difficulty in breathing and stridor. And if these are present, we should oxygenate, evaluate the patient and plan for evacuation. So these are the how to evacuate the hematoma. So this is simply scoop, that is skin exposure, cut sutures, open skin, open muscles and pack wound. So take home message is thorough clinical and radiological evaluation of airway is critical for success. Proper planning of airway management should be done. Should plan ABC and prioritize oxygen at every step. Video laryngoscope may be the first line for all intubations in case of thyroid. High frequency nasal oxygenation improves safety during intubation and extubation and decreases the chances of re-intubation in post-op. Front of neck access should be last resort, and whenever it is indicated, it should be opted. Cricothyroid membrane can be marked with the help of ultrasound, and prior information to senior person in case of help is needed is always better. And before extubation, especially in huge thyroid and malignancies, tracheomalacia and nerve injury should be excluded. An extubation plan is critical, and post-extubation care should be done in the high dependency unit or ICU. So thank you so much.
Dr. Ashish, thank you for that very crisp presentation.
Thank
We'll take questions at the end of the session. And while maybe there one little experience I'd like to share with you. I was doing a re-explorative parathyroidectomy, and it was quite deep in the tracheoesophageal groove. It was between the esophagus and the trachea. I had taken out, and I had to resect a little bit of the esophageal muscle. So when I was repairing the esophagus, the membranous trachea was in front of it, and my needle went through the membranous trachea into the balloon of the endotracheal tube. The patient desaturated. And then we had to take the needle out, take down the repair. Over a bougie, we had to take out the old endotracheal tube and then intubate the patient again. Yeah. She was in the ICU for about 3-4 days and then uneventful recovery.
Even there are case reports where it was not detected, and while extubation it was noticed that it has caught. So that is also reported. So that is a scary situation. Thank you for this.
Thank you very much. I now invite Professor Amit Agarwal. Every time we come to Lucknow, we find something new. So I'm curious to know what is new this time in the last 6 months.
So very good afternoon. At the outset, I'd like to thank my colleagues Gaurav, Anjali, Gyan, Sabha, and of course, Abhishek for inviting me. Very happy to be here. I can recall the first postgraduate course that was held in '93 when Dr. Mishra conceptualized it, and I was there along with Sangeeta. And so it's a long way from since then. Now we are on the 16th postgraduate course. So next 10-12 minutes, we'll talk about use of adjuncts. I think my job has been made easy by a previous talk by Dalapati, where an experienced surgeon can actually do a safe surgery. But let's see how technology can also help the experienced surgeon to refine his or her own surgery. So SEPGI has been my Karm Bhumi, and this is my new workplace. We all take the name of Cocker because he popularized modern thyroid surgery. And you'll be surprised to know that the capsular dissection that we do today was actually propounded by him. So not much has changed since the days of Cocker. But I'm very fond of our own heritage, and you'll be surprised to know that even in Shushruta Samhita, which is as old as 2000 years, even the use of surgery for goiter has been described. Various types of goiter has been described. So if you're interested, you can go back and see that our heritage has been rich as far as thyroid surgery is concerned. Now, in last couple of decades, there has been a shift of paradigm. Mortality has decreased, but now the focus of the surgeons has shifted to a more, give a better cosmetic results by adopting robotic and endoscopic surgery, prevent recurrences by adopting total thyroidectomy rather than subtotal, and prevent complications. And two dreaded complications, which all thyroid surgeons sitting here are aware. One is the injury to the recurrent angina nerve, and the other is injury to the parathyroid glands. And so let's see how we can minimize these complications. We can use a lot of adjuncts, but today I'm going to talk about only two adjuncts. One is neuromonitoring for recognizing the recurrent angina nerve, and the other is use of autofluorescence for recognizing the parathyroid glands. Coming to hypocalcemia, it's one of the most common complications, especially in a bilateral thyroid operation. And why is it detrimental? Because it's life-threatening, involves cost to the patient can have cardiac issues, increases your hospital stay, and reduces the quality of life. So as thyroid surgeons, we don't want our patients to be hypocalcemic. There are various intraoperative methods. Of course, when experienced surgeons, you visually identify the parathyroid gland. Previous historical techniques have been use of frozen section or a float or sink technique. And recently, utilizing the calcium levels and rapid PTH assay to predict whether the patient is going to develop hypocalcemia or not. The thing to realize is the more parathyroids you preserve, the less the chances of hypocalcemia. So as thyroid surgeons, it's imperative that we save all the 4 parathyroids. And so let's see how we can do that. And not only preserve the parathyroids, it's also important that we preserve the parathyroid glands with an intact vascular supply. Just anatomical preservation perhaps is not going to help. We need to have a good perfused parathyroid. The 2 commonly used techniques for identifying and preserving the parathyroids have been ICG angiography and recently the near-infrared autofluorescence. A word about ICG, we are all aware it's a very good molecule. When illuminated at 806 nanometer, it gives out a low energy laser. You can identify with a camera. And then you can actually grade your parathyroids. If they are well perfused, it will be white. If they are partially perfused, they'll be gray and you give a score of 1. And if they are black, that means the blood supply has been conked off and you grade them as 0. Various equipments are available in the market. And this is one of the study which we did at SGPGI when I was here. And we really found that ICG is a good indicator or predictor of the absence of hypoparathyroidism after thyroidectomy. And in fact, it's quite comparable to the rapid PTH assay, whether it's 20 minutes after surgery or 4 hours after surgery. So it's a valuable tool. But the problem with ICG is that it doesn't help you to identify the glands. It helps you to know whether the gland is perfused. But it's important that you first identify the gland. And here the importance of autofluorescence really comes in. Now, autofluorescence is actually all tissues autofluorescence. And it was found that the parathyroid tissues, the autofluorescence is 11 times higher than the surrounding tissues like the thyroid. Now, this property of the parathyroid was utilized in this equipment where it was seen that if it autofluoresces more than the thyroid, you can capture it on your monitor or by the camera. Now, there are 2 types of autofluorescence equipments. One is probe-based and one is the image-based. The probe-based is one of the commonest instruments used by the Medtronic, it was PTI. And this is actually a signal-based. And if the video works, then yeah. So it's just a model you see. You stimulate where you see is a likely parathyroid, and then you get a signal on the monitor. So these are signal-based, but you don't get any images on the monitor. Is there audio in this?
Inตัวพาราไทรอยด์ and confirmed by PGI. The ratio more than
Rating is the parathyroid.
the patient.
But the image-based autofluorescence techniques are better. And you get a nice image on the screen. The surgeons, it's very user-friendly. And one of the machines that we use is the made in India machine. This is the Irelic machine. And we'll give you just preliminary experience for last 2 years. So this is the machine and this is the handheld scanner here. And you can do the different sequences. These machines can be used for fluorescence also. You can use in your sentinel lymph node biopsies in your breast cancers as well. So on the right side, you can see that bright image is the parathyroid. So this is the parathyroid. Here the intraoperative picture where I'm pointing. I'll show you a short video. So these are the 2 parathyroids on this side. So first you grossly visualize the parathyroids and then you perform. Now you can see on the monitor, these 2 bright dots are the parathyroids. So you are sure that the structures that you have saved is the well-perfused parathyroid. So this is an image-based system. So you can see on the right side, These are the two parathyroids here and on the left side. So this is the intraoperative field after thyroidectomy, total thyroidectomy. And you have saved all the 4 parathyroids. So it really reassures the surgeon that the structures that you have preserved, that you thought were parathyroids, are actually parathyroids, and they are nicely visible on the monitor. So the patient is unlikely to develop a total thyroidectomy, yet it can develop a temporary hypocalcemia. This is an interesting case. We thought we were not sure out of these 2 structures which was the parathyroid, and which we have retrieved from the specimen. And we did an autofluorescence. You see only one of the structures is autofluorescing. So we know that this is the parathyroid tissue and not the lymph node or the fat, and which we autotransplanted. So the other structure is not autofluorescing, only one structure is autofluorescing. So this is again, we have visually identified the parathyroid. You can see on the monitor, the parathyroid you can nicely see, and you can save it nicely. So in 20 cases, mostly they were total thyroidectomy, and some 4 cases they were with neck dissection. We could save 17 parathyroids in all patients. So all 4 parathyroids were saved in 17 patients, and whereas in 3 parathyroids were saved in other patients. Only out of 3 patients, if you see on the right side of the sheet, only 3 patients had PTH which was low. Otherwise, all patients had normal or high PTH. So it correlated well with your autofluorescence. None of these patients developed hypocalcemia. On those patients where PTH was low, developed temporary hypocalcemia. So it really, reassures the surgeon. You can identify it before you damage the parathyroids. After that, you can again confirm that what you have saved is a nice, well-perfused parathyroid. A lot of meta-analysis and systemic reviews have been done, and all have confirmed that the autofluorescence is an excellent indicator for identifying the parathyroid glands during thyroid surgery. It does not have an important role in parathyroid surgery, so I'm not touching on that, but it has a definite role in thyroid surgery. So the advantages of autofluorescence over ICG is contrast-free, easy to use, Now moving on to the other adjunct, which is neuromonitoring. It's a very dreaded complication, and most of the consumer cases abroad are actually related to recurrent nerve injuries. The different causes, traction and cutting and thermal lesions, can all cause either complete or a partial paralysis of the recurrent laryngeal nerve. And it could be detected either immediate, early, or late. Why do we need neuromonitoring? Because a lot of anatomical variations, and we need to be aware of them. And intraoperatively, unless you have an endotracheal tube in place, neuromonitoring in place, you will not be able to do monitoring. So all cases actually should be monitored rather than only high risk or difficult cases. There is a lot of cases of invisible injury, as I mentioned, due to traction or thermal injury, and your IONM should be able to detect these lesions. So I'm sure yesterday you would have had a neuro monitoring workshop, so I'm not going into setup. These kind of a classical graph that you get on the monitor. I'm not going into the details, but avoid neuromuscular relaxant by the anesthetist. What are the advantages of the neuromonitoring? It helps in identification. It aids in nerve dissection. This is very important. It really saves time because early on you detect the nerve, and therefore your time is saved a lot. So it not only helps in identification, it aids in nerve dissection and saves a lot of time. And of course, it can predict post-operative vocal cord function identification at the nerve injury site. As I mentioned, in the high-risk situations where you're doing a thyroid surgery for cancer, a large goiter, a Graves' disease, a reoperative surgery, but I am a proponent of the fact that you should do neuromonitoring in all settings because every thyroid is difficult. As Ashok Shah famously said, every thyroid is difficult, So you have to go with that mindset, have a neuromonitor in place. If you get an anatomical variation, and if you have a neuromonitoring in place, you can very well save your nerves. There are a lot of systemic reviews which have shown that neuromonitoring is quite safe, and not only intermittent, you can also do a continuous neuromonitoring. So you see the graph here. At points, you will know where you are pulling the large goiter, so you can avoid the traction injuries also. So latest is continuous neuromonitoring, and the new equipment, you need not even place the electrode in the carotid sheath. So that advantage is there with NIM Vital. Can we have the audio? Yes, is there. So this is the nice sound you get. I hope it's plays, yeah. So these are a couple of cases where large goiters. This was a gentleman who came with the palsy, already had a palsy on one side. Can we have the audio? So this gentleman, we operated under neuromonitoring, and this is the nerve on this side. So these kind of patients, nerve monitoring is very reassuring. Large goiters, you see the nerve is displaced, and you can help with the help of neuromonitor, you can identify the nerve. So as I mentioned, there are a lot of advantages. And if you see the last line, the low volume thyroid surgeons can have the advantage of using neuromonitoring. So not only experienced surgeons, but low volume surgeons can take the advantage. So recently I wrote a chapter for controversies, and there we found that the meta-analysis have all proven that the rate of nerve injury is much lower in use of neuromonitoring as compared to visual identifications. So there has been a controversy over the last 2 decades, but now studies have shown clearly that there is an advantage of neuromonitoring. Now, this is my last slide. Ashok Shah mentioned what should be the attributes of an ideal thyroid surgeon. I've slightly modified it. These are the attributes, and I've dedicated my life to producing ideal thyroid surgeons. I'm happy that most of the top Indian thyroid surgeons are sitting here. So one important attribute is that he should know how to use the technology or an adjunct for minimizing the complications. There is no shame that all experienced surgeons can also refine the surgery with the use of neuromonitoring and autofluorescence. So I think a modern thyroid surgeon as of today should have a neuromonitor in the theater, should have an autofluorescence or an ICG equipment in the theater, so that you can really minimize and have an almost a zero rate of complications in your patients. And that is what, as an ideal thyroid surgeon, we should all aim for. So thank you very much for your kind attention, and thank you for inviting me. Thank you, chairpersons. Yeah. You loud voice you have. Don't know where you have a loud voice. Yeah.
Okay, enlightening as always.
Thank
you. Is there any way we can differentiate between a viable thyroid gland and a non-viable thyroid gland in the neck? Sometimes what happens is the parathyroid is there, but the vasculature may be compromised. Is there?
Good question. You combine both your techniques. So autofluorescence helps you to identify the gland, and you do ICG to know whether the perfusion is there. So both techniques are actually complementary to each other.
Any questions from the audience? Any comments? Dhyan Singh, sir.
So excellent talk, sir.
Thank you.
So just I want to know about the ICG. So what amount you use in the ICG, and whether it is different according to the BMI of the patient?
Yeah, so you get a vial and you dilute it. This 5 milligram powder is there, and you dilute it and make it up to 20 ml. And you can use up to 1 to 2 ml. The only thing, the timing is very important. So you have to immediately use your camera, because just within 2 minutes you have to use it. Otherwise, the entire field will become green. So, and yes, your question is very valid. It does depend on the weight. So it's per kg body weight of the dose that is important. In obese patients will require a higher dose, because the fat takes a lot of ICG.
Thank you, sir.
Any further questions? Thank you, sir, for the excellent session.
Thank you, sir. Very interesting. Sir, in autofluorescence, can we get any scenario where false positive parathyroid is there?
During thyroidectomy?
Yeah.
Yeah, it's again an interesting thought. I couldn't find a false negative is there. Means sometimes when the parathyroid is within the fat and it is plastered to the thyroid, you may not get a positive autofluorescence. But false positive, not seen yet.
Okay. Any lymph node or something?
Lymph
like,
nodes do not autofluoresce at all. So
Okay.
of course, that is for sure. But negative autofluorescence can be there because if the parathyroid is embedded, it may not give autofluorescence.
Thank you, sir.
Yeah.
So just to add,
Hi,
I
sir.
mean, do you also use it for adenomas?
We have used in 10
But-
cases of adenoma, and we get a very heterogeneous picture. Some of them you get autofluorescence, some of them you don't. But mostly you get a cap, what is known as a cap of autofluorescence. A part of the parathyroid will autofluoresce. But interestingly, you ask that sometimes it helps you to identify the normal parathyroid gland lying close to your adenoma. So it does help you to prevent removal of that, inadvertent removal.
Thank you, sir.
Yes, thank you.
Sir, in cases where we would need to do a bilateral neck exploration for parathyroid, do you think this would be a good adjunct if we are
Interesting thought, yes, because bilateral exploration, especially the superior parathyroids, sometimes are difficult to localize. But as I said, the parathyroid adenomas may not autofluoresce all the time.
maybe it would be good to identify the normal ones?
Exactly. So maybe the work is going on to differentiate whether between normal and hyperplasia. So in
Yes.
those cases of CRF or secondary hyperpara, it'll really help you to know whether the gland is normal or hyperplastic.
Okay, sir. If there are no further questions, thank you so much, sir. Thank you for the wonderful talk. We'll move on to the next session.
Thank you to all our speakers and chairpersons. We'll now move forward with panel discussion. Anybody interested can have a move-in tea break because we are short of time. And we'll move ahead with panel discussion on thyroid nodule. I'll invite the chairpersons, Dr. M.J. Paul sir, Dr. Bhargav sir, Dr. Bhargav sir will join us as in with video conference. Dr. Vinita Agarwal ma'am, Dr. Ashmita Arya ma'am to chair the session.
So good morning, everybody. We are ready to start the session. The first talk will be taken by Dr. Tanya Yadav, who is a radiologist at SCPGIMS. She'll be talking about the newer imaging modalities. So we know that with time, there has been a lot of change in the management, in the diagnosis of thyroid nodules. So here we are with all the panel of radiologists, pathologists, and clinicians to talk about it. Thank you, Dr. Tanya.
Thank you, especially to Gyan sir and Sabha sir for giving me this opportunity here. So before we move on to the newer imaging modalities, I believe a quick revision of the conventional ultrasound is always important. So a quick go on the normal anatomy of the thyroid. This is the butterfly-shaped gland with track muscles in the front. Posteriorly, we have trachea. On the left, we have esophagus and the longus colli muscles posteriorly. Bilaterally, we have the IJV and carotid vessels. So the basic features which discriminate between the benign and malignant nodules. The benign nodules mostly are purely cystic or cystic with thin septa. Malignant ones are mostly mixed, solid and cystic. If the nodule is hyperechoic, more echogenicity, then it is probably benign. If it goes towards darker side, it is more malignant. Then the well-defined margins, big calcifications point towards benignity and malignancies by microcalcifications, the punctate echogenic foci, they are more towards the malignant side. So quickly, the conventional ultrasonographic features. This is the spongiform pattern, very typical of a benign nodule. This is a solid nodule with less than 5% of the cystic areas, so more towards the malignancy. And the ones in which there is peripheral thick rand of soft tissue, there are more chances of being malignant. Echogenicity wise, if the nodule is hyperechoic, then it is benign. And as it goes more and more hypoechoic, like this one, where the nodule is quite dark, it is more towards some malignant side. Shape wise, if the nodule is taller than wider, it is more of malignant, and if it is oval, that is wider than tall, it is benign. Then margins, if the margins are very smooth, well defined, it is more towards the benign side. If it becomes lobulated or irregular like this one, then it is more towards the malignant side. When there is extrathyroidal extension, the chances of malignancy increases. Then the echogenic foci. So normal thyroid also has a speckled pattern, so it should not be confused. Like this one is a speckled pattern. However, the microcalcifications like this, which give the short comet tail, these are very highly likely of the malignancy. And the larger coarse calcifications, they are more in the benign nodules. So by combining all these things, we can classify the nodule according to TIRADS. And by TIRAD score, the follow-up is done through FNAC. So what's new now? We'll talk about that. CT and MRI are done for thyroid diseases to look for incidental nodules, locally invasive diseases, lymph node metastasis, any post-treatment recurrence. And new things are coming up now, like multiparametric MRI. So it was noticed that with the conventional ultrasound TIRADs, they had a lot of unnecessary biopsies, unnecessary FNACs were done because the specificity was only 49%. So new things are coming up now to reduce the rate of unnecessary tissue diagnosis. And so diffusion weighted imaging is one of those. And we know that when the nodule becomes more and more malignant, the cell density increases. And as the cell density increases in tumor tissues, the water diffusivity decreases. So these malignant nodules with high cell density, they light up on the diffusion imaging. Like we can see here, this is a nodule on conventional ultrasound, and on diffusion weighted imaging, it is lighting up. However, to confirm that this is restricted diffusion, we need the ADC imaging on which it should appear black. If the nodule is is lighting up on the diffusion, but it is not dark on the ADC images, it is not a true diffusion restriction. So that should be taken care of. It should be a true diffusion restriction to label the nodule as malignant. Now, besides the conventional ultrasound, elastography is coming up. So elastography can be used to upgrade the conventional ultrasound imaging, and it can be a valuable tool in the indeterminate nodules, Bethesda 3 and 4, in finding out localizing small papillary thyroid carcinomas. The papillary thyroid carcinomas have very fibrous stroma, so they are very stiff, and elastography can help to detect the papillary thyroid lesions. Also, the lymph node metastasis of PTC. The lymph nodes also have very tight fibrous stroma, so they will be very stiff on the elastography and they can be picked very easily. Similarly, recurrent disease assessment, scar versus tumor. So scar is also stiff and tumor is also stiff. However, scar is homogeneously stiff and tumor has mixed areas of necrosis and scarring. So the homogeneity will differentiate between the scar and tumor. There is this RAGO criteria. It will be more clear with this image. So usually all the machine vendors, they set this format. It can be reversed, but usually the green represents the elasticity and the blue represents the stiffness. So in the first image, you can see that the entire nodule is green. That means it is very soft. So it should be a benign nodule. In the other image, we can see that there is some areas of stiff areas, And as the grading increases, the stiffness, the blue areas increases. Like in the last one, the entire nodule is blue in color. So that means it is very stiff and it can be used to confirm malignancy. However, there are some pitfalls to elastography, like if the nodule has a calcified, peripheral calcified shell, we cannot use elastography. Intralesional calcification, large calcifications, they also will be very stiff. And although coarse calcification are seen in benign nodules, still we can get the stiff, because of the calcifications, the nodules will appear stiff on elastography and it will be a false positive. Similarly, partially cystic character also alters the nodule elasticity, and the Hashimoto's thyroiditis, Reader's thyroiditis, all these things which although they are benign, but because of the fibrosis, they are very stiff and they can give us false positives. Then another new thing that is coming up is the contrast enhanced ultrasound. So we know about contrast MRI, we know about contrast CT. Now contrast can be done even in the ultrasound. And the good thing about the ultrasound contrast is it is not at all renal toxic. It can be given at any creat level, any GFR level, and also it is non-ionizing. So it can be repeated multiple number of times, and it is excreted via lungs. So there is nothing to worry about except the cost. It is slightly costly in India. One vial costs around rupees 6,000. So where can we use contrast enhanced ultrasound? In adjunct to the conventional ultrasound. So again, the indeterminate nodules with Bethesda 3 and 4, nodules with indeterminate conventional findings like TIRETS 3 and 4, and to differentiate between the follicular adenoma and carcinoma, which always remains doubtful for conventional ultrasound. And also like post-ablation, to determine whether any viable thyroid is left after ablation or not, we can use the contrast enhanced ultrasound imaging on table. So how is it performed? It is performed on the same machine that we have, the routine ultrasound machine. The settings are changed to low mechanical index, and intravenous injection of the contrast agent is done. Within 2 to 3 minutes, the thyroid gland lights up. And based on the enhancement patterns, we can determine whether the nodule is benign or malignant. So what all we look for, the enhancement pattern, we look whether the nodule is enhancing homogeneously or heterogeneously, whether there is peripheral enhancement is smooth or it is irregular. So irregular central enhancement is strongly associated with malignancy, whereas homogeneous enhancement and smooth peripheral enhancement suggest benign nodules. And the degree of enhancement also suggests whether the nodule can be benign or malignant. Like because of the abnormal angiogenesis, the malignant nodules, they enhance slightly less on the contrast enhanced ultrasound. It is different than the contrast enhanced CT and MRI. So also the wash-in time, if the nodules have slow wash-in time, it indicates malignant nodules, and if there is persistent contrast, it suggests malignancy. So to summarize, if there is homogeneous hyper iso or no enhancement, and there is a regular high enhancement ring in the periphery, they are mostly benign. And if the lesion is showing iso enhancement with focal areas of low enhancement, it should be considered malignant. And an irregular ring in the periphery also suggests malignancy. It will be more clear with these images. So this is a conventional ultrasound with a hyperechoic nodule. And on contrast enhanced ultrasound, there is very homogeneous enhancement with a very smooth peripherally enhancing ring. We can see here. So this is a typical of a benign nodule. Again, in this nodule, we can see that this appears more of a solid nodule which is hypoechoic. So on conventional ultrasound, we may get confused that this is a malignant nodule because it is hypoechoic. So thyroid score will increase, and it is completely solid. So the thyroid score is definitely going to increase, and we'll unnecessarily put this nodule for FNEC or biopsy. However, on contrast enhanced ultrasound, we can see that it is not enhancing at all. So that means that the central part is non-viable, and this was a benign cystic thyroid nodule with hemorrhage within. So with the help of contrast enhanced ultrasound, we can actually downgrade the ACR thyroid's level and prevent the unnecessary FNACs. Like this nodule, it is hypoechoic on ultrasound, and on contrast enhanced ultrasound, we can see that there is heterogeneous enhancement. These are areas of iso enhancement, some areas of no enhancement, and the margins are not clear. So this points towards malignancy. And the another very good role of contrast enhanced ultrasound is during ablation. While doing the microwave ablation on table, we can determine that how much part of the nodule is still left during ablation, how much part is a viable part, what is the normal thyroid gland, so with the help of contrast enhanced ultrasound, we can reduce intraoperative bleeding and minimize damage to the thyroid function. Similarly, for follow-up also, this contrast enhanced ultrasound is very good. Instead of doing repeat CT, repeat MRI, giving renal toxic contrast agent, we can always do contrast enhanced ultrasound, and we can see how beautifully we can see that whether the ablation is complete or not. On conventional ultrasound, we may feel that a viable part is left. However, when we give the contrast, we can see that there is no viable tissue and it is a complete black hole, which makes us confident that the ablation is complete. Thank you so much.
Thank you, Dr. Tanya. We'll have the questions at the end of the session to save time together, for all the speakers.
Now I will call Dr. Manish Sora for the talk on the emerging nuclear imaging in the thyroid nodule.
Good morning, everyone. I won't be taking much time and I won't be boring any of you. So images are beautiful. It is very colorful. Lights कम कर सकते हैं क्या ज़्यादा सुंदर दिखेंगे? हाँ, thank you very much. So basically the nuclear medicine was having a great role in the starting in the era of 70s and 80s when thyroid scintigraphy was playing a major role in the evolution of thyroid nodule. But the things has changed entirely in the range of 2015 and now it has come to the zero. But still, is there any role? We would like to go into the deep and just see if there is any role. So first, a patient come with hypothyroidism and or euthyroidism and having thyroid nodule. Is there a role of assessment of that thyroid nodule by targeting sodium pertechnetate or any kind of sodium iodine symptomatic imaging means any kind of iodine? Any of the guidelines does not recommend that you should not do a thyroid scintigraphy for patient who is hypothyroid or euthyroid. So no guideline recommends the routine use of thyroid scintigraphy in the evaluation of nodule with normal TSH or nodule detected by ultrasound. It should not be done. Why? Because the prevalence is very, very high. In the India, the prevalence of thyroid nodule is still around 50%. If we go by the ultrasound, if we see the size more than 1 centimeter, obviously doctor has palpated. So that's why I sent for the ultrasound. So it will again remain around more than 50%. And the risk of malignancy is less than 10%. So the pre-test probability of finding a malignancy in such a thyroid scan will be very high prevalence of thyroid nodule and very low risk of malignancy. So obviously we are going to have very high false positive case on thyroid scintigraphy. So just see we will see the three scenario. First is thyroid scintigraphy. We just able to see the intense area of uptake in the neck. On the left side, rest of the gland is not visualized. So this is a hot nodule. The risk of malignancy is less than 5%. Second, take normal gland with a decreased uptake cold nodule. And the third is there is faint visualization of both lobes, but there is an area of showing increased uptake. That is warm nodule. So malignancy is less than 5%, 5 to 20%, or more than 5%. So the sensitivity is around 90%, but the specificity is around 10% and positive predictive value of only 10%. So to have a disease of thyroid cancer, you have to unnecessarily get FNAC of 9 patients done. So it is technically useless. And the risk is never zero. You cannot rule out that this patient will not be malignant. So thyroid scintigraphy should never be done. But when patient is presenting with hyperthyroidism and thyroid nodule, then it is almost recommended. So we have to do just to rule out whether it is autonomy, it is AFTN, and negative predictive value is extremely high in the range of 95, more than 95%. The USG may be thyroid 3 or 4, and FNAC may be even indeterminate if you get it done, and it is mandatory for the radioiodine therapy. The scan look very simple. Any can identify it. So where the nuclear medicine imaging can play a role. So two distinct things are, which is usually very well talked in the conferences, it indeterminate nodules on FNAC. And the second thing is thyroid incidentalomas. We'll just see how the evidence has grown from 2015 to 2025 in these scenarios also. First, I will be going in the indeterminate nodule. So these are indeterminate nodules on the FNAC, and whether we should perform another FNAC or third time FNAC, or we are going to just operate it, the sensitivity or specificity of FDG PET-CT in this scenario is very, very different. Specificity and positive predictive value again are very less, but the diagnostic odds ratio is 3.5. So the systemic review in 2020 told that in selected cases, just to avoid the unnecessary diagnostic surgeries, it can be done. So multiple studies were done just to evaluate this thing, whether this is viable or not. So this was a first randomized control trial multi-centering study, blinded, just to see whether FDG PET-CT guided strategy can just avoid the futile surgeries. What they did, they took all the Bethesda 3 and 4 nodules. They did FDG PET-CT. First, they divided the group into two. The diagnostic surgery was done in all the groups, and the FDG positive patients, which were having SUV more than 2.5, the median was 4, were operated. And those who were having FDG negative were kept on surveillance. So what was the outcome? The outcome was, in the surgery group, the unbeneficial management was done in 83% patients. That means only the 17% patients found to have a true malignancy. But in PET-CT, the unbeneficial management was of 42% patient. So around 50 patients, 50% patients were still unnecessarily operated. So it was recommended then that by these group, that they can reduce the futile surgeries in 40% per patients, but it is only for the non-Hurtle cell type. So it looks lucrative. Just see what the cost effectiveness say. The same group again did the studies with larger multicentric trial, and they again performed the cost effectiveness. So it is very, very important whether the strategy, because both of them with the study FDG PET-CT cost around 20,000 in India, and it cost approximately in lakhs in US and UK scenario. So whether it is be cost effective or not. So they again took the same group of patients, and they did the cost effective analysis. What they found, that cost effectiveness for 1 year cost difference was around 1,000 euro, and the quality adjusted life year was only 0.02. So technically someone has to survive 50 years just to document, yes, FDG PET-CT was very good. If we take the same rate over here, so for willingness to pay approximately 50 euro per quality adjusted life year, the FDG PET-CT effective strategy will be very, very effective. So technically this is also useless. So again, so just to see whether the molecular diagnostic also perform or does not perform. So they added the both strategies. So this is the most recent study, again multicentric, and the title itself is very good. Molecular diagnostic and FDG PET-CT in indeterminate thyroid nodule, complementary techniques or waste of valuable resources. So what they found out, that there's a randomized study, the molecular diagnostic was done, and FDG PET-CT, everything was done. So ultimately they found out the both have good sensitivity around 80 to 90%. The specificity is around 70% for molecular diagnostic, and for PET-CT it is only 41%. Even if we take the double negative of molecular diagnostic and FDG PET-CT, the sensitivity is around 95%, but specificity is only 40%. And if we take the double positivity, then even the specificity is around 86%. So what they recommended, although complementary, but benefit of their combined use may be confined when the therapeutic consequences are considered, and therefore they are not routinely recommended. The second thing, which is also hot topic, thyroid incidentalomas. Whenever you do PET-CT, whatever agent you use, whether you use the glucose metabolism, protein, lipid, PSMA, whatever you do, you will find out something which is taking up in the thyroid. If it is a well-defined nodule, it is called as thyroid incidentalomas. Thyroid incidentalomas, very large study shows that incidence is approximately 2%. And if all of them patients are sent for FNAC, almost 50% of them will be having FNAC, 20% of them will be having non-diagnostic, and you will find out risk of malignancy in approximately 1/3 of them. So 2% are having thyroid incidentaloma, and 1/3 of them are having malignancy. So approximately the risk of having malignancy in thyroid in PET-CT done for other indication is less than 1%, technically 0.66%. Depends upon how much is the focal uptake and other parameters also. So is there any change in clinical practice after all these things? In 2015, the American Thyroid Association has guideline for thyroid nodule and differentiate thyroid cancer. The first thing, they drop out the thyroid nodule word from their guideline in 2025. So there is no thyroid nodule in 2025 guideline. And the second thing they did is there is no even the mention of scintigraphy word in all 145 pages. So there is no indication of doing thyroid scan in any patient being evaluated for thyroid nodule or thyroid cancer with per-technited study before surgery. So the second very important recommendation number 10 is there any rule of preoperative somatic genomic testing to be performed to inform the extent of surgery? So in 2025, they clearly mentioned approximately 2.5 pages, and it said, this result, although pending confirmation in other studies, suggests that these molecular markers alone or in combination may be useful for risk stratification of thyroid cancer and provide significantly more accurate risk assessment than BRAF mutation alone in isolation. So they recommended approximately 5 mutation analysis in thyroid nodules. But what happened in 2025? It is not recommended now. They clearly say if the genomic profile is known or performed, यदि हो गया है तो अच्छी बात है, उसको consider करिए, but consider clinical, radiographic and cytopathological data to evaluate the surgery rather than this only. This is also conditional recommendation. And the second very important thing is this is the third cancer which were mentioned the word active surveillance apart from prostate, NET and thyroid cancer. So are there any patient to whom active surveillance or percutaneous evaluation are appropriate? Yes, it can be offered in clinical stage T1A, N0M0, ATA 2025. But obviously there should be shared clinical decision making between the patient and clinical team, and stringent follow-up has to be done. So the most important aspect of this is that most of the thyroid incidentalomas fall in this category only. A patient is having extensive metastasis from the breast cancer, almost not going to survive for more than 1 year. If you find a thyroid incidentaloma of 1 centimeter and even it is positive for PCT, whether to operate or not, it will be the. So the take-home message is very simple. Thyroid scintigraphy should be done only with nodule with hyperthyroidism, not with euthyroid or hypothyroid patients. All cold or warm nodules, if you get on a scintigraphy, then FNAC has to be done. In incidentalomas, the management needs a holistic approach, including taking the account of the primary disease status. And the use nuclear imaging only if the clinical guiding decision, individualized patient construct, otherwise don't use it. Thank you. Thank you very much.
Thank you, Dr. Manish. That was a very crisp and clear presentation. Thank you so much. We move on to the next presentation from pathology. Dr. Neha Nigam, additional professor in the Department of Pathology at SGPGIMS. She'll be talking about newer techniques in tissue diagnosis.
Okay. My heartfelt thanks to the organizing team for giving me the opportunity. Hope I make a justice to this topic. So my topic is the newer techniques in the tissue diagnosis. Before going into the details, I'll just show the outline of my presentation, the brief introduction, the molecular landscape of the follicular-derived thyroid cancers, and thyroid nodule approach and diagnosis, then the techniques in the tissue diagnosis and advances. So as we all know, the thyroid cancer incidence has been increasing over the years. The FNAC is the screening and the diagnostic modality. However, the question arises when the category 3 and 4 comes into the picture. So the increased knowledge about the molecular profiling of the thyroid neoplasias has transformed the approach towards the diagnosis, prognosis, and the therapeutics. So now the initial traditional diagnostic approach will be the imaging and the guided FNA cytology, in which diagnosis will be made in 80 to 85% of the cases, whereas 15 to 20% of the cases are non-diagnostic or of indeterminate category, for which repeat FNA or the surgical intervention has been suggested. In newer diagnostic approach, the molecular profiling or the testing has been come into the picture. So in newer diagnostic approach, when we perform the cytology, guided cytology, if it comes into the category 3, FLUS, AUS, the follicular neoplasm category 4, or the suspicious of the malignancy, then has been suggested that testing for the panel of the mutations, the basic panel, the BRAF, RAS, PAX8, PPAR, gamma has been suggested. And if they came positive, it is suggested of the malignancy and the total thyroidectomy or the surgical intervention has been required. Whereas the observation, repeat FNA or the lobectomy has been done if the test came negative. So I'm just briefing the basic molecular test because rest you can correlate with the rest of the presentation. As in the PTC, the BRAF mutation V600E, red PTC rearrangement, the RAS mutation has been documented. Whether the follicular carcinoma thyroid or the follicular origin, the RAS mutation and the PAX8 PPAR gamma rearrangement has been done. The poorly differentiated or the anaplastic carcinomas, the TP53 mutations and TERT promoter mutations are noted. And in MTC, red proto-oncogene mutations and oncocytic cell neoplasms, the RAS mutation has been documented. So these are the basic mutations. And then there are the molecular landscape and the expansion of the molecular profile, which I'll be covered later. So what could be your sample collation and what could be your methodology? The sample could be of anything, any cytology specimen. The FNA smears, you can prepare a cell block, the liquid-based cytology, the needle wash of the FNA procedure, and metastatic cytology, and as well as the tissue biopsy. So these all could be your specimen. And initially what we are applying on the ancillary application, which are the basic, the immunohistochemistry, immunocytochemistry, and the newer technique is the molecular applications. So diagnostic approach or the technique includes three of the aspects: the immunohistochemistry or the immunocytochemistry, in which there are basic first generation or the novel immunohistochemical markers. There are second generation markers, which can be more specific and sensitive. The next generation markers, which can depict your molecular profile, and the markers which are suggesting your tumor microenvironment. The next will be your molecular diagnosis or the applications, and the last will be some points about the liquid biopsy. So coming to the immunohistochemistry and the immunochemical markers. So immunostaining is very cheap and very easily performed at every center of the in every medical center. So it is easy to perform, easy to interpret, and it is well established and well validated modality. So coming to the novel and the first generation markers, these are the markers which can define the specific lineage of the tumor. Like the follicular cell differentiation, the TTF1, TTF2, and the PAX8 are showing the follicular cell differentiation along with the thyroglobulin and sodium iodide symptoms. Whereas the C cell differentiation, the calcitonin and the carcinoembryonic antigen will be performed, which can show that the tumor is of C cell differentiation. Okay. Next, in this novel or first generation marker could be added the Ki67 proliferation index and the CD markers. So some of the recent studies have shown the significance of the Ki67 proliferation index and CD markers in the as the first panel of the immunohistochemistry. So in the Ki67 proliferation index, the utility is in differentiating between the non-proliferative or non-neoplastic to neoplastic, as well as the low grade to high grade differentiation. In normal follicular thyroid cells, it is less than 1% or the less than 0.1 or 0.2, whereas in the malignancy or the malignancies, it is more than 2%. And in well-differentiated malignancies or the differentiated thyroid carcinomas, it is up to 5 to 10, whereas in the poorly differentiated and the anaplastic thyroid carcinomas, it is up to 30%. And in some studies, the anaplastic carcinoma have the 50% of the Ki67 index. So it has been proposed that to be useful in stratification of the differentiated thyroid tumors into the different risk categories. In the low risk, medium risk or moderate risk, and the high risk. The Ki proliferation index of less than 5% low risk well-differentiated tumors, whereas 5 to 10 is the medium risk and 10 to 30 is the high risk group. So these are the immunohistochemistry slides performing the Ki67. In the first picture, you can see the few of the slides are positive, brown nuclear positivity. The follicular adenoma case, 2% positivity. And in the follicular thyroid carcinoma, 4% Ki67. In the papillary thyroid carcinoma, 5%. In the poorly differentiated thyroid carcinoma, it is increased to 20%. And in high-grade PTCs, it is a papillary thyroid carcinoma. However, it is a high-grade 35% Ki67. And in anaplastic, it is around 40%. So next is the CD markers. As we all know that the normal thyroid does not show any CD markers like the CD10, 15, 20, 57, 73, 99 and 227, except the CD56 and CD117. So the normal thyroid shows CD56 and 117. So the absence of these two markers show the malignancy, whether the presence of these markers is non-neoplastic or benign. Contrary to that, rest of the above markers are not found in the normal tissue, and when present, it shows the malignancy. So like in this first picture, immunohistochemistry, CD10, it came positive, good membranous positivity. CD markers are showing the membranous positivity. So these are positive in the papillary thyroid carcinoma. The ATC, CD15 is positive again in the PTC. CD20 again, picture in the PTC. And CD56, which are common, my cursor is not moving. So CD56 is absent in the papillary thyroid carcinoma, whereas it is present in the normal and non-neoplastic tissue. So now coming to the second generation immunohistochemical markers. What are these markers? Some are the primary markers like the chromogranin, synaptophysin, calcitonin, and carcinoembryonic antigen. These are the neuroendocrine markers. Those markers which are much more specific, those are the second generation markers, like the insulinoma associated protein 1, the islet cell markers, or the FOXA1. These are the transcription factors which are involved in the embryogenesis. So when these markers are positive, these markers are much more sensitive and specific for the tumor. So these are the second generation neuroendocrine markers. Now, third category is the next generation immunohistochemistry or the immunocytochemistry markers. These are of interest because these are mutation-specific novel markers with the translational importance. It involves the use of antibodies which can detect the genetic alterations at the protein level. You can diagnose these genetic alterations in the tissue. So these are the surrogate molecular testing and have the diagnostic, prognostic, and the predictive values. So these are the common target proteins. The second column is of target proteins, the immunohistochemical markers, which have the BRAF, show the 86% sensitivity and 90% specificity for the molecular alterations of the BRAF V600E, whereas the beta-catenin, APC genetic alteration can be seen by the beta-catenin. The RAS immunochemical marker show the RAS mutation. The PTEN markers show the PTEN inactivation. The pan-TRK, which is a marker for aggressiveness or the high grade of the tumor. So this showed your NTRK rearrangement. And there could be the ALK immunohistochemistry, which shows the ALK rearrangement. So these all markers are diagnostic, prognostic, and some are predictive. So these are the immunohistochemistry of the next generation immunochemical markers. In the first picture, this is a BRAF immunohistochemistry showing the granular cytoplasmic positivity in the papillary thyroid carcinoma. The second picture is of high-grade PTC. It showed the pan-TRK positive tumor. This case has the lymph nodal metastasis as well. And in cribriform modular thyroid carcinoma, beta-catenin nuclear positivity is seen in the third picture. And in fourth, the ALK cytoplasmic positivity is seen in the EML4 ALK rearrangements. This is again suggests the lymph node aggressive nature of the tumor and the lymph node metastasis. So these markers help in the prognosis, in estimating the prognosis and the treatment decision. So now there are some next generation immunochemical markers which can detect your tumor microenvironment. Why this tumor microenvironment is important? Because modulation in this affect the tumor development and progression. And the tumor cells can dynamically interact with these specific components of the tumor microenvironment and cause the immune escape, the angiogenesis, and the progression metastasis. So these markers are important to identify your tumor microenvironment. Okay, so some are the common markers like the T regulatory proteins, the FOXP3 is available, the M2 macrophages, which is CD163 is available, and the tumor-associated neutrophils can be estimated by the immunochemical markers. Neutrophil lymphocyte ratio can be calculated, and high CD8 T cell infiltration is also associated. So another important is the PD-L1, which express in your tumor cells. So identifying the PD-L1 immunohistochemistry is very important because you have the targeted immunotherapy as a part of the combination therapy. So this is your immunohistochemical marker for the PD-L1, which showed the membranous positivity. So now next is the molecular diagnosis. So this is, as I've already told you, that important for the category 3 and 4. This is the molecular landscape of the thyroid neoplasm, which shows the percentage of these mutations present in the specific thyroid nodules. So this is the heat map. And again, as initially we have performed the limited panel of the immunohistochemistry or the molecular profiling, but the well-differentiated carcinomas have evolved genetically. So you have multiple number of the mutations which are of interest in identifying the prognosis and diagnosis. Now coming to this is the timeline. I'll take just 2 minutes more. This is the timeline of the molecular technique evolution in the thyroid diagnosis. Initially, the gene mutation analysis will be performed, the single gene mutation, BRAF or PTC, RAS for follicular pattern, TERT for the aggressive behavior or the ATC. The second is the gene expression classifier panels, which include the FRMA gene expression classifiers. FRMA is a rule out model in which the RNA-based analysis or the NGS-based analysis has been done, and the thyrocyc V1, V2 has been applied. Now, advanced NGS has been last 4-5 years. Advanced NGS has been come into the picture, and the FRMA new model for XA expression atlas has been designed, and the thyrocyc V3, which is based on your DNA RNA panel. So this is a brief about the nodule 3 and 4. I've already told you that molecular testing is required, but because of the molecular landscape or the expansion of the genetic evolution, the 5 and 6 also suggested for the molecular sequencing. So this is just a preview of the report in which the suspicious of malignancy in the cytology and in genetic analysis, FRMA expression atlas, it will come into the ETV6 NTRK3 positive tumor mutation. So you can plan the therapy for the NTR therapy. Now, last 2-3 slides about the liquid biopsy, as this is the era of the non-invasive techniques. So liquid biopsy is a minimally invasive procedure. You can detect the tumor cells, the cancer cells, the tumor DNA, cell-free DNA in the bloodstream, and detect the mutations or the genetic alterations by performing the different techniques like the PCR and the NGS. So I'm not going into the details. We have some okay. So in summary, we have immunohistochemistry and immunocytochemical markers. The novel markers are second generation, the next generation markers, the tumor microenvironment, immunohistochemical markers, and the CD markers. We are in the molecular techniques, the single gene mutation, you have the multiplex PCR, you have the digital droplet PCR, the sequencing panels, which have this modifications, and the liquid biopsy, you have the tumor cells, cell-free DNA, and tumor DNA microparticles and the exosomes, which are the latest. And these are my references. I'm sorry for the expanding my presentation.
Okay, thank you for that. Very exhaustive from the pathology point of view, but we'll call Dr. Ambika Tandon, Assistant Professor in Endocrinology, to take on the next session, which is the use of thyroxine therapy for benign thyroid nodules. At the end of the last talk, if there are any questions from the audience, please be ready. We'll just take a couple here.
So at the outset, I'd like to thank the Department of Endocrine Surgery for giving me this opportunity. And today I'll be talking about thyroxine therapy for benign thyroid nodules. So we all know that benign thyroid nodules are very common. They are mostly asymptomatic. with the clinical concerns being cosmetic reasons, pressure symptoms, and to rule out the risk of malignancy. And we also know the common causes for it are MNGs, Hashimoto's thyroiditis, cysts, follicular adenomas, and HER3 cell adenomas. So at the beginning, I would like to present this data, which was a nationwide survey from America of 1,000 physicians. And to me, it was surprising to see that almost 1/4 of these doctors were using thyroid hormone therapy in suppressive doses for thyroid nodule management. And amongst this included 14% of the surveyed endocrinologists. So firstly, I'd be answering the question, can thyroxine suppressive therapy actually reduce nodule size? So the rationale for this therapy is that thyroxine therapy will lead to decrease in the TSH or suppression of TSH and hence thyroid atrophy. But this is not that simple. The importance of TSH in goiter formation varies with the cause of the goiter. So in regions with iodine deficiency or Hashimoto's thyroiditis, the increase in TSH secretion is the predominant cause of goiter. So giving thyroxine would reduce TSH and hence decrease the goiter size. But in thyroid nodules or sporadic non-toxic MNGs, the thyroid enlargement, we know it is caused by several growth factors, one of which is TSH. So thyroxine therapy alone wouldn't suffice to reduce clinically the nodule volume. Now I'll back this up with evidence from the literature. And there is a lot of literature on this topic. Most of the literature is old, but the results are very heterogeneous. And the heterogeneity in the results can be because of the population that was studied. Some regions we know would be iodine deficient, some would be iodine sufficient. Also, the population which was enrolled was heterogeneous. And the method which was used to assess the volume of the thyroid nodules was also very heterogeneous. So one of the oldest study was from the USA. This was published in 1987. It was a double-blinded RCT of 53 euthyroid patients with biopsy-confirmed colloid solitary thyroid nodules. They were given either levothyroxine at 3 micrograms per kg per day or placebo for 6 months. And the authors noted no significant decrease in nodule diameter or volume. Another study from Italy, they studied 83 euthyroid patients, again with the palpable STN. They gave levothyroxine at slightly lower doses of 2 micrograms per kg per day or placebo. They followed their patients up till 5 years, and at 5 years, they noted significant difference in nodule volume. But this difference was mainly because the group which was receiving placebo had increase in size of the nodule, whereas the group which was receiving levothyroxine had very slightly decrease in the size. However, the new nodule detection was more in the control group. And in a subgroup analysis, they also noted that nodule shrinkage was more frequent in patients who had complete TSH suppression. This was a study from France. They studied 123 patients with a single palpable benign nodule. This was an 18-month trial, and they adjusted the levothyroxine dose to a lower TSH level of less than 0.3. Again, they had similar results like the previous study with a decrease in small decrease in the nodule volume in the levothyroxine group and an increase in the placebo group. But they noted that there was a clinically relevant volume reduction of more than 50% in around 27% of patients who were receiving levothyroxine. A large multi-centric trial from Germany, they studied around 1,000 euthyroid patients, and they divided their participants into 4 groups. One received placebo, the other received only iodine, one received thyroxine, and another received thyroxine plus iodine combined therapy. And they noted that the nodule volume reduction was the greatest in the thyroxine plus iodine group, which was around 17.3% as compared to the placebo group. There is also literature which has studied that whether comparing thyroxine to other therapies. For benign thyroid nodules, we have other therapies other than surgery like percutaneous laser ablation. So this study from Italy compared levothyroxine therapy versus a single session of laser ablation for 12 months. And they observed that the group which received laser ablation had a very significant volume reduction, and there was no significant volume reduction in the levothyroxine group. Also, because I'll be talking later what are the adverse events of giving thyroxine in the suppressive doses. So in 2014, a group tried to study whether giving thyroxine in non-suppressive doses Like we give it to euthyroid patients, but in non-suppressive doses, would that be beneficial in reducing the nodule volume? So they studied around 361 euthyroid women, but we should note that this was not a randomized controlled trial. They gave them levothyroxine to obtain TSH in the range of 0.5 to 0.8, which would not be suppressed. And again, they saw a very mild decrease in the volume size in the levothyroxine group as compared to the placebo group. However, they noted that the mean annual increase of nodule volume was significantly minor in the levothyroxine group. What about the literature from India? From India, I could come across very few studies on this topic. One was published in 2010. This was just a prospective clinical trial where they studied 22 euthyroid patients with benign thyroid nodules. And they gave them 50 to 100 micrograms of levothyroxine to keep the TSH in the low normal range. The authors actually observed a reduction in the size of nodule in around 66% patients, but they did not mention to what extent the reduction was there. But they also mentioned that there was complete disappearance of the nodule seen in 6 patients. These differences could be because the region where this was studied could be an iodine deficient region. So we know in iodine deficient regions, it is more beneficial to give thyroxine in benign thyroid nodules. Another single center cohort study from India was published in 2021, where they studied 67 patients with benign goiters. Again, they gave 50 to 100 microgram levothyroxine. And in this study, they observed that there was a clinically detectable around 20 to 50% change in volume seen in 10% of the patients. Also, there have been multiple meta-analysis of these randomized control trials. To mention one of them, this was done in 2005. It included 9 randomized control trials. And in this, the authors noted that if we were to study the the relative risk of the number of subjects with more than 50% volume reduction, there was a significant decrease in the number of subjects with more than 50% volume reduction in the placebo group as compared to the levothyroxine group. The NNT obtained from this meta-analysis was 8. That means that to have a clinically meaningful reduction in the nodule size, 8 patients would be required to be treated for 1 patient to actually benefit from the treatment. So what we saw that thyroxine therapy actually does lead to some modest reduction in the nodule volume, then why not just use it? Because we know we will be suppressing the TSH levels for long terms, and long-term suppression of TSH levels, it has been very well studied that this is related with the increased cardiovascular risk in the form of atrial fibrillation. Even increased mortality has been seen. And obviously, there is a bone loss or osteoporosis, which is more pronounced in postmenopausal women. Other concerns could be the duration of treatment. How long will we continue to give this suppressive therapy? And whether if we withdraw the thyroxine therapy, what will be the behavior of the benign nodules? There's not much literature on this, but one study had seen that after withdrawing the thyroxine, the nodules actually start growing in size again. And also, is it clinically relevant to reduce the volume by around 15 to 25%, which is seen in most of the studies? Is it actually clinically relevant to reduce the volume by this extent of cytologically benign nodules? And as I mentioned before, the meta-analysis had shown that the number needed to treat was 8, which means that 8 subjects must be subjected to the risk of adverse events for 1 patient to actually benefit from it. Coming to what the guidelines say. So the 2015 ATA guideline on management of thyroid nodules, they do not recommend TSH suppression therapy because they say that the potential harm obviously outweighs the benefit for most patients. But they say that in patients who are in iodine deficient regions, iodine supplementation should be given. The 2023 ETA guidelines also say the same, that thyroid hormone treatment is not indicated in euthyroid individuals with nodular thyroid disease. So to conclude, I would say we have to maintain a fine balance. Although thyroxine therapy results in a modest reduction in the thyroid nodule volume, this is at the cost of the potential adverse events, which includes atrial arrhythmias and the reduced bone length. Thank you very much.
Thank you. That was interesting information for all of us and reinforces the fact that it is not indicated anymore as before. So next I call upon Dr. Sarah Idris, from the Department of Endocrine Surgery to talk on ablative techniques in thyroid nodules. Sorry, video.
A very good afternoon to everyone at PGES. I'm extremely disappointed to not be able to attend the meeting this time because of certain work commitments, which I was forced to quite literally perform. But at least I get to record this and send across my talk. Gaurav sir was right. I'm missing out on all the fun and the interaction between the colleagues and seniors. But I hope my luck is on my side next time. Without further ado, I begin with the task that I was given, which was to talk on ablative techniques in thyroid nodules. And we all know that in the current era, patients are preferring heat over surgery because minimally invasive thyroid ablative procedures have become very viable alternatives and have gained widespread acceptance as safe and effective procedures to reduce the size of the thyroid nodules and alleviate symptoms. The ablative techniques that are commonly being used these days are radiofrequency ablation, microwave ablation, laser ablation, and high-intensity focused ultrasound. Each of these cause thermal ablation by heat generation within the thyroid nodule, causing coagulative necrosis, cell death, and thereby reduction in the size or disappearance of the nodule itself. There are certain other techniques which are based on chemicals like ethanol, which cause direct tissue death, thereby leading to decrease in the size of nodules. And furthermore, are cryoablation and irreversible electroporation techniques, which are based on freezing of the tissue, leading to cell death. However, cryoablation and irreversible electroporation are not very much in use, and we do not have a lot of literature on their utility in thyroid nodules. The most frequently performed ones are radiofrequency ablation and microwave ablation. Coming to the indications of ablative procedures in thyroid nodules, we all know that TIRADS 1, 2, and 3 lesions or AFTNs in patients who are high-risk candidates for surgery or radioactive iodine ablation can very easily be subjected to ablative techniques. Even in malignancy, patients who have papillary microthyroid carcinoma or recurrent PTC having less than 3 lesions measuring less than 2 centimeters in size have easily been ablated using these techniques. Also, indeterminate nodules with negative molecular tests are being subjected to ablation. Although we do not have a lot of evidence available currently, and the guidelines don't recommend them usually, but there are reports that are coming up that indeterminate nodules can also be subjected to ablative procedures, provided their molecular tests are negative. So the contraindications, of course, are just the opposite. Indeterminate nodules with positive molecular tests, malignant thyroid nodules measuring more than 2 centimeters in size, and all those lesions which we are not able to visualize on ultrasound. The prerequisites that we need to keep in mind before we subject a patient to ablative procedures is, of course, a laryngoscopy and basal calcitonin as per the European Thyroid Association. Informed consent is extremely important in all patients because their expectations need to match our outcomes, and therefore a proper template of informed consent with all the information in the patient's language should be provided to the patient. This procedure can be done under local, regional, or general anesthesia, and I think that's the best part about it. Coming to the procedure, the patient lies supine on the table with the generator on the side and a grounding pad attached to the thigh or the calf, and the surgeon uses the electrode under ultrasound guidance, inserts it into the thyroid trans-isthmically, as is seen in this picture, and starts the ablation of the thyroid nodule after doing a hydrodissection with lignocaine or saline. Now, the ablation has to be done from distal to proximal or posterior part of the nodule to the anterior part. The probe needs to go along all the axis of the nodules and small ablative units are created by the active tip, which stays at a point for around 5 to 9 seconds and then moves proximally. This technique is called moving shot technique and it's incomplete ablation of the tumor. A post-procedural checklist should be maintained for all the patients and they should be observed for 30 to 60 minutes, after which they can easily be discharged with certain discharge instructions. This is one of the thyroid nodule that I ablated recently, and you can actually see the nodule being very distinct here, and the tumescent has been given in the area around the nodule. After ablation, the margins have become indistinct, and small ablative units can be easily appreciated in this ultrasound. After the procedure, the patient needs to be followed up at 3 months, 3 to 6 months, and at 12 months. At each follow-up, we need to assess clinical, biochemical, and sonographic parameters. The most important one being sonographic one, because the volume reduction rate of the thyroid nodule is the one that is the indicator of the success of your procedure. Oh, nobody would have performed these procedures had there not been evidence for their outcomes. The outcome that we look for after a thyroid nodule ablative procedure is the volume reduction, symptom and cosmetic improvement, the rate of complications post-procedure, the nodule regrowth, and additional treatment or sessions required. In cases of papillary microthyroid carcinoma or recurrent thyroid carcinoma, the tumor disappearance, the local recurrence, and lymph node metastasis become very, very important outcome indicators. This table here shows the volume reduction rate of radiofrequency ablation, which is in the tune of 76 to 99% for various kinds of nodules. Similarly, microwave ablation also is associated with 85% plus volume reduction rate. Laser ablation and high-intensity focused ultrasound have slightly decreased rates of volume reduction, but that is really not because of the procedure, but rather because of the fact that these procedures are performed in less number of patients and therefore we have less data. Zhu et al. Recently did a meta-analysis where he pooled the mean volume of reduction rate of all the thyroid ablative procedures during the 5-year follow-up period. And he found that at 6 months, 61.83% volume reduction was seen, which only increased to 81.43 at the end of 5 years, which is quite significant. Also, when compared with surgery, thermal ablation is not only associated with significantly decreased nodule volume, but it is also associated with lower postoperative complications in the form of hoarseness of voice or auditory injury and hypercalcemia, and also improved perioperative outcomes in the form of early discharge, early recovery, and also good quality of life. There was a preservation of thyroid function in 93% of patients undergoing thermal ablation as compared to 71% patients undergoing surgery, which is again a big thumbs up for ablative procedures. Even for tumor progression or recurrence-free survival, there was no difference between ablative procedures versus surgery, which gives a very good upper hand to thermal ablation as compared to surgery. Now, if you ask me which one of the thermal techniques is better than the other, then the evidence supports radiofrequency ablation as per the current guidelines because it has the highest volume reduction rate at both 1 and 12 months among the 4 treatment modalities of RFA, microwave, laser, and HIFU. A cumulative ranking analysis was done for all the procedures that are done for thyroid nodules, and it was seen that at 12 months, the radiofrequency ablation had the highest VRR, which was sustained up to 36 months. So the RFA had slight advantage in symptom relief, and the microwave had a slight advantage in aesthetic outcomes. But in cases of papillary thyroid microcarcinoma or recurrent thyroid carcinoma, Lee et al. Reported that microwave ablation had the lowest recurrence probability, but for minimizing the lymph node metastasis, radiofrequency ablation ranked the highest. So currently, radiofrequency ablation and microwave ablation are the bosses of thyroid ablation techniques. One may be better than the other in certain aspects, but overall, they are minimally invasive, they are safe and effective, they are comparable to surgery in well-selected patients or even better at times. And all the evidence that we have till now is in their favor. So the take-home message that I would like to give here is that we should select our patients carefully in whom we can perform these procedures safely and effectively. And I'm sure that this might very soon become the gold standard of management of thyroid nodules, provided we have a long-term follow-up. That is to be the long-term follow-up in our research. With that, I thank you, and that is my team at RML when we performed.
Okay, that brings us to the end of the session. Thank you, Sarah. And we can take any full 5 minutes for questions from the floor. So first, we had the talk on the new imaging modalities. Any questions or ask Dr. Vinita to comment on that?
To start the ball rolling, I don't see Dr. Tanya in the audience. So maybe Dr. Asmita can answer. So my question is related to your, she presented about contrast enhanced ultrasound. And every time she talked about it, she said that FNAC will not be required. I understand that your pathologist, of course, will remain there. But what I wanted to ask you on a lighter note is, what are the indications when it can help where FNAC will not be required and areas where FNAC will still be required?
Ma'am, when we see the lesions are well-defined, cystic, and we give the TIRADS 2 and 3, normally we not require a FNAC if lesion is having a features of TIRADS 4, that suspicious, high suspicious of malignancy. And TIRADS 5, definitely we will do the biopsy. So biopsy or FNAC, but in TIRADS 2 and TIRADS 3 lesions, we do not do the FNAC. And yes.
So there was presentation about the newer modalities like contrast enhanced ultrasound. Are you using any of them? And the elastography as well? Where would you use it, selectively or routinely?
In our institute, we are not using the contrast enhanced ultrasound, but we are using the ultrasound that based on the elastography. So we are having machine that we are routinely using the ultrasound elastography to differentiate the lesions. Basically, the role of elastography is come when we are clearly diagnosed. These are the BIRADS 1, 2, TIRADS, sorry for that. TIRADS 1, 2, and 3 lesions. Definitely we are clearly make on the baseline images. When the role comes, we have to differentiate TIRADS 4 or 5. Sometimes the features are combined and we are not able to differentiate. The role of elastography is come in those lesions to differentiate benign versus malignant. As on the baseline images, we can conventional easily define the TIRADS based on that different imaging features. But definitely the elastography help us in those cases where we are in the doubt. And a lot of studies are suggesting these are a non-invasive methods where we should definitely opt for that if we are available to avoid the FNAC. Still, we know the pathology is a gold standard.
Thank you, Dr. Asmita. So do we have any questions from the house related to the talk for nuclear medicine, pathology, and radiology? Then we move on to the clinical talks. Yeah. So my question was basically to Dr. Sarah, where she talked about the ablative techniques. I was wondering that after those, maybe a clinician, endocrine surgeon can answer. So after the ablative procedures, when you have it, when these patients go in for surgery, some of them will obviously go in for surgery if required. what are do we see any changes on histopathology, or can a histopathologist make out if these ablative procedures have been done on those nodules?
Okay, well, I can share one. The whole point is the case selection, and it is in a way the two talks came earlier. We tried suppressing nodules with thyroxine, and ablative techniques have probably taken over from that. Now the question is selection. First of all, is there a need to reduce it from the patient's point of view? And second, make sure that you're not dealing with a malignancy. Now, unfortunately, I've seen somebody come from another center who was not chosen right. It was 4.5 centimeter nodule, which had suspicious features. But because the FNA was non-diagnostic, they went ahead. And within 3 months had a recurrence of a malignant nodule, became even larger. So we had to go in and take it out. And you can imagine it is not an easy operation to do it post-ablation. So they found necrotic areas which are about 60% of the nodule, but 40% was still occupied by a large malignant tumor. So case selection is the most important thing here.
I have a question with the Dr. Neha. Ma'am, in the thyroid's lesion, we should go for FNSE or biopsy. Yeah, FNSE is still I mean, gold standard for the thyroid lesions.
For thyroid, FNC is the gold standard, or the screening test, or you can say the first test to be performed. Biopsy can be performed, but it has various complications. And in those cases, like in the anaplastic thyroid carcinomas or the polydifferentiated tumors, in which the surgery is not possible and they want some immunohistochemical markers, they perform the thyroid biopsies. We have some experience with the thyroid biopsies, but the first choice is a FNAC.
Actually, these lesions are highly vascular, and when we take the tissues, we have a lot of hemorrhage and hematoma along with the tissue, and that's why I ask you, we should prefer biopsy or not.
No,
Yes.
cytology is the best.
Okay, man. Thank you.
The biopsy has even more complications in thyroid.
If there are no more questions, we will end this session. Thank you, everybody, for participating.
Thank you all the chairpersons and speakers. We now move ahead with our next session, which brings us to primary hypoparathyroidism and its changing trends. May I invite the chairpersons, Dr. Vivek Agarwal, Dr. Shashi Moli, Dr. Anish Sharian, Dr. Shalik Moedu to preside over this session.
So, good afternoon, everybody. Our first talk by Dr. Sushil Gupta is deleted. So, we'll straight away invite our next speaker from overseas, Dr. Kichri from Sri Lanka. He'll be talking about focused parathyroidectomy, whether it's still the workhorse. So, I invite Dr. Kichri on the desk.
Very good afternoon to everybody. First of all, I must thank the organizing committee, especially Professor Gaurav Agrawal and my friend Sabha, to invite to this great institute and to this great country. Actually, I'm visiting for the first time. Right. So my topic that I was given is focused parathyroidectomy. Is it still the workhorse? I'm happy that a lot of international experts are here in this audience, including Australian New Zealand Association of Endocrine Surgeons. She also said during my break that she's happy about this talk. So before embarking on the lecture, I must thank these three people because I'm from Sri Lanka. Professor Vital and Professor Amit Agrawal and my teacher, Professor Ranil Fernando. Those three eminent people made very strong academic link between Sri Lanka and India, I would say endocrine surgically. So I hope everybody in this audience will do the same in next years. Because one thing is in parathyroid surgery, I think it is different from other countries to our region. So what I'm going to present here today, the data are not from our own data because we don't have big data. So all the data is from Western countries because numbers are very much limited in our setting. So I think we need to get together and make a database like you create one in UK because we see very much less number. We don't know the reason. So that is why I think Professor Rani Fernando say elusive parathyroidectomies, parathyroids in the our part of the country. So what is focused parathyroidism? Again, before going, I will quickly tell a very small story, epic, which you all know very well than me. Arjuna and Eye of the Bird, right? So one day, this guru wanted to test the focus of his students and their talents. So Guru Dronacharya make a trick that he hung a wooden bird on a tree and asked students to arrow at the right time. And then he asked then the students, each students, what you can see, my students. And one by one said, I can see the right eye as well as the left eye. And also I can see the tree and also the surrounding mountain. And then he asked Arjun, what you can see, my son? And he said, I can see only the right eye. He asked, what is the color of the bird? And he said, I can't see the color. I can see only the right eye. So I feel that this great story from Mahabharata is a little bit similar to the parathyroid. So, but the difference is about 80 to 85%, probably 90% of the cases are having only single target, single parathyroid. So the other about 15% has multiglandular disease. So as you know, we can offer the focused parathyroidectomy only in the single adenomas. So multigland disease, as you all know, can be due to hyperplasia or multiple adenomas. And rarely we do parathyroid carcinoma, about 1%. So our main target, therefore, we should know that the ability to focus, the technology to focus is the success of focused parathyroidectomy. So I will quickly go through these things which you will know. Ultrasound in our part of the world, especially in Sri Lanka, we're highly dependent on these things. So hypoechoic lesions with vascular pedicle, roughly around sensitivity. I'll go to the other one. Cystectomy B, the planar one we can do. And mostly we do maybe scan combined with SPECT CT. So has again about 85 to 90% sensitivity. So 4D CT, again, a very good one. The problem is the radiation dose. In Sri Lanka, actually, we in my center, I have only ultrasound scan and 100 slice CT machine. We don't have SESTIMIB, so most of the time we do 4D CTs. Okay, so our target, most of the hospitals, I think we do ultrasound first and detect it, and then we do the SPECT MIMI. It increases the sensitivity to a greater extent, but still not 100%. I mean, it can miss the cases, right? So if you're missing the cases, then we need to see whether the targeted or index gland we have removed. So if you're not, the problem is most of the time in parathyroid surgery, I think we target the case and we see a nice adenoma in the images, and we open the neck and we take the gland very happily, and we get a very psychological happiness by pulling it. It's a nice gland and show to the nurse, oh, see the gland, but we don't know whether other glands are whether functioning on abnormal or not. That is the most case for the failure. So in this case, intraoperative parathyroid monitoring is extremely important, because when you remove the gland, we know exactly we have removed the index gland. So what we do is we take the blood as a baseline before the surgery, before remove the gland, and then the 5 minutes and 10 minutes and maybe 15 minutes. So usually 50% of drastic reduction occur within 5 minutes. So that is called Miami criteria. So see, if you remove the index gland and if it is not dropping to 50%, and then we know another gland is functioning. So here it is, one advantage is that we can take blood from the left jugular and the right jugular, and we can see which side is higher, and then we can go for the not the focus exploration, but we can search for the other gland. So it is important. And the bilateral neck exploration was actually is the opponent of this one, focused parathyroidectomy. So was the gold standard before 1990. However, now I think the focused parathyroidectomy is becoming preferred in the centers where the technology is good. So the question that we need to ask, if we are going toward the focused parathyroidectomy, does the morbidity of bilateral neck exploration is more than focused parathyroidectomy? So this is what I said, actually, Euclid's database from UK, Bates database. So where actually at the time of the study, it had 28,000 cases. In this study, they have included 22,000, almost 22,000 cases, right? So that is the importance of having a large database, which we can't get because of the lack of numbers. So if you see here, focused parathyroidectomy, overall complications are more in bilateral exploration, but it's mostly due to hypocalcemia. But other complications in both groups are almost same, according to this study, right? So all other complications are almost same. So even recurrent laryngeal injury is same, right? It's a large database. So then the other thing we need to think about, the cure rate, whether the cure rate of bilateral neck exploration is better or inferior than the focal parathyroidectomy. So then we should know what is cure, what is defined as a cure in primary hyperparathyroidism. It's, as you all know, it is a sustained normal calcemia for at least 6 months after surgery is probably the currently definition. So at that study, again, conclude that normal calcemia rate, once you've done the image, concordant image, and then do the surgery, it's almost similar to focused parathyroidectomy versus bilateral exploration, although statistically significant slightly, but the percentages wise, it's almost similar in that large group of study. So we talked about 6 months, up to 6 months, that is the cure of our intention. So, but what about after 6 months, right? So this study I think North, is from the Australia, no? I think this is a meta-analysis taken more than 19 studies, had patient total of 12,743, and they compared bilateral neck exploration versus focal parathyroidectomy had similar recurrence and the similar persistence and similar reoperation rate, but similar to the previous study, the overall complication rate was higher in bilateral neck exploration, and focus group had a short operative time. So the question is, focus parathyroidism is still the workhorse? I think yes, with qualification. The focus parathyroidectomy remains the preferred approach. Indeed, the workhorse for well-localized single gland primary hyperparathyroidism. It offers comparable cure rate to bilateral neck exploration. It reduces the morbidity and small incision. Feasibility, probably a feasibility as an outpatient procedure. And of course, enhance the patient's satisfaction in many instances. It is success yet its success hinges on high quality operative localization, use of IPTH, and as I said, a skilled surgeon like Arjun. So I'm not going to discuss these things where the indicates. I later noted that there's another lecture on bilateral neck exploration, but I would like to tell about this one. Focused parathyroidectomy is not possible when there's no facilities. Like in my case, although I know that focused parathyroidism is better with good technology, I usually tend to do bilateral neck exploration because I can't fail. If I fail, I have to get the patient back and operate. So it's a sort of waste of resource. So if you get all this data, the difference is slight. So therefore, I usually do in Sri Lanka bilateral neck. Not that because it's not good, it's because we have limited resources. So in conclusion, focused parathyroidectomy continues to hold a central place in managing primary hyperparathyroidism with proper imaging, monitoring, and expertise. It remains a low morbidity, high efficacy procedure, and truly the workhorse for the right patient. Thank you. Yeah,
Excellent lecture, sir. Just a comment for like our Dronacharya of today for parathyroid. There are slight difference of difference in teaching. They say don't only eye on the parathyroid, but keep eye on the surrounding important structures like recurrent laryngeal nerve. And if you happen to see any thyroid nodule, do FNA that. If you can peep into the close by another gland, superior or inferior, you can do that also.
Good comment, actually. So the problem is that now if you get the data, so you see the problem of bilateral neck exploration was the more hypocalcemia. So that is because we tend to look for more. If you're going to look for more, what we do is we remove more gland. So what we do is we identify the gland from the eye. So if we see the 4 glands and we arbitrarily think, oh, this is abnormal, and we'll remove that one as well. So therefore, I would say sometimes it can cause over surgery. That is why that, and so I mean that I taken this story for
No debate about that. That was just on a lighter note to look at the recurrent nerve also
Yes,
going along that.
Exactly.
So as you mentioned, the data which shows more complications of hypocalcemia. Were these cases who had undergone? These were the cases which underwent subtotal parathyroidectomy or single gland after a neck exploration.
Yeah.
Or
you.
they were, converted from focus to neck exploration or subtotal after failure of fall of IOPTH.
Yeah, these are actually the database from the UK. So British Association Endocrine Surgeons, there's a UCRED database where they have focused parathyroid patients as well as bilateral neck exploration patient. So they have included all this data, and their study actually suggested that there are a lot of missing data. But I think to compare these two, I think the quality of data must be okay. Yeah.
If they included the cases where they are done subtotal parathyroidectomy, then there is a obvious logical conclusion that they will have post-operative hypocalcemia more likely to have. So that doesn't
I think you mean
I mean add to the advantage of focus, because that is the inherent issue with the procedure you are doing, the pathology you are tackling.
Yeah.
So I mean, just a comment.
Just wanted to know. So, do you have IOPTH available at your center?
And not actually.
Not actually.
And
Yeah,
actually,
that-
I want to say, I did a fellowship in Oxford University. They also didn't do. I don't know nowadays. I did 2019. They also didn't do. They actually did also foreground exploration. Because I think it's a very good adjunct if you have.
Yeah. So you do it bilateral neck exploration in all the
Bilateral
cases.
neck exploration.
Right. Okay. Thank you. Any from the floor? Thank you.
Thank you so much.
So next, I invite our Dr. Pradeep sir for role of BNA in 2025.
Thank you very much. At first, I should thank the organizers, Gaurav Agarwal sir and his team for this opportunity. Dr. Sabha asked me to talk about bilateral neck exploration in 2025. I think I will do justice to this. I'll put forward my views on this. First, I'll start with one or two cases. Of course, these cases are a little bit old, a few years old, because after that, approaches have changed. So this is a 55-year-old patient who had come for a health checkup from UAE. Many of our patients are from Gulf. They come for health checkups to Kerala. So the calcium was high, phosphorus was high, and PTH was high, no normal vitamin D, obviously primary hyperparathyroidism. So she underwent an ultrasound of the neck, which showed a thyroid nodule, but no parathyroid. And this is a MIBI scan, which is negative. So few years back, our approaches have been to do bilateral neck exploration in that patient. So in this patient, she underwent neck exploration. You can see that the normal parathyroids can be seen on one side. And after that, we went for the next other side, and you can see that the parathyroid gland is identified. It's about 1.6 centimeters, and that is removed. And PTH confirms that, intraoperative PTH confirms that the surgery is complete. Another patient, a 66-year-old lady, who has been diagnosed as primary hyperparathyroidism for about a year on calcium mimetics with some symptoms of PHPT. You can see the calcium is high, phosphorus is low, PTH is high. And this is the MIBI scan, which is showing that it is negative. Ultrasound shows that there is a nodularity in the thyroid, but no parathyroid is detected. This is a CT scan of that patient, again negative. So we explored both sides and found out the superior parathyroid, which is enlarged. And as confirmed by PTH, intraoperative PTH, it shows that the surgery is complete. So we looked at our patient's profile over the past few years, since I started practicing in 2008 after the MCH. Over the years, I found out that our patients, we are getting more of asymptomatic cases. And to the tune of 40%, now we have asymptomatic patients. And in this asymptomatic patients, the localization studies are actually negative. in about, you get positive studies only about 25% of the ultrasounds and 17% of the maybe rest are all negative. And during our surgery, we found that this localization actually has been falsely negative in ultrasound and falsely negative in maybe scans. In fact, the tumor is there, but only thing is that it has not been picked up. And you should also be lucky to have a good sonologist, because the sonologist can pick your lesion if they are doing it routinely. So not localized and routine imaging, what should you do? Now its trend has changed. You do more localizations. And I personally feel comfortable in doing more localization study so that you are not, during the surgery, you don't have to spend much of your adrenaline. So now we have the 4D CT, as our previous speaker has mentioned. This is a patient where the MEBI and ultrasound are negative, and you can see that the parathyroid is located in the pre-aortic region in the superior mediastinum. And another patient who had a choline PET, which showed that it is positive, which has been missed on MEBI and ultrasound. So you can avoid doing bilateral exploration by adding on these investigations. So basically, the surgical approach in a patient with primary hyperparathyroidism depends on whether you are dealing with a genetic disease or whether it is localized or not. So the localized part has already been dealt with. So if you have a genetic disease and or it is non-localized, you do the conventional exploration. That is the 4-gland exploration. And if you find during exploration that all other 3 glands are suppressed, you can do an adenoma excision and then come out. But if there is a genetic disease, in certain cases, you can come out with an adenoma excision. Otherwise, you have to do a subtotal parathyroidectomy or a total parathyroidectomy with autotransplantation. So these are the genetic disease, the spectrum of disease, which I'm sure all of you know, and which you are likely to deal with when you deal with a primary hyperparathyroidism. Bilateral neck exploration, you definitely need in certain cases. That is familial hyperparathyroidism and renal hyperparathyroidism. So this is one of the child which we operated, a 14-month-old child with failure to thrive. You see the calcium was 28, PTH high, maybe an ultrasound negative. And during the exploration, 4-gland exploration, you can see all the 4 parathyroids can be identified, and it was removed. And this is how the PTH has behaved. After the 4th gland excision, PTH has come down to normal, 13, and calcium, post-operative calcium, so you can see up to 6th post-operative day, it has fallen. This is another case where you have to do 4-gland exploration. This gentleman had presented with symptoms of hypercalcemia. You can see that there is the typical collagenoma seen. Prolactin is high, PTH is high, calcium high, phosphorus low. So he is having MEN1. So such patient, you have to do the 4-gland exploration. And in this patient underwent 4-gland exploration, total parathyroidectomy and autotransplantation to the left forearm. So to do a successful bilateral exploration, you should have certain adjuvants with you, like the intraoperative PTH, frozen sections, intraoperative gamma probes, in certain cases, intraoperative ultrasound also. In renal hyperparathyroidism, we do bilateral neck exploration. I will not go into the indications, which you are all well aware of. So there, the preferred procedure will be a total parathyroidectomy with autotransplant, or subtotal parathyroidectomy, or total parathyroidectomy alone without any autotransplant, depends on the institutes. And now, as Dr. Amit Agarwal was mentioning about autofluorescence, I think this is one which can be applied and seen when you do a bilateral neck exploration, when you have the machine with you. And it's an excellent way to identify the parathyroid, especially the non-enlarged one. You have the probe-based as well as the imaging-based autofluorescence machines. The fluo beam, it's based on the principle that autofluorescence is maximum for the parathyroid tissue. If you look at the tissues in the neck, the thyroid, parathyroid, muscle, fat, and trachea, the most autofluorescence is for the parathyroid. So I would conclude by saying that bilateral neck exploration has a definite role in the management of primary hyperparathyroidism. And especially when you get cases where you find that the preoperative localizations have been falsely positive, and you go and start exploring, start a focused one, and you find that it's all negative. you have to convert to bilateral neck explosions. So thank you. Thank you very much.
Thank you, Dr. Pradeep, for bringing in clarity of when to explore bilaterally. Any questions from the house?
Sir, great talk actually. And you said I wanted you to talk on that. I thought in this scenario of normocalcemic, normohormonal PHPT also now coming in, and as you rightly pointed out, there can be like discordant. Like we saw something on a PET scan or a 4D-CT went in. So very important point of like converting into bilateral neck exploration when you are not comfortably finding that enlarged gland on focus parathyroidectomy. That is a very important point. On the other side, do you use when doing bilateral neck exploration PTH also? First question. And the second question is, like in normohormonal PHPT, what criteria for intraoperative PTH monitoring?
In bilateral neck exploration, we use intraoperative PTH, especially even in the renal one, the MEN one, every case we use. And it's actually a guide. There may be literature showing that this is not very helpful in MEN and all those things, but it gives you a path to work on. Whereas in hormonal, it is tricky. You cannot use it. So you may say that this proportion decrease or that proportion decrease. That's all subjective. You cannot use it.
Sir, two questions. One is when we are doing bilateral neck exploration, and of course, in today's era, we have a lot of imaging. In spite of that, if there is an indication, do you go ahead with surgery? If yes, if all the 4 parathyroids are looking normal, what will you do? This is the first question.
Okay, so you have done imaging, it is not picked up the lesion. You have done the 4-gland exploration, you're looking and you find that all the 4 parathyroids are normal.
But there is a hypercalcemia.
And you are sure about your biochemical diagnosis, like primary hyperparathyroidism, there is no doubt. Then you should look for supernumerary glands. You look at the ectopic sites. You can look into the carotid sheath, the conventional routine exploration, all the areas you can look at. And after that, probably that is an area where you should stop and then re-evaluate the patient later on.
Okay. And any role of, as you said, IJV sampling for PTH?
I have personally not done it.
Okay.
I have not done it. To localize the
To
site.
localize the site.
No, I personally not done it.
Okay. And one more thing, as in the 14-month-old baby, so all 4 glands were removed, if I'm not wrong. Since we cannot label it as early MEN because they'll have to be clinically progressing that. So 2 things, was auto transplantation done? And
No,
second,
not done.
was thymectomy done? Thymectomy
Thymectomy was not done.
was also
You
not
can
done.
see the PTH has fallen so much in that case. I didn't go for a thymectomy in that patient. Second thing is that there was no auto transplantation done in the patient. The patient is on calcium and rocatrol supplementation.
Thank you.
Pradeep, just 2 questions if I can. Lovely talk as usual. One is, it is interesting to see that 40% of your patients are asymptomatic. Do you think that's because of the population that is coming from UAE that you're managing? Second is, do you still auto transplant to the forearm or have you changed to the neck?
The patient profile, we do get patients from Gulf for health checkups and all. But the data which I mentioned is actually more of our patients, not their data. And that includes also data from Andhra Pradesh, where I was working earlier for about 5 years. That data is also there. So initial years data, initially in the 2008 period, it was 100% symptomatic. After that, there are a lot of asymptomatic patients. So it includes Andhra patients also. And what is the second one? Auto transplantation. Yeah, auto transplantation I do in familial hyperparathyroidism onto the forearm, not in the neck.
I think if no more questions, we invite the next speaker, Dr. Rohit Anthony. He'll talk on molecular test for parathyroid disorders.
Yeah, good afternoon, everyone. At the outset, I wish to thank the organizing committee members, especially Professor Gaurav and Professor Sabha, who have invited me to give a talk on molecular test for parathyroid disorders. So basically, in this talk, what I'll be introducing is as a complement to biochemical and radiological and detection of parathyroid abnormalities, how the genetic tests are evolving to be a supplementary route for diagnosing and maybe offer prognostic value for parathyroid disorders. So just a brief introduction. Everybody here knows that its parathyroid glands secrete PTH is necessary for calcium regulation. It has implication in bone health and neuromuscular and metabolic balance. Disorders of parathyroid glands are basically hyperparathyroidism, which are basically because of increased PTH causing hypercalcemia, and many of the hyperparathyroidism causes are because of the parathyroid tumors, which can be adenomas, men, or carcinomas. And hypoparathyroidism basically results from inadequate PTH, which causes low calcium and muscle spasm. So why is the need? There's a need for clinical for diagnosis of parathyroid abnormalities. This is because of importance of accurate diagnosis help in for the effective treatment of the disorders. It helps in personalized treatment plan, and it basically prevents the complication which can happen to the patients later. So the traditional diagnostic assays for the diagnosing parathyroid abnormalities are basically serum calcium testing, parathyroid hormone assays, and the phosphate measurements, which give you an idea of a hypo and hyperparathyroidism. Beside biochemical assays, imaging technologies also help in diagnosing the lesions in parathyroid, basically most of the parathyroid cancers. And ultrasound imaging, BV scan and CT scan are the most commonly used radiological assays to test parathyroid abnormalities in the for parathyroid cancer detection. Having said that, more of these biochemical assays and radiological assays are very important for detection of parathyroid abnormalities, but they have limited sensitivity and specificities. There is a risk of misdiagnosis, and incomplete lesion localization can also be there in using these techniques. So here comes the role of molecular testing for parathyroid diseases. And this basically is based on the rationale that there's a genetic cause for many of the parathyroid abnormalities, and detecting the gene mutations can help you to complement your or supplement your already existing biochemical and radiological diagnostic assays. So if you see primary hyperparathyroidism, it can be sporadic and heritable. And in sporadic, parathyroid adenomas and carcinomas are common, and which have been shown to have known molecular gene signatures. And there is a mutation in genes which are responsible for the occurrence of these tumors. In the heritable hyperparathyroidism, syndromic and syndromic is basically because of the multiple endocrine neoplasia, and HPT, JT abnormalities in which specific genes have been implicated to have mutations, either inactivating or activating mutations. Non-syndromic types of primary hyperparathyroidism include FHH, type 1 FHH, type 2 and 3, FIHP, and NHHPT, which also are linked to mutations in genes. So just to give you a brief account of various gene mutations which are responsible for these abnormalities. So the most common is the multiple endocrine neoplasia type 1, which is basically a mutation in the menin protein coding gene, and with 100% penetrance, and progression to malignancy does not seem to be a prerogative in this case. In MEN2, basically, is the mutation in C-RED gene, and 20 to 30% of HPT in MEN2A, and basically or hyperplasia, adenomas, or in combination. And 25% of the patient developing clinical signs of the disease, and 50% of the patients who develop the parathyroid tumors, hypercalcemia is not observed. Now, hyperparathyroidism, jaw tumor syndrome is associated with inactivating mutation in CDC73 gene. This is a tumor suppressor gene, and mutation in this gene has been shown to cause this abnormalities. And calcium sensing receptor mutations have been detected in familial isolated hyperparathyroidism. And many of these mutations have been shown to be causative because in animal models of these diseases, they do develop diseases which are similar to human conditions. So these are well-known mutations which are causative in nature. So beside the well-established genes which have been implicated in hyperparathyroidism and tumor arising in parathyroid gland, the one in the block, you can see in the block, these bold blocks are the one which have been proven to be regulating cancer development. And beside them, there are many other genes which have been shown like PI3 kinase mutation, beta-catenin Wnt pathways, and cyclin D1, and many of the histone methyltransferase have also been shown to have mutated in the patients developing parathyroid tumors, especially parathyroid carcinoma and adenomas. But these have not been validated in animal models and other ex vivo and cell line system to show that these are positive and not associative in nature. Beside hyperparathyroidism, if you see the overview of familial hypocalciuric hypercalcemia cases, they are also associated with mutation in FHH1. There is a mutation in calcium sensing receptor gene. In FHH2, there is a inactivating mutation of GNA11 gene, and in FHH3, there is inactivating mutation in AP2S1 gene in the 19th chromosome. So, so you can see there is a wide range of mutations which are responsible for purely hyperparathyroid phenotype and also abnormalities in calcium metabolism. For example, in this FHH syndrome. Now, after looking at hyperparathyroidism, what about hypoparathyroidism? So hypoparathyroidism, you know, can be because of many reasons. One is because acquired of nature, because of pre-existing surgeries of the neck. It could be autoimmune hypoparathyroidism, congenital hypoparathyroidism, and familial isolated hypoparathyroidism. So autoimmune, congenital, and familial isolated hyperparathyroidism have been associated with mutation in certain gene types. For example, in familial isolated hypoparathyroidism, there have been known mutation in calcium sensing receptor gene, and in hypoparathyroidism with syndromic features like DeGeorge syndrome and in Kenny-Caffey syndrome, there have been mutations noted in FM111A gene. So there's a predisposition to develop these syndrome if you have mutations in these genes. Especially there have been some mitochondrial gene defects also seen in cases of hyperparathyroidism due to metabolic diseases. And they have been, which can cause long chain hydroxyacyl coenzyme A dehydrogenase deficiency and has been associated with cases of hyperparathyroidism. In case of autoimmune hyperparathyroidism, basically, there are mutation observed in ARE genes and also in calcium sensing receptor genes, which have been shown to increase autoimmune manifestation in hypoparathyroidism. Now, what are the different assays and techniques which can be used to detect gene mutation in parathyroid abnormalities? So basically, instruments which are required to detect these are either polymerase chain reaction, PCR-based methods, whole genome sequencing using next generation sequencing techniques, which gives you basically a more comprehensive genetic profile, and also a fish which is frozen in situ hybridization, which can let you know the rearrangement and deletion in the chromosomes. And this can go side by side with your regular biochemical analysis of parathyroidism. What are the advantage over the traditional methods? Basically, it has more improved sensitivity and specificity, and over the traditional biochemical assays, you can do early detection. So even before even before the syndrome has starting to show clinical feature, you can detect any changes, mutation in the genes, and basically it has even more value as a prognostic and for prognostic value, because it can also tell you that most probably if a person has a mutation in this gene, how the disease will, the outcome, what will be the prognostic outcome. So beside being only a diagnostic tool, it also has a prognostic outcome. And clinical application of using molecular test in in parathyroid abnormality is because molecular testing gives you diagnosing hereditary parathyroid abnormalities, which is not possible with biochemical assays, and it helps in early diagnosis benefit, and especially family screening, because family screening helps you detect hereditary condition in relatives, enabling preventive healthcare measures. It also helps basically surgeons to know that what would be the outcome of a cancer growth in the parathyroid gland, whether it could be a malignant or a benign state, and also whether the precise extent of surgical dissection will improve the effectiveness and reduce risk because of the gene signature there in the genes. So challenges still, it's an upcoming area of diagnostics in parathyroid treatment, and basically the challenges are the cost barrier. This expensive genetic testing is expensive, especially if going for NGS. Accessibility, not all labs are equipped with molecular equipments to do molecular testing, and it needs expertise of specialized people who know and to interpret molecular test data. So to conclude, molecular testing and gene-based testing of parathyroid diseases are basically helping to increase the diagnostic accuracy for better patient outcome. And also it raises a possibility of personalized patient care using gene signatures in patients. Thanks.
Thank you, sir, for excellent lecture. Just one question. Do we have any recommendation for any actionable mutation for patient presenting with primary hyperparathyroidism only?
So it depends if it's a hyperparathyroid, it's a cancer. If there's an imaging technique is showing there's a possibility of men or adenomas, then some of the gene mutations can be detected to tell whether it is which will progress to a malignant state or it will be a benign state only. And so that is what people are generally using it for. It's not still going in the routine testing at present, at least not in our institute. But these are some considerations which are going on.
Any questions from Dr. Gyan?
Excellent talk, Rohit. So just I want to know what is the effect of aging on this hypoparathyroidism?
Aging.
Aging, yes. Do you have any effect of calcium sensing receptor of aging and other things?
Not sure, Sam. Not sure about that.
Okay. So according to literature, there is a sensitivity of the receptor is reduced after the aging. So if you have any research on that or any publications? Not sure, sir.
Not very much sure. Unless it's related to the vitamin D sensitivity and things, then definitely aging will have an effect on that. Yeah.
Okay. Thank you so much.
Thank you for such enlightening session. Now I invite Dr. Sapna for interesting case snippets. So I think those who are a little dozing off can wake up. It will be more interesting.
Good morning, all. Thank you, the entire organizing team, for inviting me. I think we have learned enough about parathyroids in this session, and let's see some cases. So the first case is a stone concert. So it was a 45-year-old premenopausal lady. She was a known hypothyroid patient. She presented with complaints of recurrent renal stones, 5 to 6 years history, on conservative treatment until April 2024 when she underwent a PCNL. Now, in July 25, she presented with complaints of severe pain abdomen, basically symptoms of urinary tract infection. Investigations revealed that creatinine was elevated and all the other investigations suggestive of PTH-dependent hypercalcemia, basically primary hyperpara. USG abdomen revealed contracted right kidney with a small calculus causing hydronephrosis on the right side, and the left kidney showed features of pyelonephritis. NCCT KUB was done and it also confirmed the features. So she was started on antibiotics and calcitonin for her calcium, which was 13.1. Thyroxine dose was increased because her TSH was 22. And after this conservative symptomatic treatment, she was discharged after a week. And within 3 to 4 days of discharge, she developed severe epigastric and right hypochondriac pain. I hope you have noted in the last USG, the gallbladder was normal. So she presented she developed severe epigastric and right hypochondriac pain. And the USG now showed dilated CBD with GB sludge and choledocholithesis. And her liver functions were markedly deranged with SGPT, SGOT almost thousands. So now this is the kidney and the gallbladder. Bhai dard tu de raha tha ya main? So she underwent ERCP and there were GB stones, a dilated CBD. But there were no stones in the GVD. Probably the stones had passed out till then and a stent was placed. And now coming back to a hyperpara, as soon as the LFT improved, she was referred to the endocrinology sciences. We started the localizing studies. USG showed a small right inferior parathyroid adenoma. The CT also The CT also, 4D CT showed a right inferior parathyroid adenoma. You can see this over here. Cesta maybe 4D CT, all were suggestive of right inferior parathyroid adenoma. Her calcium levels were stabilized with calcitonin and fluids. And I did a focused right inferior parathyroidectomy. It was a 2.6 into 1.6 centimeter right inferior parathyroid adenoma. IOPTH showed more than 50% drop, but I was not very happy with the post-excision 20 minutes level, which was 202. Post-operatively, calcium dropped, and I also repeated a PTH, which was 14. So now this was something which it was a relief. Histopathology was a parathyroid adenoma. Coming to the second case, 73-year-old lady, a diagnosed case of CLL on treatment. She was on ibrutinib for 3 years, since 3 years, hypothyroid. She presented with complaints of altered sensorium, loss of appetite, bilateral red eyes, generalized weakness, and severe headache. As she was being treated for her CLL, she was hospitalized under the medical oncology department and evaluated. Other parameters were normal. Her calcium was high. Her PTH was also high. And urine showed your pus cells. So she was labeled as a case of metabolic encephalopathy because of hypercalcemia and UTI and conjunctivitis. She was treated symptomatically. So to my surprise, no imaging was done in this lady, 73-year-old lady. Generally, the physicians, the first thing they do is an MRI brain or something like that, but nothing was done. She was given zoledronic acid and discharged.
And after 15 days, she presented to us again with altered sensorium and pain abdomen, which is mild pain of abdomen. The calcium was normal, considering she was given zolindronate. PTH was high. There was leukocytosis. So obviously altered sensorium and neurology opinion was taken. They advised for an NCCT brain, which was normal. And they also considered that it was metabolic encephalopathy, considering her calcium levels were normal now and all her other electrolytes, that is sodium and potassium, were also normal. So they also considered it as metabolic encephalopathy. Medical oncology opinion was taken and they stopped ibrutinib. So we went ahead with the localizing studies. Now in this, the CT showed a 3.5 centimeter adenoma. How is it? I can't see it. Okay, this is the one. 3.5 centimeter right superior parathyroid adenoma. In this picture, you can see it was behind the esophagus, behind the cricoarytenoid joint, and located very superiorly. Again, you can see here. This was the adenoma. Cesta may be also suggestive of right superior parathyroid adenoma. So we planned her for a focused surgery, but considering her age and comorbidities, she was a high risk, explained to the patients. But just before the day surgery, she developed severe right hypochondriac pain. And because of that, she again went, she was little altered, but she was responding to commands. So again, all the references were taken and CTs were done. Like basically she had a CT thorax, CT abdomen, everything for the anesthetist. And USG and CT was done. It showed minimal fluid collection and everything turned out to be fine except for moderate pleural effusion on the right side. So that could be the reason for her hypochondriac pain. So after a few days, we took her for a surgery, but this time I did it under a superficial cervical block. I was a 3.5 centimeters right superior parathyroid adenoma. The IUPTH was not satisfactory, but since it was done under superficial block, I did not wait for the reports. She was shifted to ward and I repeated the PTH after 24 hours, and to my satisfaction, it was 55. Her calcium dropped to 8 and histopathology was parathyroid adenoma. The third case, she was a 45-year postmenopausal lady presented with constipation, knee pains, vomiting of around 1 month duration. She was a known hypothyroid patient. She gave a history of recurrent renal stones, 3 episodes in 6 years. So on routine investigation, PTH dependent hypercalcemia. PTH calcium was not very high. So we evaluated, first a sonography was done, suggestive of a small right inferior parathyroid adenoma. Cesta may be again right inferior parathyroid adenoma. 4D CT showed a well-defined nodular lesion. It was a bilobe lesion located in the paratracheal location, likely right. See, I've already marked it. Right, likely right inferior parathyroid adenoma. But in this case, you can see the anterior part is well enhancing, but the posterior part is not enhancing. But the entire part was the adenoma, and both the thyroid lobes were grossly atrophied. So a diagnosis of PHPT, plan for focused parathyroidectomy. So during surgery, it was a 2 into 2 centimeter parathyroid adenoma located in the right inferior, located in the right paratracheal location, but far from thyroid because the thyroid was grossly atrophied. The anterior part was very characteristic of a parathyroid adenoma, but the adenoma was going into the prevertebral plane and the posterior part was grayish white with few adhesions into the prevertebral plane. So I had a high suspicion of malignancy. I sent it for frozen section. Parathyroid tissue was identified and there were numerous atypical cells. So possibility of parathyroid carcinoma cannot be ruled out is what my pathologist told me. The PTH was also sent simultaneously. We did show a more than 50% drop, but obviously not very significant. So based on the frozen section biopsy, I removed the thyroid, which was grossly atrophied because of Hashimoto's thyroiditis, probably. And I'm not sure in this case was an en bloc resection possible because the parathyroid and thyroid were not connected at all. Post-operatively, she was fine. Calcium's dropped. Because the PTH were not significant, I repeated the PTH. Post-operative day 2 was 12. The final histopathology, it was an encapsulated tumor, but showed severe nuclear atypia, irregular chromatin, and prominent nucleoli. The cells were infiltrating the capsule and the fat, but the lymphovascular invasion was equivocal. So again, we were left midway. So they gave a diagnosis possibility of parathyroid carcinoma or atypical parathyroid tumor. So the specimen was further subjected for CD34 and that came out to be negative, and the final diagnosis of atypical parathyroid adenoma was given. She's doing fine now. In fact, I just got a call from the relative that she's having mild pains and aches. Her calcium is fine. She's not on any supplements, but PTH is on the higher side. Case 4. It was a 50-year postmenopausal lady, a known case of OCD on treatment with multiple antidepressants, antipsychotics, and anxiolytics. She presented with complaints of right leg pain, low-grade fever, headache of 2 months duration, and chest pain, dyspnea on exertion, decreased appetite, nausea, vomiting, and constipation of 3 to 5 days. She was evaluated. Majority of the investigations were normal. She was given some symptomatic treatment elsewhere. She was the ECG showed features of sick sinus syndrome, and she was discharged. Again, she was hospitalized with similar complaints, and there she was diagnosed as junctional bradycardia and discharged again. And as soon as she goes home, the symptoms were worsened. Now she went to a different city where she was, and on that there the total leukocyte count was elevated. TROP-I was positive, CPK-MB was very high. Creat started deteriorating. Sodium, potassium were also on the lower side. Urine showed infections. 2D echo also showed changes. So a diagnosis of UTI, sepsis with AKI and dyselectrolytemia was made, and she was given symptomatic treatment. Now, finally, they considered calcium as an electrolyte, and after 2 months of calcium was done, which came out to be 19.17. PTH was around more than 1500. On one fine day, she went unconscious, her blood pressure fell, and she needed ventilatory support. HRCT was also done, which showed ground glass suggestive of pulmonary edema. So for her PTH and calcium, she was started on cinacalcet, calcitonin, and gradual improvement was done, and she was discharged in a stable condition with calcium 7.82. Finally, she came to the endocrinology department. The symptoms were better, but she still had low-grade fever and bilateral lower limb weakness this time. Creat was on the higher side. On examination, she was irritable with decreased power and tone in both the lower limbs. PTH was high. Neurology suggested nerve conduction studies, in which was suggestive of metabolic myopathy or rhabdomyolysis. We did the localization study. System EV was suggestive of a left superior parathyroid adenoma. However, 4D-CT was not sure. It just showed a small nodule close in the thyroid, but there was arterial enhancement, but the origin was not clear. But 4D-CT also showed filling defects in the right and the left pulmonary arteries, suggestive of pulmonary thromboembolism, which was confirmed on CT pulmonary angio. And then a Doppler was done of lower limbs, and just showed DVT. Now, I don't know why, but the endocrinologist got a USG guided FNAC from that suspicious nodule, and it definitely confirmed that it was a parathyroid. So we planned for a superior parathyroid adenoma excision, focus surgery, but intraoperatively we found 182 centimeter grayish white nodule just lateral to the mid pole of the left thyroid, invading the thyroid lobe. And there was no other parathyroid lesion or adenoma seen on the left side. Considering the grayish white nature, high suspicion of carcinoma was done. And since it was invading the thyroid, left hemithyroidectomy and a left CCLND was done. The adenoma was, the lesion was confirmed as a parathyroid carcinoma on frozen section. IOPTS showed a significant fall. Post-operatively, it was she was fine, uneventful. Histopathology confirmed parathyroid carcinoma, but it was a R0 resection, so no radiotherapy was advised. She was on regular follow-up till 3 months, everything was fine. But at 6 months, calcium started raising up, and PTH also was very high. She was given symptomatic and cynic acid was started for 1 month, but she presented again with high levels of calcium and PTH. Now a 4D CT was done. They showed a recurrent lesion in the left paratracheal region and closely abutting the trachea and left carotid vessels. SESTA maybe showed a tracer-avid lesion at the surgical site, and there was tracer-avid lesion in the upper pole of the right thyroid lobe. Now we know that there's a recurrence, and now there was a trial going on for the 68 gallium trivexin scan at our institute. So that was also done, and it showed uptake on both the sides. So surgery, the recurrent lesion was removed. It was located just at the entry point, sitting on the nerve, on the entry point of the recurrent nerve. It was excised, and a right hemithyroidectomy and right CCLND was also done. IUPTs did not show a significant fall. Histopathology showed parathyroid carcinoma recurrence, and the right hemithyroidectomy specimen showed extracapsular angioinvasion of parathyroid carcinoma. She has underwent radiotherapy and she's also on cynic acid. She's absolutely fine. Her voice is normal considering the lesion was sitting right on the nerve. So that is it. Thank you.
Nice presentation of interesting cases. Just to about the second case, I think she was a sick lady. Would you have considered? And
sorry,
she was the second lady. Yes. Would you have considered any ablative technique for the parathyroid rather than operating?
Look, I did it under a local, more of a local anesthesia. She was absolutely fine. She was eating after 1 hour. So why consider?
The second question was, I think, for the patient with the parathyroid carcinoma that was away from the thyroid.
Parathyroid.
Yes. Introp, would you have considered doing a central compartment for that patient?
Yeah. So I didn't consider it that time, but now I'm not sure if I should be doing. But atypical parathyroid adenoma, it's not indicated. Now, if I go back to the histopathology, I don't need to do a CCLND in that case. But now her PTH is raising because atypical, we are not sure because her final reporting was done after a month of a lot of molecular testing. So we don't know. Maybe I'll image it again.
So some cases of adenoma will have delayed PTH fall, I think in your case also. So how do you go about, like, you'll immediately explore or wait for few more samples, delayed samples, and if yes, for how long?
More than 50% drop, I generally
Then
use
it's
it.
okay. But
That's okay. But
sometimes there is not, the desired fall is not there. Maybe a delayed fall is there. So
I explore it then and there itself.
and suppose you don't find any other enlarged gland, then I mean, how to go about? Because I've seen if we delay by another 10 minutes, sometimes you get that desired fall. And so any experience of the house or the Paul, sir, you have any?
The fall has like a Gaussian distribution. So you will have outliers. There's always 2 to 3% who will take longer than your usual pattern to fall. So I think what you could do, if you go by your evaluation of the case, that your clinical imaging all working in with localized, and you have your intraoperative decision making, I think sometimes you can override your PTH if you're convinced that you've got it. We've done that, as you said. You just wait another 10 minutes and do one more sample, and then it falls. Then you're good. But sometimes it may fall only the next morning, as I think one of your cases. Yeah. So that is a call that you have to take as a surgeon. Yeah.
Kidney is affected, it takes a little longer time for
Yes,
fall.
that's a good point. Yes, in your case, yeah.
3 of my cases, I've seen that hypothyroid patient also, they have taken a long time to fall. I'm not sure how relatable that is.
So,
But,
but we are doing this IOPTH mostly for well localized cases. So we go by, we very well taken that clinical judgment into consideration before starting surgery itself. So then again, if we don't have a fall, should we consider it as a, false this thing, or We wait in every case till we get the desired call for another 10-20 minutes. So, because otherwise this test carries no meaning.
Yeah, but it happens only occasionally. So those are the cases you have to take. But if you have a doubt, always you can look at the other side. That's not a problem. But if you think you'd rather avoid unnecessary dissection, then you wait and take another sample. I think that's how.
Thank you.
Okay, thank you for Dr. Pradeep.
That in some of the cases, the maybe as well as the ultrasound have localized your lesion, but still you are going and investigating further with 4D CT and all. Is there any specific reason for
One of the DM endocrinology student has a project comparing sestamibi and 4D CT. So
Oh, that's why you're doing additional investigation. Okay.
yeah, that is why they investigate.
Okay. Thank you.
So 4D CT is definitely a boon. I think if I have to go only for a single investigation, I would go for 4D CT.
That is okay. But here the sequence, yeah.
That is the project.
One more thing, in parathyroid carcinoma, was FDG PET done or yeah, after the second setting? Okay.
Dr. Swapna, good talk. What is your sensitivity and specificity of this 4D CT out of your patients? Your accuracy of picking these lesions, 4D CT.
Sir, I won't be able to tell the exact percentage, but 4D CT, the exact location they are mentioning, the adenoma in majority of the cases are found it exactly there, sir.
Have you found any false negative?
4D CT, no, sir.
Thank you.
Thank you, sir.
Thank you for that. We'll move on to the next session.
Thank you, speakers. Thank you, respected chairpersons. Now we'll move forward with sponsored session from Pfizer, conducted by Dr. Abhishek sir. I invite Dr. Abhishek sir to take the podium.
Good afternoon, everyone. I'm extremely sorry I have to hold you up before lunch, but it's a necessity. I've been told to speak on the treatment benefit of CDK4/6 inhibitors in hormone receptor positive, HER2 negative breast cancers, clinical trials, and the real world experience. So this is a sponsored session by Pfizer. So these are the list of RCTs in patients with hormone receptor positive, HER2 negative breast cancer patients. We all know the Mona Lisa, Monarch, and the Paloma trials. So the FDA-approved CDK4/6 inhibitors are abemaciclib, ribociclib, as well as palbociclib. So in ASCO 2022, the palbociclib, there was a study which was discussed and published. The overall survival with first-line palbociclib plus letrozole versus placebo plus letrozole in women with hormone receptor positive, HER2 negative advanced breast cancers. It was an analysis from Paloma 2 trial. So palbociclib is the first CDK4/6 inhibitor which has been approved as treatment for estrogen receptor positive, HER2 negative advanced breast cancer based on the results of Paloma 1 trial in 2015. Consequently, Paloma 2 trial, which was a randomized double-blind phase 3 study, demonstrated a statistically significant and clinically meaningful improvement in the primary endpoint of progression-free survival, confirming the findings of Paloma 1. So after a median follow-up of 23 months, the median progression-free survival was 24.8 months in palbociclib plus letrozole group versus 14.5 months in placebo plus letrozole group with a hazard ratio of 0.58. However, at the time of final progression-free analysis, the overall survival data were not mature. So it was performed after the required events were reached in November 2021 with a median follow-up of 90 months. So this was a study design. 666 patients were randomized into receiving palbociclib plus letrozole and placebo plus letrozole, with the primary endpoint being a progression-free survival and the secondary endpoints being overall survival and the safety and the response. So the progression-free survival as we can see, the updated analysis, the progression-free survival was 27.6 months. And these are the demographics and baseline characteristics between the two groups, which were comparable. The overall survival in the palbociclib plus letrozole group was 53.9 months as compared to 51.2 months in placebo plus letrozole group. Post ad hoc sensitivity analysis, excluding the patients in which the survival data were not available, was further, it was more in palbociclib plus letrozole group as compared to placebo, which decreased to 44.6% after excluding the data, patients' data which were not available. So the combined overall survival analysis of Paloma 1 and 2 trials showed in all the patients the median overall survival of 51.8 months versus 46.8 months. Also, the time for in patients in whom it was used as a first-line therapy, the time to chemotherapy was 38.1 months versus 29.8 months. These were the most common adverse events, which were defined as more than equal to 20%, most commonly being the neutropenia, followed by infections. So conclusions from the Paloma trial was it met its primary endpoint of improving the progression-free survival and other endpoints. And overall survival was numerically longer in the study group versus the control group. But the results were not statistically significant. So interpretation of overall survival in Paloma 2 is limited by large and disproportionate percentage in patients with missing survival data between the two treatment arms. So next, coming to the real world data, some Indian experience. So this is the largest real world data from Indian population, combining patients from Rajiv Gandhi and BLK hospitals in Delhi, which was a retrospective study. 118 hormone receptor positive patients, metastatic breast cancer patients on palbociclib plus aromatase inhibitors or palbociclib plus fulvestrant between February 17, 2017, 2022 were included. All were premenopausal women. Sorry, all premenopausal women received ovarian suppression or ablation. So the results were, it had, when it was used as a first line, the median progression-free survival was 20.2 months. When it was used as a second line, the median progression-free survival was 12 months. And the overall survival was, objective response rate was 80% versus 47.8%. 10% of patients had a grade 3 or 4 adverse events. So it concluded that the present real-world data of palbociclib used in Indian population suggests similar effectiveness to previously published real-world data evidences. We also have other studies from the other Indian experiences. This one is from, it was a multi-center study, retrospective from South India, analyzing the real-world experience between October 2016 to 2019. And it also concluded it resulted has a similar efficacy and safety in Indian patients as compared to the Paloma trials. This was another study. This study comprised of 67 female patients who were commenced on the treatment with palbociclib between 2016 and 2020. And for these 67 patients, palbociclib was commenced as a first-line systemic therapy in 36% of the cases, second-line 31%, and third-line in 33% of the cases. So the median progression-free survival was 18.7 months, and the overall survival was 23.2 months. So palbociclib is a useful addition in the management of hormone receptor positive, HER2 negative breast cancers, and its benefit is confirmed in our real-world setting, both in first as well as subsequent lines of therapies. So to summarize, all CDK4/6 pivotal trials were designed to demonstrate a benefit in primary endpoint and in the primary endpoint of PFS. And PFS is accepted primary endpoint in metastatic breast cancer by regulatory authorities all over the world. Also, the real-world evidence of associated overall survival benefits for patients treated with palbociclib combination therapy in the first line can help inform treatment decisions. And according to worldwide guidelines, CDK4/6 inhibitors in combination with endocrine therapy are the choice for patients with hormone receptor positive, HER2 negative, advanced or metastatic breast cancer. Now, there's this study, a P-Verify study, which is a comparative over just the last part of the presentation. The comparative overall survival of CDK4/6 inhibitors plus aromatase inhibitors in hormone receptor positive metastatic breast cancer setting in US real world setting. So The rationale was that in the absence of head-to-head randomized clinical trials, several real-world studies have evaluated the comparative effectiveness between the three CDK4/6 inhibitors. They compared all the three inhibitors, palbociclib, ribociclib, as well as abemaciclib. Although most of the patients were randomized to, most of the patients received palbociclib. And the primary endpoint was the overall survival as defined by the number of months from the start of the index to the death. So this was the study design. As I told, the most out of the 9,146 patients, 6,381 were in palbociclib group. The least number of patients were there in abemaciclib group. So this was the overall survival in the palbociclib group, as well as the ribo and abemaciclib. We can see the 12 months, 24 months, and 30 months overall survival are almost comparable. In unadjusted analysis, also the overall survival was almost comparable between the three groups, and on sensitivity analysis too. So the strengths of the study, this study was, the patients were diverse, and it represented comprehensive data collected in the US nationwide longitudinal database. And also the findings remained consistent in the some analysis of the patients who started treatment in 2017 or later, when all CDK4/6 inhibitors were commercially available in the US. So these are the author's conclusions and limitations. The limitation was that it was a retrospective database analysis, and although the statistical methodologies were used to balance the baseline characteristics between treatment groups, these methodologies cannot account for potential unmeasured confounders. And also the results may not be generalizable to patient populations that were present in their database. Thank you.
Thank you, sir. Now we take a break for lunch served at the foyer outside. We'll resume at 2 p.m. with few interesting debates. The workshop on ICG, neuromonitoring and microwave, the stalls are open outside in the foyer. Anybody interested can reach out the stalls outside.
सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव।
At the outset, I extend my warm greetings to all the eminent faculty members, invited guests, alumni, residents, and the delegates who have joined us from across India and abroad. Postgraduate course in endocrine surgery has evolved into one of the most respected
क्रतुण्ड महाकाय
Patients didn't had any these surgeries. And more resistance. The patient have lot of toxins and
is well put forwarded by Pooja ma'am. She has rightly pointed out the window period which period and the risk of back resistance and resurgence of the tumor. Now we'll invite Dr. Smita, how she is. Puja ma'am again for rebutting.
It's 2025. There's a term mentioned called prehabilitation. So you prepare the patient before you start them on TKIs, screen for hypertension, control it well. Half-life of lenvatinib is very short. It can withdraw, give long holidays. Pregnancy extensive. Avoid urea.
CMC level 3 institutional data on TKIs. So we could able to achieve 42% partial response relative and 70% partial. So, and Dr. Smita has pointed out that majority of the cases we had achieved partial response and a few are unacceptable. My question to Dr. Smita is when we could able to achieve a partial response and a few are unacceptable, being that the majority could able to be resected after a partial response, we can't go ahead with surgery to give at least better quality of life for the patient so that we can avoid continuing the TKIs. let's say there's completed one, and let's say the patient is ready for surgery. You still not operate, and if not surgery, what else? Breast you have. Because there's no radiotherapy, there's no nothing else that works. So what else? Not surgery.
Well, that's quite interesting debate. So, second thing is we start using adjunct setting. We use when there is a metastatic refractory By the literature, they say it is contraindicated. You should not be stressed with it. For the point of the conflict, because the change to a new adjuvant. If you think by semantics, it points to surgery.
Primary, I prefer using the term primary TKI scenario. So, we prepare a prospective data again in this situation. With the target. Yeah. So the real practice. Thank you both of you for your valuable inputs. Thank you so much.
start in prospective trials with this. And if you look at ratio of patients who are blocked and who are not blocked, one by Liu et al. Challenging for an anesthetist to manage. But for a surgeon, I think we'll be happy with some amount of hypotension during or even for some time after surgery. When we look at this forest plot of intraoperative highest heart rate and alpha blockade, once again, here the heterogeneity was acceptable and the diamond is very close to zero. So this was not of much importance and it hardly matters to us because even if you look at the highest heart rate, it's almost 110. I probably had 150 when I was driving and on the Uber ride to SGPGI without any health risks. So again, heart rate is of not much importance to us. Major most post-operative events comparing alpha blockade. Here, the heterogeneity was good, zero. But for the ICU admissions, if you look, the heterogeneity was higher. Despite high heterogeneity, need to believe these forest plots or not. And more so, if you look at in the entire meta-analysis, there were almost 1,700 patients. But when they subgroup analysis, less than a quarter of them have actually been utilized. So can we trust this meta-analysis? My answer is definitely no. And again, for major post-operative periods, and I'll be happy if Dr. Ramya in a subsequent talk can show that whether any professional body talks in favor of no blockade, I will rest my debate and I'll give in to her. Most professional bodies always favor a blockade, even on date. This was published, I think, in 2025. And it does talk about that blockade is very much a part of our algorithm. And even if we have to look at the previous study, where was it published? International Journal of Surgery. It's a good journal with a good impact factor. But if the authors were so good, I'm not questioning the abilities. Definitely, I'm nowhere near to them. Why do they have to publish it as an open access thing? I'm sure if it was a very good meta-analysis, it would have been published free of cost. The authors must have paid a lot from their pockets to get this published. So that is my that is my primary objection if we go on quoting this paper. Okay, I was telling you we need to involve the anesthetist. I didn't get enough time. This idea came to me later. I passed on this Google. This is nothing. Even Ganesh said, sorry, Bharat said this was biased. मैंने उससे पूछा कि the Google form that we sent out, उससे कुछ responses आए कि नहीं आए. He said, sir, आपके favor में है. मैंने बोला तुम ऐसे बोल रहे हो तो क्या होगा? So this was, we sent it out to all the anesthesia consultant who come to an endocrine surgery OT, and God promise or pinky promise है जो भी बोला जाता है. I did not tell them कि it is for this. They should give an honest opinion. And all out of 8 of them said that they want a blocked patient for FIO. I'm sure even if the anesthetist in SGPJ were to be asked, they would have all said that they want a blocked patient. With that, thank you. But at the same time, I don't like a non-smiling Dr. Ramya. So just end by saying always and never are 2 words you should always remember never to use. Thank you.
Dr. Ramya for no blockade.
I know Dr. Kulranjan is the crowd's favorite, but literature favors my point. And Smita has just shown how we can torture the data to make it confess our point. He did exactly that with one meta-analysis. So I'm going to show the results of that meta-analysis, which he has failed to show, ultimate conclusions. So why are we even debating it? If alpha blockade is a must, and if we cannot do FIO surgeries without alpha blockade, then why are we even debating it? Yes, we all know surgery is the curative option for FIO. And the perioperative mortality has come down since it was first studied from almost 1950s, from 45% to about 0 to 3%, thanks to the preoperative preparation and advancements in anesthesia, which is intraop monitoring, as well as ultra short acting, effective intravenous infusible drugs, which we can titrate to the effect. So these are the things that have helped us to achieve this reduced mortality. But let's not confuse no alpha blockade with no control of hypertension or lack of a preparedness. So we are just saying that we should not do alpha blockade. But why do we need this extra preparation before FIO surgery? So there is a secretion of or passive release of epinephrine and norepinephrine by the tumor, which causes chronic vasoconstriction, hypertension, tachycardia, and volume depletion. But the hypertension may be continuous, episodic, or the patient may even be normotensive. Often the release of the hormones is paroxysmal, which is unpredictable many times, and there could be life-threatening outcomes with possibility of hypertensive and cardiac emergencies, kidney damage, strokes, bowel ischemia, and others. So the goal of preparation for surgery is to control the hypertension and tachyarrhythmias and to prevent postoperative hypotension, because all these can result in catastrophic events. So how can we achieve this? That is the point of interest. So what entails an adequate preparation? The blood pressure should be under adequate control. There should be the reversal of chronic volume depletion, and there should be heart rate and arrhythmia control, and myocardial function, if it is compromised, that has to be optimized, and reversal of glucose and electrolyte disturbances, and meet the Roizen's criteria. So traditionally, we have been preparing the patients by using alpha blockade and other add-ons. Mostly, they were the then available calcium channel blockers and then beta blockers for tachyarrhythmias. And we commonly use prazosin and phenoxybenzamine, but there are certain real limitations to these drugs. Prazosin, as we all know, is short-acting. It's a selective and competitive blocker. It is ineffective to control the intended hypertensive emergency, which we're all fearing about. So because it's a competitive inhibitor, there could be a rapid recycling of alpha receptors once we stop these medications, or because of short duration of action. And it is not as efficacious, but it has as just the calcium channel blockade, or rather phenoxybenzamine, but has similar post-op morbidity when we don't block the patient, as in when we don't use alpha blockers. Phenoxybenzamine, on the other hand, it's a non-selective, non-competitive, irreversible blockade, which blocks by covalent bond, and the receptors have to be resynthesized once we stop the drug. But the downside of it is that it causes prolonged post-op hypotension, which we don't want. And it's not easily available and it's expensive. So we can actually achieve these ideal targets by using newer calcium channel blockers, which were not available then. So currently we have cilnidipine, we have nicardipine, we have such ultra short acting effective medications that we can actually achieve all this by not using these alpha blockers. So we've actually shifted the problem from pre-operative hypertension to post-op hypertension by using these medications. And we are unable to prevent completely the intra-op severe events. So the latest evidence supports use of calcium channel blockers. Why? Because if we look at the mechanism of action of calcium channel blockers, they inhibit norepinephrine mediated transmembrane calcium influx in vascular smooth muscle, which leads to arterial dilatation. But the most important thing that we have to note here, it results in reduction of afterload and improvement in left ventricular function as well, without decreasing the venous return, which we all know is a major problem with alpha blockers. So calcium channel blockers, I am sure all of us agree that it's one of the, after ACE inhibitors, even for essential hypertension, we use it as one of the first line drugs to treat hypertension. And it is very well studied, easily available, inexpensive, and it is at least as effective as alpha blockers in pheochromocytoma, if not better. So why do I say this? Nowadays, there's a shift in how we diagnose pheochromocytoma as well. There's a lot of them have been diagnosed as incidentalomas, and many of them even can be normotensive. So here, we can actually control the hypertension by using calcium channel blockers with an optimal regimen and use other medications if there's any need for tachycardia, which calcium channel blockers by themselves don't cause over and above. So, and as I was just mentioning, we have so many intra and post-op options right now. So anesthesia technique has changed. I'm sure anesthesia colleagues here agree. So adequate pre-medications, invasive monitoring, and keeping the patient at adequate depth before intubating, and such short-acting medications for both hypertension and hypotension and for arrhythmias are all available now. So coming to scientific evidence. So one meta-analysis, I have skipped the other meta-analysis, which was, I know the quality was poor. I'll be mentioning one meta-analysis, and the quality of the meta-analysis depends upon the quality of the studies that are included. So it just, on the face of it, we all know that there are no randomized trials in this area, and the whole data comes from observational studies, which are retrospective predominantly. Probably the reason is it's a rare tumor, and yes, there is a prospect for doing prospective multi-center or multinational trials. But as of today, there are only a couple of meta-analysis, of which one we have extensively seen by Wong et al. Dr. Kulanjan sir has shown it, and I'll be telling the conclusions of that. And the parameters they have used in the studies, rightly so, are the mean maximal intraoperative systolic and diastolic blood pressure, because these are directly and indirectly related to these catastrophic events, mean maximal heart rate, and any cardiovascular complications or mortality, and the mean lowest systolic blood pressure. So this paper, actually, it's an single institutional study. I'll show a couple of papers. Here, they have analyzed about 140 patients from their own data from UK. Here, they have seen that the cardiac instability remained significant in the surgery of pheochromocytoma and paraganglioma, despite whether we do this alpha and beta blockade or not. And then the question, should we even block? So the question arose, we can understand the question from here. So again, another study where this also, I think Dr. Kulanjan has shown, both alpha and calcium blockade, both of them have even though there is intraoperative hemodynamic instability, but the outcomes are similar. So this is a study done in about 155 patients where it's published from France and New York. There were 41 patients who received alpha blockade, and there was no preparation at all in 4 patients, probably because they're normotensive, and 110 patients had just calcium channel blockade. And the mean maximal systolic blood pressure was less after alpha blockade, we agree. But if we look at the overall complication rates, that is the catastrophic events or the need for additional medication for hypertension episodes, it's similar. Whereas the persistent hypotension was much, and the need for vasoactive pressors as well as mean fluid volume infused was much larger for alpha blockade. And another study from Martin Wall's group from Germany, which I had firsthand experience working. I mean, I have observed them for a week while I was in Germany. Even there, they have done many cases without alpha blockade, and their mortality rate is also very less, and the complication rates are also very less. So the Wong et al. Meta-analysis, what are the conclusions from this? So here they have seen that intraoperatively, none of the analyzed hemodynamic, first of all, 15 non-randomized studies were used in this, versus the Shimak et al. Paper where only 4 studies. Here they have analyzed 15 studies. Cumulatively, there were 3,500 patients, and none of the hemodynamic parameters differed between the patients with or without alpha blockade. So as I said, the output of meta-analysis depends entirely on the quality of the studies. We cannot change the studies, but there is definitely a trend even from this paper that preoperative alpha blockade ensured neither more stable intraop hemodynamics nor better perioperative outcomes over no blockade. However, of course, we all need a large RCTs. So how much ever we debate about it, the current evidence says that alpha blockade, yes, definitely causes hypotension. The maximal systolic blood pressure may be different by about 70 to 20 millimeter mercury better with alpha blockade. But the catastrophic events or the problematic events are similar, whether we use calcium channel blocker based control of hypertension or alpha blockade. And yes, traditional view, we should have been using alpha blockade, but current meta-analysis say not really. And yes, Dr. Sanjay, if he had been here, he would have said similar things. Once upon a time, even laparoscopic adrenalectomy was contraindicated in pheochromocytoma in 1950s, but now that's the norm. Yes, Dr. Kulranjan, truth hurts sometimes, but there is a trend towards not using alpha blockade. And what definitely is helped by alpha blockade is anesthetist's heart and our bonding, surgeons bonding with endocrinologists, because we keep calling them what dose. So ultimately, what definitely helps is control of hypertension based on calcium channel blockers, continuous intraoperative monitoring, and of course, postoperative care, a good anesthesiologist, and a good crosstalk between all the team members. So we should not just continue doing because somebody else has been doing it. At some point of time, if we see evidence against it, we should be open enough to welcome that evidence. Thank you.
Thank you, Dr. Ramya. Rebuttal. Kulranjan sir, any rebuttal from your end?
Sure. So I think she was speaking in my favor. All the studies that she brought out, also the second study, 41 patients in the blocked group and 4 patients in the non-blocked group. Is that an article good enough? No, 41 and 4. No preparation at all. No? So I think that should not be quoted at all. And even she said 3,500 patients in that meta-analysis. But if you look at the subgroup analysis where we talked about the morbidity and other things, only 500 odd were taken into consideration. And when we have such retrospective studies, there'd be an inherent bias anyway. Someone who would have morbidity, we would definitely block him. And all those apparently fit young patients, tumors may have been smaller and all those things, we tend to do it all the time. And I'm sure the studies would have also done that. They would have not been blocked. So can we really quote that? And she talks about here at the center of Professor Martin Wall's, that particular study, more non-blocked patients than blocked. But how many of us in India can even think that we are a center as good as that? We are good, but probably we cannot compare to that. And the kind of facilities that are available there and at a typical hospital in India, I think that itself is questionable. And as I said, it is not only the surgeons' comfort levels. Here, the anesthesia should be taken into, the anesthetist comfort should be taken into consideration. I think a good study would have monitor the heart rate and BP of an anesthetist during pheo surgery with or without blockade. I don't think there would ever be a debate then. And when we talk about most of the studies with blockade, all utilize phenoxybenzamine. Phenoxybenzamine is a long acting. That definitely causes long postoperative hypotension. She was speaking against prazosin. The half-life of prazosin is in minutes. Needless to say that the effect may last as long as 10 to 24 hours. So even if you're given the morning dose of prazosin, the effect of prazosin would have definitely gone by the next morning for sure, 100% in all patients. In some by a few hours, and in majority by the evening, the effect of prazosin would not be there. So can prazosin be disregarded? I definitely wouldn't agree to that. And I would just typically ask doctor, how many of your few patients have you done without blocking? In Germany. So this debate is in India. In the at SGPJ, which is apparently the place for endocrine surgery, if SGPJ doesn't believe in no blockade as of now, I think the same message should go to others. And what happens with if we kind of just simplify things so much, I think a lot of catastrophe will happen in a country like India. कभी वर्कअप वो मेटानेफ्रिन देखेंगे ही नहीं देखेंगे बस किडनी के ऊपर एक गार्ड दिखी every surgeon right and left in every gully kucha of Lucknow will go on to excise it and it will never come, it will never see the it will never reach us only. So I think if we are promoting no blockade in a country like ours as on date, ये तो इससे महापाप कुछ नहीं हो सकता है सारी तीर्थ यात्रा करके पहले उसको ढूंढना पड़ेगा डॉक्टर
Sir missed the actual point of debate. It's not preparing for surgery. It's about using calcium channel blockers instead of alpha blockade. So I understand his attachment for prazosin, but the newer calcium channel blockers like cilnidipine and nicardipine, they are very effective and we can use many of them and achieve the same results. And the other point that I want to highlight is the prazosin blockade that we have used may not have prepared the patient adequately for the surge of the hormones that are released intraoperatively. So how much ever we block, the amount of hormones that are released, then if we have blocked everyone adequately, there should not be any hypertensive episodes during surgery. So that's not the point. So what I'm saying is even calcium channel blockers can correct the preoperative hypertension that patients have without causing postoperative hypotension. And whether there are any events intraoperatively, we have such amazing drugs nowadays which are rapid, effective, and we can titrate them and achieve responsive one. Yeah, thank you.
Thank you, Kulranjan sir and Ramya ma'am. If we had overseas faculty who would put a good perspective, another perspective, because we've been doing blockade for a long time. Probably we are also having a that bias. No, I do agree that's not a bias. That's science. I agree. Sorry for that. Apologies.
Yes, I agree. Dr. Joan Walsh would have loved to participate in this debate, but over last 3 days while she was here, and when we operated 2 FIOs during that time, she was. We did discuss about blockade versus no blockade. Australian norms are still for blockade, but what they do is, and they mostly use phenoxybenzamine. They skip the phenoxybenzamine dose on the day prior to surgery. So that's a good middle path, achieving exactly what both of you wanted. Another fun fact, I'll not name the study, go back, see it. One of the studies which looked at postoperative morbidity, not mortality, excluded patients who did not survive.
One quick question. So you were talking about no blockade. Have you gone through and how many of these anesthesia detailed procedure of the anesthesia has been given and how many of them have used labetalol infusion during intra-op because it is both alpha and beta blockade? Was there any data on that?
I think instead of labetalol, many have preferred esmolol.
A lot of anesthetists use labetalol instead of esmolol.
I don't know. I'm not aware of that.
No. See,
See, though it is pre-op, what are we looking at? See, intra-op also. Why they have not given pre-op blockade? Because the intra-op anesthesia management is too good.
So in that too good, how many or what are the drugs they have used apart from esmolol or NTG? Because labetalol, most often anesthetists use labetalol because they say that, okay, they tend to use that, it's alpha blockade also, so I'll use it instead of just esmolol. So that's what my question was.
Shashi has a point. What he's mentioning is we can drive fast because we have effective brakes in our vehicles. That is exactly the point or uh, the the uh, uh, the defense taken by non-blockade those who favor non-blockade. So yes, the current generation anesthesia perioperative medicine is so good that even if you have a catastrophic event during surgery, they'll somehow bail the patient out, which was not the case when most of these earlier studies were designed.
Point is, just because we use alpha blockade doesn't prevent our necessity for using these drugs intraoperative. So we may still have to use the same medications. So whether we block or not.
Himgirish sir, you had a point. So Himgirish sir had a
Yeah, point in jest. Purely in jest. 1 point each for both of you. So Gulranjan, you said you have to block, right? So whether you block or not, I mean, okay, agree. But in this debate, Amrish Puri is saying that you have to block. Whether you block or not, the postoperative hypertension, we have these patients when you're operating more than 15, 20 minutes of 200, 120, 250, 120 morbidly high blood pressures. Anything that's more than 10 minutes of such high blood pressures will put the body at dangers of this, which is basically what we are setting out to prevent when we are blocking. So why block at all? To Ramya, if you're not blocking, you don't want to block, right? How is my heart rate as a surgeon leading up to the 2 weeks before surgery when the patient is not blocked, vis-a-vis the patient being blocked? I have maybe, but you are the one who's going to answer. It's not the anesthetist. Patient comes looking for the surgeon. My heart rate better be 70, 80 rather than 120, 130. I'm going to live longer.
So I just want to share my experience here, sir. I have been data for a couple of years now. The adrenal is operated by the urologist, and I see all the endocrinologists see the POs in the KEM hospital. So they don't use alpha blocker. They only use calcium channel blockers, and they send the patients. So I don't know, the anesthesia team is good and they do it without blockade, without the alpha blockade. Yeah, please.
Levels the previous day and it was elevated and the case was cancelled and posted the very next day. So urologists do operate without blockade.
Yeah, I know that.
No, no, I think I would be just adding a bit. Whatever my anesthetist is happy with, I would be happy to block or not block. And my heart rate or my blood pressure would be inversely proportional to anesthetist's heart rate and blood pressure. And then I have to customize anesthetist wise also. I need to look at the list, who is the anesthetist today, and then my strategy. So at the end of day, whatever arguments we are making here, that should be acceptable to anesthetists. If they are happy, patient is happy, surgeon is on board. That's what, that
We'll
is
have
that.
That if we go with नहीं मैम, we are not doing justice to the residents also. ऐसे PO का केस अगर एग्जाम में मिला तो resident criteria is always asked. Let's not give him a premature death. ठीक है, एक short question भी हम हटा ले रहे हैं. If no block is that question also will go.
So points well taken, Dr. Ramya and Dr. Kulranjan. A patient need preparation, whether it is alpha blockade or no alpha blockade. They need at least a calcium channel blocker if at all, if they are hormotensive, this one. So I think the point has been clearly made by both the parties here. Thank you so much. It was a wonderful debate. We enjoyed it a lot.
Thank you, chairpersons. Thank you, sir, for the wonderful session. Now we'll move forward. Symposium on adrenal disorders. I will invite the chairpersons, Dr. Anjali Mishra ma'am, Dr. Gopalpuri sir, to take the chairs. First speaker would be Dr. Zafar sir on adrenal imaging, newer developments. Anjali ma'am.
I would like to now invite the first speaker, Dr. Zafar Nias, on adrenal imaging, the new developments. Over to you, sir.
Actually, I was looking at the newer developments. So in radiology, I think not much has changed in the past 10 years, but in nuclear medicine, they have many new tracers available for this pheochromocytoma and paraganglioma. In radiology, we still have a CT and MRI. So, but I'll be discussing common adrenal lesions and how we make our differential diagnosis and what we are doing in radiology. So these are the options. Ultrasound is useful for larger adrenal lesions. It's very difficult to pick up small adrenal lesions with the help of ultrasound. However, CT and MRI, they are very good in picking up small lesions. Even 3-4 mm lesions can be picked up. And also we are doing a lot of CT guided biopsies in the cases where we have to prove the nature of the lesion. And in nuclear medicine, they are doing PET for various indications, like for staging the disease and also for PHEOs. So they are doing, they have many newer tracers coming up. So I don't know much about them, but I'll be showing some good cases, what I had in my experience. So generally, it's always good to know the background of the patient before reporting a case, because we should know whether the lesion was incidentally detected or the patient is having low hormones, means Addison's disease, or he's hypersecreting. So then we can make sense of the imaging findings. Like if a patient is coming with the Addison's disease and he has bilateral adrenal masses. So I'll be thinking more about these 4 conditions. Either it is histoplasmosis or tuberculosis, and sometime it can be metastasis and lymphoma. So surprisingly, histoplasmosis is very common, although in other organs like lung, I'm not getting histoplasmosis, but somehow adrenal is a very peculiar site. And in our setup also, whenever we do biopsy of a bilateral adrenal mass in a patient with the Addison's disease, and mostly it turns out to be histoplasmosis and sometimes tuberculosis also. So this is how we see. So what we see bilaterally enlarged adrenal glands, and usually the entire gland is involved, and sometimes the outline of the morphology of the gland is preserved. And the gland, depending on the stage, the gland may have some necrotic areas, or it may be totally necrotic. So it depends at what time the patient has been imaged. So generally we have bilateral enlarged adrenals. And like another case here, we have more necrosis in the adrenal compared to the previous case. So for the 4 most important differentials, 2 are the histoplasmosis and tuberculosis, and rarely we have metastasis, and a few cases of lymphoma also we have seen. So this is a very common presentation in our setup. Sometimes these patients come late, and then the masses are regress, and the entire adrenal gland is replaced by calcifications. So also some cases we encounter at this stage also. This is a case, again, bilateral adrenal mass, but these masses are quite bulky and there are no necrotic areas. And this was a case of large cell lymphoma. So 2-3 cases I have encountered where we have seen bilateral lymphomas also. So we keep this also in the differential diagnosis of bilateral adrenal lesions, but necrosis is less common in lymphoma compared to the TB and histoplasmosis. Now, we also encounter cases where there is hormone overproduction, whether it could be Cushing syndrome or there is virilization. And in this setup, generally we think about whether it is adenoma or adrenal hyperplasia or sometime adrenal cortical carcinoma. So this is a case here, bilateral adrenal, they are thickened, but not much nodular, but they are thickened. Generally, we take criteria. So if it is more than 4 to 6 mm thickness, the limb, then we label it as thickened adrenal. So here both adrenal glands are enlarged and no focal mass is seen, and this was a case of adrenal hyperplasia. But sometimes we have bilateral enlarged adrenals with multiple nodular appearance also. We can see, so this type of picture also, macronodular hyperplasia, we sometimes see, and these cases may have overproduction. Now coming to the adenocortical carcinomas, they are usually, we encounter them when they are quite large, and as you know, these are very infiltrating lesions. They can involve, like in this case, the IVC is involved, and we can also have metastasis. And in this case, there is a large mass in the adrenal gland, and we can also see the mass is extending into IVC and reaching till cavo-arterial junction. So similar to renal cell carcinoma, adrenal cell carcinoma also has a tendency to invade the veins. And as the adrenal veins, either directly or through the renal vein, they drain into the IVC. So tumor thrombus can go into the IVC and sometime up to the heart. So another case, we have a large adrenal mass and kidney can be seen separately, but what we see is that the mass is extending into the renal vein, in the adrenal vein and into the IVC, and in fact, it is coursing superiorly into the IVC. So we can have metastasis, we can have infiltration of the adjacent organs, and also we can have invasion of the renal vein and IVC in cases of adenocortical carcinoma. Now, another presentation is a patient with hypertension, and then we can sometimes find out enhancing mass in the adrenal gland, and then of course on imaging we cannot say this is FeO. You need to correlate with the urine metanephrine and other parameters, other hormonal parameters. But on imaging, especially in a patient who is hypertensive, if we get a very enhancing mass and it has some non-enhancing or necrotic areas, then this appearance is quite suggestive, although not diagnostic, but quite suggestive of pheochromocytoma. And of course, this is not my area of expertise, but in nuclear medicine, people are doing PET scan, and they have many tracers, some of which are quite specific for pheo and paraganglioma, whereas like FDG PET is somewhat non-specific. It is for detecting metastatic disease and malignant conditions. But there are some radio tracers which are quite specific for pheochromocytoma and paragangliomas. Now coming to the incidental lesions. So since the availability of the CT nowadays, we are like very commonly detecting incidental lesions in the adrenal. The patient comes for either evaluation of the malignancy or for some other region, and we found a nodule in the adrenal. So these cases are mostly benign non-functional adenomas, but our concern is metastasis, especially if the patient has a primary disease. So, and also there are other lesions like adrenal cyst and myelolipomas. They can also present as a incidental lesions. So I think you people must be knowing more about how to triage the patient with incidentaloma. I'll be showing what we are doing. So the basic intention of imaging in a case of adrenal incidentaloma is to differentiate it from metastasis and primary malignant masses, that is adrenal cortical carcinoma. And so this is, I think, from European Society of Endocrinologists. And they have proposed an algorithm for imaging the patients with incidental adrenal masses. And so they have used plain CT. They have not used contrast CT where we calculate washout and washout ratios, but they have mainly relied on NCCT. And if on plain CT, the HU value or the density of the lesion is less than 10 HU and it is homogeneous, no more imaging is required, whether it is of any size. So if on plain CT, it is less than 10 HU, then they don't do any imaging further. While for more than 10 HU, then they again, they have different recommendations. But for lesions which are like more than 10 HU and more than 4 centimeter, if the lesion is more than 20 HU on plain CT and more than 4 centimeter, then mostly they, after considering multidisciplinary discussion, they mostly either do PET CT or sometimes they go for surgery. In between, usually additional imaging like MRI or PET is done. Here they have not discussed much about the washout, what we calculate on the CT, but still we are doing it. So in what we are doing in a CT scan, if there is a patient with the adrenal mass, so first we do a plain CT, and there are some CT features which can tell us that this mass is definitely benign, but not in all cases. But in some cases, if the patient has a adrenal lesion which has a density of less than 10 HU, or there is a macroscopic fat, means we can clearly see a fat in the lesion, or the lesion is typical fluid attenuation, or it is having coarse calcification, means thick, chunky calcification. So if we are seeing these features, then we know that this is a benign lesion and we don't need to study this lesion further. However, if on NCCT the value is more than 10 HU, then we have to either do contrast CT and then a delayed scan at 15 minutes and calculate the washout ratio. We can calculate absolute washout ratio and relative ratio. And then we can identify some of the lipid poor adenomas. But still, those lesions which does not show washout or signal drop, they still can be lipid poor adenoma, and there is also possibility of FEO, adrenal cortical carcinoma metastasis, and in these cases, further workup like PET scan, biopsy may be required. So our main target is to at least detect those lesions which have typical features to suggest benign etiology, so that we can stop at that point and not to do further unnecessary investigations. So this is an example of MRI outphase imaging. In MRI, this is a sequence which is called outphase imaging. In outphasing imaging, what happens, as you can see, the vertebra has become black actually. First see the vertebra. So this is the vertebra on in-phase image, just 2 minutes. So this is the vertebra on in-phase image and in out-phase image, because it has intracellular fat. So to detect intracellular fat, we use this MRI out-of-phase imaging, whereas we use fat suppressed sequences for detecting macroscopic fat. So this is an adrenal nodule which has density of 3.7. So it is a typical lipid rich adenoma, and we stop at this point. This is a case of myelolipoma. We have macroscopic fat, and if we see large amount of macroscopic fat, our diagnosis is almost sure it is myelolipoma. But in also sometime we have adrenal lesions where there is metastasis and we do CT guided biopsy to prove, confirm the diagnosis. In children, generally we see neuroblastoma, sometimes ganglionoma, adrenal adenoma and adrenal cortical carcinoma also sometimes seen. Just two more cases. This is a case of child with intraabdominal mass. We see a large mass in the arising from adrenal fossa with coarse calcification, and also there are multiple lymph nodes. So this was a case of a neuroblastoma. This is a case very recently done. This child presented to neurology with opsoclonus myoclonus ataxia syndrome, and on CT abdomen chest was done, and there was a lesion found in the left adrenal. Biopsy was done, and it was a small round blue cell tumor, IC awaited. So this is these are the cases which we have seen. So basically, as a radiologist, we try to find out lesions which are typically benign, and so that we can stop doing further aggressive tests. Whereas in cases where imaging findings are not conclusive, we go ahead with other techniques like PET, sometime biopsy. Thank you very much.
Thank you, Dr. Zafar. You have very nicely shown all the spectrum of adrenal lesions on imaging. That was well explanatory. Just one question I had. This, as a surgeon, we rely much on CT scan, but many a time of adrenal lesions, we find the plane between liver, adrenal, sometimes smudgy, and we are not very sure how it will be intraoperative. So can imaging help us in better delineation of the planes? Sometimes we open and we find there was no problem with the planes.
Actually, it depends on the fat also. Sometimes patient is very thin, so he has very little fat. So if the patient has very little fat, there is an adrenal lesion, it will be almost closely abutting the liver. There will be no plane. And while in some patient, you get very good fat planes. So I think still it is a area where there is some confusion whether it is but in large masses we can try sometime ultrasound to see whether there is a movement of that adrenal mass over the liver or not. But sometime there is no fat plane, and we cannot be very sure whether the lesion is actually adherent with the liver capsule or it is free. So that is a problematic area, especially in the patients who have little fat actually. So that's still, but I think mostly it is free actually, until mostly, although most of the lesions, they are in contact with liver, but most of the time it is not involved actually. So that we know.
Sure, thank you. Any other questions from the house? Sure, thank you, sir.
Next talk is on the preoperative management in Cushing syndrome. I invite Dr. Adarsh Raghavan for the talk.
Good afternoon, one and all. I thank the organizing committee for giving me this opportunity to speak on preoperative medical management in Cushing syndrome patients. As we know that Cushing syndrome people are having an increased tendency for venous thromboembolism to occur, and we have to take an informed decision on whether we want to use venous thromboembolic prophylaxis or not, based on various patterns which we are going to see. And the patients are going to have metabolic derangements like diabetes, hypertension, dyslipidemia, along with an increased risk of venous thromboembolism and increased propensity to develop immunocompromised states and infections. So Cushing syndrome is as such a prothrombotic state, and there are altering factors of the coagulation cascade that occurs, along with derangements in regulators of fibrinolysis and platelet function, like factor 8, fibrinogen, von Willebrand factor being a very important factor that is deranged, leading to this increased prothrombotic state. Biochemically or in blood samples, we'll see that there is a shortening of the APTT, and there is also a compensatory increase in coagulation inhibitors that is going to be noted. Along with this, there is chronic endothelial damage, atherosclerosis, and associated obesity, diabetes, and hypertension that may also contribute to thrombogenesis. And this abnormal coagulation parameters are not always present in all patients of Cushing syndrome cases, and they do not correlate with the degree of the hypercortisolemia as such that is going to be noted in these patients. So in general, the risk of venous thromboembolism is around 18 times higher than in the general population. And the venous thromboembolism rates is increased in the postoperative period by up to 20%. This is usually seen within 1 year of diagnosis and within 2 to 3 months post-surgery. That's the period that we are seeing. Other than the disease as such being responsible for increased venous thromboembolism risk, surgery is also a factor, and the acute cortisol drop that can occur following surgery is also implicated as a factor. Along with the sudden anti-inflammatory action of glucocorticoids dropping will lead to a further procoagulant state. Some studies have shown that bilateral adrenalectomy has been associated with a higher incidence of developing of venous thromboembolism, but whether it is because it is a bilateral disease per se, or is it because of the severe form of Cushing syndrome that can occur during that period, or whether it is associated with malignancy as a factor individually is not known. So is there a recommendation that we have to give venous thromboembolic prophylaxis for all patients? Is no, there is no direct recommendation that has been given by the Endocrine Society. They're saying that you have to choose to give anticoagulation to those patients in whom there is already a history of venous thromboembolism. They are having thrombophilic states, when the patient is having severe hypercortisolism, where the patient has been using any hormonal pills like use of estrogen or testosterone, or prolonged preoperative or postoperative hospitalization is anticipated in those patients, and you're expecting it to be, say, from Cushing's disease, and the surgery might be incomplete, so high postoperative cortisol levels are still noted, and glucocorticoid over replacement is anticipated in those patients, then you have to consider for anticoagulation. Other than this, not a direct indication, but relative, is when there is active cancer, smoking, or prolonged immobilization in older age, you may have to consider prophylaxis. The most common drugs that we use are low molecular weight heparin, fondaparinol, and direct oral anticoagulants that we can use. Aspirin and warfarin are usually not indicated for venous thromboembolic prophylaxis. And when do you want to ideally time it? Is at least 24 to 48 hours before surgery. And then you stop for a period of 1 day at least, depending on the drug that you choose. And you may want to continue it for a period of at least anywhere ranging from 1 week to 6 weeks, the ideal period being 2 to 4 weeks. A longer regimen of, say, 2 to 3 months may also be required in cases of bilateral adrenalectomy has been done. And we can also use prophylactic stockings, and early mobilization and intermittent compression devices will be recommended during the postoperative period. So the drugs most commonly used are low molecular weight heparin, given as subcutaneous. Unfractionated heparin can be given subcutaneous twice daily, at least 5,000 units can be given. Factor Xa inhibitor, fondaparinol, can be given subcutaneously, and it can be used in patients in whom heparin-induced thrombocytopenia can be anticipated. And when there is severe renal impairment, fondaparinol should be avoided. Direct anticoagulants like rivaroxaban, dabigatran, and apixaban can also be used. The thing that we need to keep in mind is not just the venous thromboembolism, but the other drugs that you might want to give to control your hypercortisolemia, like your ketoconazole or levoketoconazole. And when they are used in combination, they may increase the levels of these drugs. Your aspirin and warfarin are not commonly used for venous thromboembolic phenomenon prophylaxis. Right. So how do we assess whether this patient is going to have this risk of developing a venous thromboembolism? Is by using a risk assessment model. This was designed in the year 2015 and published in 2016. It was done in 1,100 patients in Italy, and where they found out independent risk factors like age, when more than 69 years of age, when the patient is having an acute severe infection or sepsis, when the patient is having reduced mobility, which might be due to either their morbid obesity, or which might be due to osteoporotic fracture, or they are predominantly bedridden. A high midnight cortisol level that is more than 3.15 times the upper limit of normal. a very shortened APTT, and the patient gives a history of previous cardiac events, the risk stratification was done based on the scores that were developed for Cushing syndrome. And when the score was 3 and above, they found that 85% of those patients were to develop a venous thromboembolism. So definitely with this score, they will be able to gauge whether this patient will require will require prophylaxis or not. Other than this, we know that the cardiovascular system is bound to be compromised in these patients. And when there is hypercortisolism, there's increased cardiovascular risk, and associated insulin resistance and diabetes is going to lead to increased visceral fat accumulation and increased lipolysis and free fatty acids. And this will further lead to atherosclerosis, worsening of the cardiovascular condition. The patient biochemically can have hypokalemia and increased QT levels, and cardiac arrhythmias may also occur. An echocardiogram and stress testing is needed in asymptomatic patients with Cushing syndrome. Aspirin, though not useful as for deep vein thrombosis, can be used for secondary prevention of cardiovascular events. And for the dyslipidemia, we may give statins as well. And the initiation is recommended in high-risk patients. Again, early detection and active management of the cardiometabolic comorbidities is mandatory, though they might be already on treatment for this hypertension and diabetes. The treatment is usually not optimized in view of this hyperproduction, and it needs to be optimally controlled because the hazard ratios for developing an MI or a stroke is higher by 3.7 and 2 times when compared to a general population. The drugs most commonly used are mineralocorticoid antagonists because this indirectly helps you control the hypokalemia as well. The angiotensin converting enzyme inhibitors, your ARBs, the beta blockers, and also the loop diuretics. But the problem with the loop diuretics is that they may worsen your hypokalemia and lead to further potassium replacement that is required. With the mineralocorticoid receptor blockers, ketoconazole can increase the levels of eplerenone, and the ketoconazole can also increase the levels of your AC inhibitors and your ARBs. And we must also treat the diabetes simultaneously, with metformin being the first go-to drug. And in severe cases, you might have to give subcutaneous insulin. And in hyperglycemia that's severe, an IV insulin infusion may also be required. Again, for the drug interactions, we need to keep in mind that when levoketoconazole is given, the levels of metformin is going to be increased, and also ketoconazole increases the levels of your gliptins when they are being used. For the dyslipidemia, statins will be the go-to drug, and the levels are increased by ketoconazole as well, and we can also use ezetimibe. The potassium replacement primarily is going to be done by your mineralocorticoid receptor antagonist that you're going to give, potassium sparing. And then you may want to give oral supplements, and in certain circumstances, IV should also be given. Other than the metabolic derangements, immunosuppression is something that we have to keep in mind, where the patient can develop both typical as well as opportunistic bacterial, viral, or fungal infections. The incidence is highest during active hypercortisolism and the first 3 months after surgery, and the patients can have urinary tract infections, skin, soft tissue infections, pneumonia, and sepsis, the most dangerous of which is going to be your pneumocystis jirovecii pneumonia. Rare but life-threatening, and it's usually in the immediate post-operative period that we are going to see this. The pathophysiology defined for this is the immune reconstitution syndrome, where the body tries a vigorous response at the lung level in the immunocompromised state, and the patient can have substantial hypoxia, dyspnea, fever, and ground glass opacities on the CT. With the COVID-19 phenomenon that has occurred, they may be coexisting SARS-CoV ground glass opacities that you're seeing. It could be a hiding of the pneumocystis jirovecii pneumonia as well. So absolute thought in the back of the mind should be present to not miss this. The treatment is usually with cotrimoxazole, sulfamethoxazole, and trimethoprim, and it is usually given in combination with prednisolone, and especially in those in the urinary free cortisol levels that is greater than 20 times the upper limit of normal, the incidence of pneumocystis jirovecii pneumonia is higher, and it should be continued for a period of at least 2 weeks. The side effects of these drugs should also be kept in mind, and especially when given in concurrence with ketoconazole as well. Also, the most important point is we can look for influenza and herpes zoster infections that may occur in this immunocompromised state. And please keep in mind that live vaccines should not be administered in these patients. So what is the goal of my pre-surgical medical treatment is to reduce the signs and symptoms, the symptoms that are being caused by Cushing syndrome, like hyperglycemia, hypertension, hypokalemia, infection, and psychiatric symptoms. But how do I reduce this hypercortisolemia? So here is where I choose drugs like metyrapone and osilodostrat, which block my 11-beta hydroxylase. And there is leading, because what is happening is there is accumulation of the oxycorticosterone and leading to indirect activation of mineralocorticoid receptors. And this have a side effect profile of causing hypertension. This osilodostrat, this was recommended for the treatment of hypercortisolism that is being produced in patients who are treated for Cushing's disease, but incomplete treatment. And they said that this effect is being useful in Cushing's syndrome as well. It's FDA approved for patients in Cushing's disease, in whom pituitary surgery is not possible or has been incomplete. And this has been found to be useful in decreasing the mean cortisol levels by around 3rd to 4th weeks. 5 more minutes, please. The other drug that we were discussing is metyrapone, where okay, ma'am, that 2 more slides there. Yeah. With metyrapone can be used. And other than this, we can use mifepristone, which is a glucocorticoid receptor blocker. And it is selectively used in severe diabetes in higher doses for its hyperglycemic effect. And it, of course, leads to termination of pregnancy. The other important drugs that we are seeing for interactions is going to be the ketoconazole, has a multi-level action that is going to lead to decrease in the production, urinary free cortisol levels by around 65% of patients. Last but not the least is going to be mitotane, which is not used in Cushing's syndrome as such for benign diseases, predominantly used in adrenocortical carcinoma, has a delayed onset of action of around 8 weeks, but has a high toxicity profile. Now, what else am I going to look for is proximal myopathy and osteoporosis that may coexist. And I have to consider treating these patients with calcium supplements, vitamin D supplements, and bisphosphonates when required. So the largest database of Cushing syndrome is from the European Registry of Cushing syndrome, ERCUSYN, where they said that preoperative medical management in Cushing syndrome, whether it was directly useful or not, they found in one study in 2018 that those who were treated with medical management had a postoperatively less severe outcome compared to having a more severe outcome in whom direct surgery was done. And they said that there is a higher incidence of Cushing's in the elderly, and there are higher prevalence of thromboembolic events in patients suffering from Cushing syndrome. And they recommended usage of venous thromboembolic prophylaxis in the elderly and the high-risk individuals as such. So before we conclude, we take the patient up for surgery. So we have to see that whether the hypertension has been controlled, the electrolyte imbalance has been taken care of, the anesthetist has been informed for the difficult airway if there is any, whether we have taken care of prophylaxis that is required, whether the hyperglycemia has been controlled and the hypercoagulation state has been controlled or not, and then we take up for surgery. Saying a thank you from our institute, Madras Medical College. Thank you.
Sure. Thank you to Adarsh for nicely covering all the problems associated with these high-risk patients. They are really high risk for anesthesia and for surgery. So any questions from the house? So do you have personal experience of managing these patients, and what are drugs you had to use?
One was a 36-year-old female who presented with a 6-month history of hypercortisolism. And we started her on ketoconazole. She had fungal infections. So we had started her on ketoconazole for 1 week and took her up for surgery. So we didn't see much of the side effect profile of ketoconazole in her, and we took her up for surgery.
Sure. Thank you. Thank you, sir.
Thank you.
Thank you. The next talk will be on management of pediatric adrenocortical tumors. I invite Dr. Lokesh Sharma for the same.
Good afternoon. Thank you for having me here. I'm Dr. Lokesh. I'm a ped endo person working in SGBI only. So we'll talk about a very rare condition, that is pediatric adrenocortical tumors. These are really rare tumors, which comprises of only 0.2% of all pediatric malignancies. and their incidence is also so very rare, that is 0.2 to 0.3 new case a million a year in any population. It is extremely high, specifically in Brazil, because of one founder mutation. Otherwise, all over world, this is the same. And they have more genetic and epigenetic alterations in pediatrics compared to adult people. And specifically TP53 and LNP loci are more commonly known to have genetic alterations in pediatric population. So peak age of incidence in pediatric population is less than 5 years. And that overall, if you are talking, then there are another peak that will be in the 4th decade. So there are 2 peaks of adenocortical tumors in whole life, first in first 5 years and then in the 4th decade. And there will be a smaller peak in the 2nd decade also, but that is compared to all these 2 peaks, that will be smaller in adolescent population. So how do they present? Compared to adult population, pediatric patients are mostly functional tumors. So they will have some endocrine syndrome. Mostly they have virilization features, and commonly they have comorbidity of the Cushing syndrome also. So that is nearly, I will say, nearly 90 to 95% tumors are secreting tumors, and nearly 80 to 90% will have some syndrome. And virilization is the most common out of these, and Cushing syndrome is the comorbidity in many of them. Other than that, feminization or gynecomastia may be there due to estrogen excess, testosterone producing tumor and converting enzyme, converting to estrogen. They may have feminization features, and signs of hyperaldosteronism and hypertension, hypokalemia are also possible in some subset of patients. And tumors are large. If tumors are larger than 10 centimeter, adenocortical carcinoma and older children, then there is more likely that they will have Cushing syndrome. Coming to the evaluation of adenocortical tumors in children, labs, like that is a first thing we will do, because they will come to endocrine side because they are functional tumors most commonly. So what we do all the function, all 3 layers, that is ACTH, cortisol, 17-hydroxyprogesterone, androstenedione, DHEAS, that is commonly available and commonly detectable also, testosterone, estradiol, renin, and aldosterone. So by this, we will do profile of the all 3 cortical layers. And plasma DHEAS, that is nearly present in all patients in pediatrics, and that is a sensitive marker to diagnose as well as for surveillance also. So other than this endocrine workup, we do routine workup also to see the comorbidities and complications. That will be complete count, renal function, electrolytes, LFT, coglogram, blood gas, X-ray spine or BMD, depending on our situation, and urine routine, blood glucose profile. After lab workup, imaging is also necessary. Ultrasound is sensitive mostly in larger tumors, that is more than 3 centimeters. But ultrasound is specifically useful to see vena cava invasion. It can see vena cava invasion up to atrium. That's a simple investigation and can see but it can be used for one very useful information. Other than that, CT and MRI, these CT is preferred, and it is mandatory to have a CT or MRI depending on the situation to localize, like to see the extent of the disease before going for surgery. And MRI is very more useful when we see a syndrome, genetic syndrome, and we are expecting that long-term surveillance will be necessary. And other than that, functional scans can be done specifically in METs, or when we are seeing recurrence, FDG PET can be used, is being used most commonly. And there is another tracer which is more specific than FDG, that is metomidate, but there are more evidence needed to use in common condition, in common practice. So like Dr. Jafar talked about the radiological features of adrenal tumors in all populations, but in adenocortical tumors in children, in spite of having all the things, like we can have heterogeneity, we can have necrosis, we can have calcification, still we may not be able to tell whether it is adenocortical tumor is benign or malignant. So so we should have a thought in our mind that despite the all radiological signs which we have in radiology, only the presence of regional invasion or distant metastasis, that is a telltale sign that it is malignant. Otherwise, it is difficult to define them radiologically as well as histopathologically. So coming to histopathology, it is difficult to differentiate adenoma from the carcinoma. He described first how to differentiate between adenoma and carcinoma in adults. Then it was modified. So then it came to modified Weiss criteria. Modified Weiss criteria is most commonly used as of now, but now there is enough data that pediatric adenocortical tumors should be categorized by Beneke criteria. It has some modification of the modified Weiss also, and it is more specific for pediatric populations. We'll talk about that. What is the Beneke criteria and how it is different from the Weiss and modified Weiss. So tumors exhibiting histologically benign features may have late metastasis or late recurrence, whereas patients with tumors having a microscopic appearance typical of malignancy may have survived for years. So this is the evidence that in spite of every radiological or histopathological evidence, we may not be able to be very sure that it is adenoma or carcinoma in children, more it is like in children. So how to stage local, regional, and metastatic diseases? We all know, like any other carcinoma or tumor. So 75% will have local disease that will be categorized in stage 1 or 2, depending on the size or resectability. Smaller tumors with full resectability will be stage 1, and larger tumors more than 5 with complete resectability will have stage 2. While around 10% will come with the regional invasion. So that will be local disease, but it is invasive to adjacent organs. And around 15% will come with the metastatic disease, that is stage 4. And it is commonly hematogenically spread at liver, lung, brain, and bones. So these are the criteria which are currently are in practice in pediatric ACTs. IPECTR is it is the largest registry. It is International Pediatric Adenocortical Tumor Registry of the St. Jude's Hospital, USA. They have the largest cohort in the world, and they keep publishing the data, I think, from 1980s. And other than that, there is another group that is COG, Children's Oncology Group. That is an umbrella group which studies all the cancers in the children, and they also validate all the data coming from the other organs. So that IPECTR criteria, which we already discussed, tumor completely accessible and small tumor, stage 1, accessible larger tumor, stage 2, locally invasive, stage 3, and MATS is stage 4. And that Sandrini system is another system which is also validated and is being used in many countries. Nearly same, but they are taking size as volume rather than grams. That's it. Other things are same. So how to define benign versus malignant? These criteria used to be this is the oldest criteria. It was defined in adults first. Then it was modified by some criteria and it became modified Weiss criteria. Now we have Beneke criteria. So that Beneke criteria has 9 categories. Out of them, these are the, you can see my cursor. Do we have a pointer? Okay, so initial 2 are depending mitotic indices, number of mitotic activity and presence of atypical mitotic figures. Then we will have presence or absence of tumor necrosis, then venous invasion and capsular invasion. Other than these, other criteria depends on the tumor grossing. So how much tumor weighs, tumor size, extension into the adjacent structures, and invasion into the IVC. So these 9 categories each will have 1 point, and points 4 or more than that will have adenocortical carcinoma. And 3 is indeterminate, and less than 3, like 1 or 2, will be having benign tumors. So this is how they define, slightly different from modified Weiss. The same criteria has been taken in the latest WHO classification, which was published before 2 years. So they have taken the Beneke's criteria exactly same. And in addition to that, they have added 2 desirable points. So these are the IHC markers. If we have P53 IHC showing loss of P53 and Ki67 index more than 15%, that will be indicative of carcinoma. So this is how to stage. Then coming to the genetics of ACT, this is also very important because this is different from the adult people. And many times, most of the times, you will be getting some genetic abnormality than not. So TP53 loss of function is carried by nearly 75% children who come with adenocortical tumors. It may or may not be associated with the leaf-Romani. Same way, IGF-2 overexpression, it is very common, but it is in somatic mutation. So it has to be detected in the tumor cells, and nearly all patients will have some alteration in the IGF-2. It may or may not be associated with the Beckwith-Biedman again. This is same locus 11p15 is associated with the Beckwith-Biedman syndrome, which has a predisposition of the adrenocortical tumors. But children in all ACTs will not have Beckwith-Biedman, but they will have very likely some alteration in the IGF-2 expression. Other than these, Lynch and Meneman syndromes are associated with the adenocortical tumors in children. 9q copy number gain and 4q34 loss is also associated loci, and somatic mutations of ATRX and CTNN1B. NNB1 are other loci which are associated with the ACTs in children. So, all in all, genetic testing and counseling is recommended for all the patients who come to us with the adenocortical tumors. So, treatment, how to treat? Sir, everything has been taken from adults. So surgery has to be done. Stage 1, 2, 3, there is no doubt. We have an unequivocal evidences. R0 or R0 rejection whenever possible. We can do unblock rejection whenever we need to reach to R0. And these tumors are very friable. So open surgery is still preferred or standard of care to prevent the spillage. Medical management, same as taken from adults. Mitoten is the only thing which is proven some evidence till it is standard of it is not standard of care in children. Same things we need to take care that it has very low therapeutic index, so drug levels has to be done. Doses are also same, like 4 gram per meter square. Other than mitoten, cisplatin, etoposide, and doxorubicin have been used with varied results in combination with mitoten, not alone. And endocrine endocrine treatment, hormone replacement has to be done because contralateral adrenal will be invariably suppressed. So we need to replace with the adrenal hormones, and supportive care in form of fluid and electrolytes, hypertension management, and prevention of the infection and wound care. And radiation does not have a standard of care approach, but in children who have margins left and they have T53 mutation positive, then we can offer negative. T53 mutation negative has to be negative. If we are offering radiation, then we can offer them radiation, local radiation for the prevention of recurrence. Prognosis, it's not great, variable. 5-year survival near 30 to 70%, though it varies depending on the size of the tumor, age of presentation, and resectability. Smaller tumors, early age has better prognosis, up to 70 to 80% 5-year survival are there in studies. And larger tumors, invasion MATs have very poor prognosis. 5-year survival in children with MATs is nearly 20% or less than that. So these are the two Indian studies that are found in recent years. One is from our center and one is from AIMS. So prognosis was not great in our study. At 12 months, 41%, 24 months, 20%, and 60 months, no survival. In AIMS study was somewhat better, 75% and 44% was the overall prognosis and event-free survival. But in this study, like mostly children were stage 2, 3, and 4, mostly 1, 3, and 4. In that study, like majority were stage 1 or 2. So that may be a difference causing a difference in outcomes. Thank you.
So thank you, Dr. Lokesh, for nicely covering all the components of pediatric adenocortical neoplasms. My just one question was that have you used mitoten in children?
No, I don't have personal experience. It's very difficult to get, and actually we do not have unequivocal evidence also in children. So stage 3, stage 4, it has been extrapolated from the other studies that can be used. Stage 1, stage 2, like we don't use.
We don't.
Stage
Okay.
3, stage 4 we can use, but majority I will say it's very rare. I think we will get one case a year, not more than that. And most of the time we are not able to get mitoten.
Sure. Thank you. Any questions from the house? Yes, Gyansa.
Yeah. Excellent presentation, Dr. Lakesh. Just I want one small clarification that is FDG PET is mandatory in all children with cortical cancer?
No.
But you have in your slide, it was mentioned that it is not because on the imaging wise, it is not possible to detect whether it is benign or malignant. So you write that FDG PET is there. So does it mandatory?
No, like on the conventional imaging, if we have seen if there is another lesion and we are suspecting METs, then we should go ahead. Otherwise, it's not mandatory. They didn't write.
But you told that on the imaging basis, you can't differentiate whether it is benign or malignant.
No, is like we have done. We are doing CT or MRI. We will also do chest and abdomen with that.
Okay.
If you are getting any other lesion.
Okay,
then
so you do the metastatic workup with chest,
yeah, that
chest and abdomen CT or MRI, and then if you find lesion, then only
then
go for the.
it's required. If you are suspecting METs.
Okay, thank you so much. Thank you for clearing.
Like sir, from data wise, 15% only large registries have shown only 15% will have METs at presentation because they are large tumors, and in children like we are like they are mostly symptomatic, so they come earlier than in adults. Any other question? Okay.
Thank you, sir. Now I'll invite Dr. Anish Cherian to deliver the talk on management of adenocortical carcinomas. What is new?
Good afternoon. So what's new in the management of ACCs? We know that ACC is present in about the 5th and 6th decade of life, and predominance is in females. Majority present with a functional tumor, and most of them are cortisol secreting. A subset present with vague abdominal symptoms such as a mass or abdominal pain, and a minority are incidentally detected. Majority are sporadic, whereas minority are hereditary, deformity being the major cause of hereditary syndrome. In pathology, we know that SF1 is the most reliable and specific biomarker for tumors of adrenal origin that are cortical. So if you have a non-functional tumor and you not sure whether it's cortical or medullary, then the IHC that is used is SF1. And traditionally, to differentiate benign versus malignant tumors, we have been using the WISE and the modified WISE scoring system, the score of 3 or more that indicates malignancy. So what's new? The WHO 2022 classification of adrenocortical tumors expands the use of other multi-parameter diagnostic algorithms to assist the workup of adrenocortical neoplasms. And these include the reticulin algorithm, the Lin-Weiss-Viskili system that is mainly used in the oncocytic neoplasms, and the Helsinki scoring system. It also underscores the diagnostic and prognostic impact of angioinvasion and highlights the role of IHCs and molecular markers for ACC. With regards to the multi-parameter diagnostic algorithms, the most popular is the reticulin algorithm because of its reproducibility. And here, using the Gordon-Sweet silver histo stain, where there is a loss of reticulin framework or an altered reticulin framework, along with one of the following features, that is mitotic count more than 5 per 50 hyperfield, tumor necrosis or vascular invasion that would suggest that it is a malignant tumor. The Helsinki scoring system uses 3 parameters: mitosis more than 5 per 50 hyperfields, score of 3. Presence of necrosis scored as 5, and they use a numeric value for Ki-67 proliferation index. And in this system, when you have a score of more than 8.5, it suggests that the tumor is malignant, and a score of more than 17 predicts an adverse prognosis. So this system incorporates both diagnostic algorithm as well as prognostication. The definition of microinvasion is tumor cells that invade through a vessel wall and form a thrombus or fibrin tumor complex, or an intravascular tumor cells that are admixed with platelet thrombus or fibrin. So we know now that microscopic angioinvasion is also a prognostic factor in adrenocortical carcinomas. With regards to IHC and molecular biomarkers for ACC, the 2022 WHO emphasizes the importance of an accurate assessment of proliferation rate. And this includes the mitotic count and Ki-67 index. So if you noticed from all the previous criteria, the mitotic count that has been one of the criteria is if it is more than 5 per 50 hyperfield. So this indicates that there is an increased mitotic activity. With regards to the grade, they have subdivided ACCs into low grade and high grade ACCs depending on number of mitosis. Less than or up to 20 mitosis per 50 suggests that it is a low grade ACC, whereas if it's more than
20 mitosis per 50 hyperfield suggests it's a high-grade ACC. In patients with a low-grade ACC, sometimes it's difficult to identify the mitosis, and in this situation, the IHC that is used is a phosphohistone H3, as seen in this photomicrograph. The slide above is a low grade where it's sometimes difficult to pick up the mitosis, and in that situation, we can use this IHC. Previously, we knew that SF1 is a diagnostic marker to tell you that it is a cortical tumor. If you want to know if it is malignant, the marker that has been shown to be of good value is the IGF-2. Poor prognostic markers include P53 and beta-catenin. Now, regarding the management, we know that as the stage increases, the prognosis worsens. For localized tumors, the treatment of choice is complete resection with R0 or negative margins, and this is the only chance of cure. The extent of surgery would include en-bloc resection with periadrenal and hilar lymphadenopathy. In the metastatic setting, there is a role for debulking only in the subset of patients where there is severe hormonal excess that cannot be otherwise controlled, and about 80% of the tumor burden can be safely removed, or in a situation where there's perceived risk of local complication without other treatment options. Regards to the adjuvant treatment, mitotain has been universally given post-surgery on the basis of about 7 or 8 retrospective studies suggesting prolonged time to recurrence with mitotain. However, there have been conflicting evidence reported, and there is also challenges with administration of mitotain. So with this background, there was a trial between 2008 to 2018 that was specifically targeted to low and intermediate risk ACCs to evaluate the efficacy and safety of adjuvant mitotain compared to surveillance alone following complete tumor resection. And the findings suggested that there was insufficient evidence that mitotain efficacy and suggested that active surveillance is adequate for low-grade and localized ACC. Further, 2003, there was another trial, and this was aimed at advanced ACC to establish the treatment standard. When we say advanced, these are a subset of patients who are not amenable for surgical resection. This cohort was randomized into a group that had received etoposide, doxorubicin, cisplatin, and mitotain, and the other cohort was those that received streptozocin and mitotain. The group that received EDP plus M showed better response, significantly better response, better progression-free survival. However, there's no difference in overall survival. So from this, the current algorithm for management of resectable ACCs is that the low-risk group, that is the NSAT stage 1 and stage 2 with a Ki-67 less than or equal to 10%, active surveillance is adequate. The standard risk where the NSAT stage is 1 or 2 with a Ki-67 11 to 30%, or a stage 3, the Ki-67 less than 30 would benefit from adjuvant mitotain, and the rest would receive systemic therapy. Advanced and metastatic disease, the treatment of choice would be systemic therapy, first line being EDP and mitotain based on the previous trials, second line streptozocin and mitotain. The issues from these, the issues that we know are that in localized ACC, after complete resection, the reported recurrence rates is close to 50%. Advanced metastatic ACC, the objective clinical response to the best available therapy is less than 25%. So therefore, there's an undeniable lack of efficient drugs for treating ACC and the need for identification of newer therapeutic agents. And therefore, there have been multiple clinical trials trying to find out what drug or the best drug for adrenocortical carcinomas. I've just listed out or shown a couple of trials. This set of trials was done on the IGF and the mTOR pathway. And as you can see, there's a very dismal response. TKIs have also been tried. Again, the response has been dismal. This may be because mitotain induces CYP3A4 activity, which leads to rapid metabolism of some of the TKIs. And many of these trials have been performed on patients who are receiving mitotain as well. So recently, there was a trial with cabozantinib, and this was in a cohort of patients that did not or stopped mitotain for a considerable duration of time. And there was some evidence of response. So there are 2 ongoing phase 2 trials with cabozantinib, one in Europe and one in US. Immunotherapy has come in a big way in treatment of cancers. In ACC, in the tumors, we know that there is a low degree of T cell infiltration and they are leukocyte deplete, maybe because of intratumoral glucocorticoid exposure. And there are 4 trials that have sort of looked into immunotherapy, again, with not very good responses. The molecular profiling of tumors, now this is just in the lab, it's not been translated to the bedside. We have categorized tumors into 3 risk groups or clusters, depending on the mutational pathways that have been seen, the RNA expression, the chromosomal landscape, and the DNA methylation. And these clusters are the cluster of cluster 1, which shows low disease progression rate, cluster of cluster 2 with an intermediate disease progression rate, and cluster of cluster 3, which shows a high degree of disease progression. So maybe the future would, we would see AI that is being used in the diagnostic workup, identification of markers to predict response to therapy, tumor sequencing, molecular profiling as the clusters has been shown, may support therapeutic decision-making, and identification of drug combinations with improved outcome, and screening and follow-up, maybe non-invasive techniques for early diagnosis and detection of recurrences. So just 2 readings that I thought would be good for the postgraduates if you have time to go back and read. Thank you.
So thank you, Anish, for that widely, nicely covering all the aspects of the latest advances, though there a lot more needs to be done to understand it. So have you used TKIs in metastatic setting or anything new?
So when we look back at the data, there were only about 2 patients that we've used immune checkpoint inhibitors, but again, the numbers are very low and not much response, so not really something that we would try in the future.
Immunotherapy?
Immunotherapy, we have not used as of now. Yeah. Mitotain is what we go to, but again, like our previous speaker said, mitotain is difficult to get, cost is prohibitory, and we reserve it for patients who are in metastatic setting.
And have you gone for laparoscopic approach if you suspect ACC in the beginning?
Yes, so I think laparoscopy is not contraindicated. It depends on the experience of the surgeon. It also depends upon the extent of the disease on the imaging. So if it's localized and it's operable, as long as your surgery follows oncological principles, laparoscopic is still safe.
Sure, thank you. Any questions from the house?
Do you have any experience with the FAPI therapy for metastatic ACCs?
Sorry?
FAPI therapy,
No.
fibroblast activation.
No.
Okay. We recently tried in few patients and the response is good. However, we could not convert them into operable states, but they definitely prolonged the survival. At our institute, it's currently under trial, so it's currently free of cost. Thank you, sir. And this concludes this session. I now invite the organizers to take it further. Thank you.
Thank you, speakers. Thank you, sir. Up next is much awaited quiz coordinated by Professor Sabaratnam, sir. May I invite, sir?
So yesterday also I was in a hurry to finish my talk in 3 minutes. People were very happy. I don't think I should do the same thing again, actually. So if one part is not done, then forgive me. And then we start off with this. Please raise your hand and answer. It's interactive quiz. Anybody in the hall can participate. And then we will have a formal quiz, actually. So this is the first. Anybody can say when these two rhino coughs did our respected Chief Minister Yogi Adityanath ji bring in? So if you answer that, I'm giving a prize. And if you say the name of two calves, I will give this sword actually. Two rhino, he is very fond of rhinos actually. Anybody, nobody there? Okay, if that is not the question which you are just put in.
So I don't even know where to start. He's such a huge creature. He feels like just like a rock.
Yeah.
How much does he weigh?
So he weighs about 4,300 pounds. So that's a pretty average size for an adult Indian rhino male.
Standing on his all fours right now, he's probably.
Actually, this is an Indian rhinoceros. Now, can anybody say the difference between one horn Indian rhinoceros and African rhinoceros? See, actually, by the time one Prachi, you want to try? Yeah, please. Single horn and two horns. Okay, one difference. One price you give. Second, somebody try. This is not a very difficult question, is it not? Yeah, please. I should hear. Beak mouth. Okay, you can give beak mouth in which rhinoceros actually? See, which one lives like solo and which lives in herd? Okay, so I will tell the answer also. Dr. Yogi Adityanath ji, our respected CM, brought the two rhinoceros from Assam in 2022. Har and Gauri, actually they were named. Whenever he visits Gorakhpur Zoo, he takes care of them. One horn rhinoceros is Indian rhinoceros, two horn is African. African will feed on bush. Indian rhinoceros grass, it lives alone. African rhinoceros will live as herd. Okay, and one more, because rhino is very close to us. Why is Indian rhinoceros the mascot of endocrine surgery? Like full answer, please. Okay, give her one prize. Like Richard Owen, Sir Richard Owen, when he did an autopsy, anybody knows the story of one horn Indian rhinoceros? Which article was published in World Journal in 2010 by Martha Elger, which said the story of an Indian rhinoceros? What does it say actually? Yeah, please, you can tell me the story in line. Yeah. Like actually it is okay, you can give one to it's like the Indian rhinoceros had been there for 13 years in that zoo, and Indian elephant was purchased by the queen, and they thought Indian and Indian will go together actually. But elephant are creatures, when there is a space sharing and water, this one, they become ferocious. There was a rib fracture, as you said, and a pneumothorax, and the rhinoceros died after some days, and he had conducted autopsy for more than 4 years. The death of an Indian rhinoceros by Martha might be in World Journal of Surgery, I think August 2010 issue. Okay, so you all should read that actually. So I will make life little easier actually, because okay, that is from a Coolie movie. Anybody knows what is the concept of that movie? Lokesh Kanagaraj. So, okay, it is based on killing people and transplanting their heart, actually. Do you know who did the first heart transplantation in the world and when? At least who did the first? Yes, sir. For sir, you give one. Sir Christian Bernard did the. Sir, ko de do bhai. Mm. Okay, this one, anybody knows this movie? Somebody was told, yeah, you give one prize, but see, actually, there was a study published in Journal of Endocrinology regarding the incidence of increase in thyroid cancer in Kerala, actually. Anybody knows which study and what? Because being a very small state, but so much rapid increase in incidence of thyroid cancer. Yes, sir. Yes, sir. Sir, कोई एक दे दो. Ma'am, sir has been passionate. I was sir's student. Sir has been passionate about history of endocrinology and endocrine surgery. So I'm very happy. Thank you so much, sir. Now we go to the formal quiz. I have a lot of questions like that. Just open karne. We will have 40 seconds. Okay. So I thought if my residents are busy, so I pasted the slide as well. So 40 seconds. No, surgeons need anticipation actually. So 3 pioneers who established Indian Association of Endocrine Surgery in India. No, because history, like, see, actually we all need to know, is it not? Yes, sir. This is a formal question, sir. They are writing. Paper to the paper. We have 3 named orations named after them, and 4th one is named after our Professor Mishra, sir. So we need to know them. Who are the 3 pillars? Three pioneers. Okay. We had on the first day, I have taken questions from what has been demonstrated so that you will, what surgical procedure or technique is being performed? I think it will, like, all of you are so bright and brilliant. I think 20 seconds is more. Huh? Mithilesh is saying gala dinner. So we have a session, 2 sessions. How does an auto-transplanted parathyroid survive? This I took from Talabadi sir when he came as an examiner. He asked this question actually. I was co-examiner, so once you auto-transplant, how does a parathyroid survive? Meenakshi ji, you are writing? You are not participating, okay. So one of the most, this is a very important thing. Discovery is to see what everyone saw, but to think which nobody thought. From Sweden. School Uppsala. So thyroidia artery, what percentage of individuals will have this artery? Arteria thyroidia ima. Previously used to ask also from Dilip has seen one here. Huh? So identify this nerve, name the space, and what classification is used. This is quite straightforward, is it not? See here, adrenalectomy has been done for a pathology, and I want you to name the landmark paper. You have some clues also. That's a flag, and that's the place actually. Or if you want to make myself little easier for you, it's a myelolipoma operated. Landmark paper on this or lipomatous lesions of the adrenal gland. Madam has told already, I have given the answer actually. This was Madam's favorite question. This country, city country or something like that. And it starts with the hospital institution name starts with Queen. And more than that, I think then I will tell the answer myself. Is it not? Okay. This is a modified V scoring for a patient. The score in this patient was 3 out of 7. So I request you to interpret this score. This is IPTH monitoring. We have many criteria actually. At least name 2 criteria. Most of them are named on the cities, is it not? Huh? See. All are named. All are cities. Okay. So Lugol's iodine composition. We are not using. This is an FNA from a rapidly growing thyroid nodule. Diagnosis. Excuse me, like to. This has been shown in the endopathology session today morning many times. Diagnosis and then 2 nuclear features.
This is a X-ray of a patient who had multiple kidney stones, actually, with fragility fracture. Mention the finding and what would be the cause for this X-ray finding. At least 1 or 2 findings should do, and what would be the cause for it. Okay. This also has been, there was a talk some 2 hours back. Name this approach for parathyroid disorder and any 2 adjuncts which can be used for performing successfully this operation. These are all quite straightforward, is it? Child with the cyst in the midline, spot the diagnosis, diagnose the condition, and suggest the surgical procedure if you're operating on this child. Another 2 minutes, I'll finish so that we don't. Or should we finish with only 15 questions? Huh? Diagnose this condition. At least 20 questions will. Newer drug, which is now available, FDA approved for this condition, eye condition. See, we use the term commonly sutureless thyroidectomy. Some of us use ligashore, some of us use harmonic. Just to mention the mechanism in a single word or 1 or 2 words. How does ligashore work and how does harmonic work? And name this condition. This patient had a huge thyroid gland and we operated. That's a trachea there. So some people say it's a myth. This condition doesn't exist at all. But we see this condition often, especially in very long-standing goiter. And somebody said FAPI. We also have an investigation which can avoid ASVS in diagnosing cons. So what is this newer imaging modality? Yeah. So this is the one. Before I'll give a breather of 1 minute for you to just and see, actually, I do not want to take this with me and go. If whosoever answer, just to put the thing on. This identify this famous person. Actually, when you can exchange your answer sheets, we'll correct this one also. First attempt itself, if anybody says this one, he said this. Usually, he was referred to as an outstanding general surgeon in the world today. At the time of crisis, he was never known to lose either his head or the nerve. First and foremost, he never allowed himself or his assistant to forget that they had a human life in their hands. Surely, but for him, thousands of lives would not be alive today. Second, he was the surgeon who was invited to review the reports of the then president of US, Theodore Roosevelt, and he advised him not to contest the second time. Sorry. And third, there is a bridge named after him. fourth clue, many of you will answer, but one of whosoever answers first, because that is going to be a easier one. And anybody till now? Sir, this is a fourth clue. Huh? Stop. Frank Lahi. So sir ko de do bhai. He was Frank Lahi actually. Sir. नहीं sir, वो actually Frank Lahi was the surgeon. So भैया एक fourth, can one of the assist? भैया sir को दे. So thank you so much, sir. Actually, like I am very, very indebted. This one, band kar de. So that was Frank Lahi, sir. Yes, sir. So we go to the answers. If you interchanged your answer sheet, you can correct for others. So 3 personalities, Professor S. Vittal, Padma Shri, Professor S. Vittal, sir, who was the founder president of IAES, and then Professor Dr. R. Jyotiramalingam, sir, and Professor K.D. Verma, sir. These were the 3 people. Second one, rabbit technique, what is robotic assisted breast axilloinsufflation thyroidectomy. Third, by imbibition. Fourth, he was Ivor Sandstrom, who said, discovery is to see what everyone saw, but to think which nobody thought. Thyroidema in 0.4 to 1% of individuals. That was external branch of superior laryngeal nerve, space of Reeves and Serenia's classification. There are many classifications you can name. This landmark paper on myelolipoma, Lowe and Lamb's paper from Queen Mary's, Hong Kong. And the present score, more than 3/7 suggests malignant behavior. Miami, Vienna, Halle, Rome, and Lucknow criteria, 9 criteria, many criteria are there. Lugol's iodine consists of iodine 5 grams, 10 gram of potassium iodide, and 80 ml of distilled water. This FNAC is anaplastic thyroid carcinoma or an undifferentiated thyroid carcinoma, where you can see squamoid cells, spindle cells, and giant cells. This was discussed many a times. Papillary thyroid cancer, whatever 2 nuclear features you have written, I am happy with that. The 13th question, the answer was primary hyperparathyroidism, subperiosteal resorption, tufting, and squaring of metacarpals, you can say. And the procedure done was focused or a selective parathyroidectomy. Adjuncts include IOPTH, frozen section biopsy, FNAPTH, methylene blue, radio-guided parathyroidectomy, intraop ultrasound, ICG, ionic calcium, something like that. So 15th question is thyroglossal cyst, and the operation is cyst trunks operation. 16th is large goiter or an MNG with retrosternal extension. You can see the dilated veins. The newer drug for this Graves' ophthalmopathy, Tepeza or treptotumumab. And mechanism of action, like in harmonic, it's a mechanical vibration, ligashore pressure and current. So the 19th question is, the answer is tracheomalacia. And we have published quite a bit in tracheomalacia as well. And the 20th question answer is gallium pentoxifer PET scan. We have done in around 5 patients. Thank you very much. I hope you learned something through the quiz. And answer sheets, you can give it to, if you are corrected, it's fine. Otherwise, I will correct and announce the winners. Over to the organizers for this.
We have now reached the conclusion of today's scientific program, and it's time to move forward with the alumni event. The theme of this meet is endocrine surgery training and practice in India. This session will be moderated by Professor Dr. Gaurav Agarwal, sir. I would now like to invite the esteemed panelists to the dais. Dr. S.K. Mishra, sir, Dr. M.J. Paul, sir, Dr. Pooja Ramakant, ma'am, Dr. Dalapati Sadacharan, sir, Dr. Divya Daya, ma'am, Dr. Farhanul Huda, sir. I request Professor Gaurav Agarwal, sir, to deliver the introductory remarks and theme setting. Later, we will also be having discussion of responses by our alumni and eminent endocrine surgeons collected through a Google form circulated earlier. This will be followed by an open house discussion. Thank you. Over to you, sir.
Okay. Good evening, everyone. So I'll request everybody to please come, take your seats. We'll then start this, what we are calling as, then we'll start this as the PGI Endocrine Surgery Alumni Session. And this year we have a theme to this session, and that theme is Endocrine Surgery Training and Practice in India, the Way Forward. So what we have planned is to have few components or parts of this session. We have some experts in front of you who are all, I mean, I don't think I need to introduce any of them to you all. They are representing one major academic institution which is running MCH program in endocrine surgery. Professor S.K. Mishra has been the long-time head of department at SGPGI. Now he's at RML Institute of another institute in Lucknow. Dr. M.J. Paul, he's the head of, has been the head of endocrine surgery at CMC Vellore. Dr. Divya Daya, she is the chief of endocrine and breast surgery unit at PGI Chandigarh. Dr. Farhanul Huda, he is the professor in charge of endocrine and breast and endocrine surgery unit at All Institute Rishikesh. Dr. Dalpati Sadacharan, he is the current officiating head and associate professor in endocrine surgery at Madras Medical College, Chennai. And I request Dr. Pooja Ramakant to kindly come up. So Dr. Pooja Ramakant is professor of endocrine surgery at KGMU, Lucknow. So this panel is representing majority of such institutions which are running MCH programs in the country today. So we have sent out a set of very simple few questions to these experts and few other experts, asking for their views about what are the challenges with endocrine surgery training in India currently and what are their suggestions to improve the scenario. Later on, we will also discuss some feedback or views that we have collected from alumni of the department on similar themes, and perhaps also on additional themes like what challenges they face in practicing endocrine surgery in the country, and again, what are their suggestions. So let me first start with sharing, or maybe Divya can help us doing it. We sent out a Google form with a set of questions. Is it? And while this is being set up, I request all the alumni of the department, call up your outstanding colleagues. There would be a few, or rather many, standing outside, outstanding. So while we are discussing it, we will hear from the experts, the senior people, but equally I welcome views from all others who are there in the audience. Many of you, I can see, are senior people and have a lot of experience with training.
Okay, can you see these? Can you increase the size? So endocrine surgery training in a formal way started more than 2 decades ago, or rather 25 years ago in the country. It's, or I'm sorry, 35 years ago in the country. So it's been a long time, yet unfortunately, we still are one of the smallest super specialty or surgical super specialty community. And that begs a question. Why is it that we are still not such a big community as compared to majority of other super specialties? But being such a small community, a close-knit community, we also have certain strengths. So let's start with discussing what are our strengths of this specialty. And the experts were asked about what, in their perspective, what are the major strengths of endocrine surgery training in India today. A majority of them considered strong surgical skill training with high clinical exposure, structured academic training and research opportunities, experienced mentors and faculty guidance, and alumni networking opportunities. And these were views shared by majority. And of course, a few of them also considered opportunities for networking through CMEs and PG courses and collaborative knowledge sharing networks and interactive session with other departments and institutes. So I'll just go through these one by one and then we'll discuss them again. Then we also asked them what are the strategies in their mind, how we can improve or strengthen the endocrine surgery training in the country. A common theme that emerged has been standardized curriculum across the country, which fortunately is a reality today. More hands-on surgical opportunities during training, interinstitutional exchange, and this is a unique response because all the experts have had a consensus on this. And my take on this is that all of us believe that standalone, we cannot perhaps provide a complete, comprehensive training. And we can always fall back on our colleagues in other institutions to do that for us. And postgraduate course run by the Indian Association of Endocrine Surgeon, the International Association of Endocrine Surgeon, and certain other organizations. So those are what suggestions we have, but I'm sure there'll be more suggestions that we will hear during the course of this discussion. The third question we asked was in the opinion of the experts, why do we have such few endocrine surgery training programs in India at this moment? And the largest or the commonest view expressed was lack of awareness of endocrine surgery as a specialty in our country. And I can't agree more. This is something we need to ponder upon and then try and find a solution to that. Of course, there were other important things which were brought out, including reluctance of medical institutions and colleges to start a new department or a course in endocrine surgery, considering it to be very narrow or focused specialty. There are other issues too, like stringent requirements of the National Medical Commission to start new courses and departments. But of course, these can be circumvented with some effort. We also asked the experts what are in their views, the key challenges in practicing endocrine surgery in the country today. And again, the limited awareness about our specialty in minds of or in the especially in the medical fraternity for referrals and for not just referral of patients, but also encouraging training in this area. Overlapping with other subspecialties is a major issue. We have overlap with head and neck surgery, ENT surgery, general surgery, surgical oncology, urology. But then such an overlap exists with almost all other super specialties as well, or majority of them. How we can circumvent this is something we will get to discuss later. And according to some, the low remuneration or employability of trained endocrine surgery is a problem. Again, something which has been discussed quite often. What factors did the experts think are the most important ones for strengthening endocrine surgery practice in India? And greater public and physician awareness was opinion expressed by all of them. And again, there cannot be two opinions about it. Besides stronger alumni networking and collaboration and acceptance by the government agencies, the National Medical Council and Commission and other regulators are the other things which have been expressed so far. And then we asked for other suggestions for improving and advancing endocrine surgery training and practice in the country. There have been a number of such opinions, and I will skip that for the moment and then ask the experts about their thoughts on these issues. So let me start with Professor S.K. Mishra. Sir, we have known you've seen the views that majority of people have expressed. What are your other thoughts? How can we move forward in improving the acceptance of endocrine surgery as a specialty, increasing both quantity and quality of training in the country, and having more centers offering training programs?
A very difficult question to answer actually, is because I've seen this growing in the last 35 years. So, many of you have joined later, you realized we started very in scratch. For any new specialty to come up, it takes time. After all, many years ago, it was only general surgery. Then everything has come up, neurosurgery, cardiac surgery, so many specialties, subspecialties, sub-specialties have come up. And they are not so far where people are doing only operation of thyroid surgery. Only. Now, of course, there are people who are doing only breast surgery and established. You have seen in front of eyes. Many of our alumni are focused only in breast. So how it will develop, it is evolution in process. It is still not established, especially for endocrine. It is no doubt is the youngest super specialty of surgery. We have to wait and see. And the centers which have been established now being competent enough to deliver structured curriculum-based programs, they should keep on doing their job. And the onus lies on the alumni. I always put a stress on the alumni because they are our ambassadors to take the message forward. And you can see in front of your eyes, they're all settled out in different places and they're setting up these things. And that's the only way to raise awareness so that you are the best in particular surgery compared to X number of subspecialties who are operating. And what is more important is satisfy your patient. I always, these are my favorite statement. Patients are ambassadors. They are our ambassadors. Just do a good job for the patient. Communicate well with the patient. Let them go back and talk about you only. That's the way actually. It's not the rickshaw puller who picks up the patient from the railway station and delivers in some nursing home and takes some commission and go away. Let the patients are your ambassadors to take it forward. Arrange number of courses, seminars, short courses, half an hour, half day, small event, focused on particular things. Like Paul raised this issue recently. I talk about the RML things. So RML cannot compete with all of you. This is a small organization with 2 faculty members, but they thought of coming out with this idea of unique concept of picking up small things, focused on only, okay, what are the pre-op problems, intra problems, like that. So I feel there are a lot of avenues and a lot of scope, a lot of ways, a lot of skills required. Think about strategically, think very futuristic way, and think in a very broader way how we can take this specialty forward. And senior people has to realize we are in a stage we have to really give people, raise youngsters, encourage them to go forward, right? And that's the only thing I can only suggest. There are roles of each and everybody, students, residents coming out. Now, one thing I want to tell all the alumni, you come sometime in the other response also. Never think that just doing MCH is enough. I personally feel, I also wrote something to Dr. Paul also. Tell me why in ISS, they have raised this bar of age, 40 years. Less than 40 years, young surgeons eligible for fellowships. It's not like that. Compared to the training programs all over the Europe, US and everything, they have a longer training program actually. There are different way of training program. Don't compare your training program with Europe or America. I think, Gaurav, you know very well when you started MCS program, how much of feedback you took from different countries and we landed up that thing. College also witnessed to that also. So it is different from different countries. It is you decide how you will train it. They need mentoring. I mentioned in that other sections also. They need handholding. They need something to address. There are many things not given in the book, not many things taught in during MCS. You land up in situations, and all of you must have experienced, which you have never seen. But if you have seen this person doing that way, then you can do it better way. So I feel, Gaurav, I think you have to think in a very innovative way. In our country, we have many challenges. Within these challenges, you can still develop. You have come a long way. Now almost 3 decades, more than 3 decades. We have teachers also have shown us how they have struggled to bring it up this level. They can still take it forward.
Thank you, sir. So patients are our best ambassadors or propagandists, if we may call them. We need to have an eye on continuing development and training. Dr. Paul, specifically on the issue of what efforts we, the established centers, can make, or what contribution we can make towards increasing the number of training centers in endocrine surgery in the country. How can we help?
Yeah. So I think first, as it came out in the survey, we have to understand the factors that are limiting the growth. So what is first mentioned was that awareness is less. So I think as institutes, what we can do is to make our programs more aware through different resources, the associations, maybe even through news or whatever. It has to be brought into the public context that this is a separate specialty. I think one of our main problems is the word endocrine. I think all of you would have, most lay people don't know, if you say endocrine surgery, what are you operating on? So unfortunately, since we are multi-site, we don't have the the use of having, say, neurosurgery or cardiac surgery is very simple to relate to. So that's a huge block, I find. A lot of people don't even understand the word. Now, unfortunately, I think that is a problem we may not be able to overcome. But what we can do is through public and through meetings, okay, endocrine equals, that has to sort of become like a mantra. Endocrine equals thyroid, parathyroid, adrenal. And what is the special aspects of this is, I would say, 2 Fs. It's the functionality and familial. That means you have to understand the medical functional aspect and the familial genetic aspects, which is what sometimes makes it difficult for other surgeons to practice in the modern context. And that's when they would refer, okay, we'll get a familial condition, I'm not aware, send it to the endocrine surgeon, he will sort it. Okay, it's a functional tumor, okay, it needs medical coordination, send it to the endocrine surgeon. So these are actually some of the strengths that keep it with us. Now, if we look, as we said, one of the major problems for us is each area is actually operated by someone else, unlike, say, neuro or cardiac, which are very specific. We are multi-site. So we have to show that our strength is, even though we are multi-site and not specific to one anatomical region, the 2 Fs are the building blocks of what make us a specialty. And that is what attracted many of us, actually, the aspect of the functionality and the familial aspects of the disease to this specialty. The third aspect, which is a problem now, is a question of breast interrelation. And when we are looking at the way the world is going, it looks like breast is taking off on its own. So we were for a long time hoping that we can make it endocrine and breast. We have to now think that that may not be so, because it seems to be separating. At the same time, when people who finish their training go out, what they find is the initial volume comes from the breastwork. And that is necessary for their survival. So looking at all these factors, the other side of the coin is how do we develop it in institutes? And now we have to realize in India, there are so many different models. Like even sitting here on the panel, we all come from different backgrounds. You have the classic pattern medical college which has all full spectrum training. You have a specialty institute training like SCPGI. You have medical colleges have only general surgery and need to develop specialties further. And you have private institutes which want to do DNB training or fellowship training. So we have to encourage the development of specialty in each of these areas. And since many of these are beyond our control, I think the focus would be in medical colleges to help general surgeons with interest form a subspecialty unit, which is what will then take it forward to become a department and then training. And there is a lot of resistance from general surgeons. We know that from interacting with general surgeons in medical colleges. But so that is one area where an association we can go into medical colleges. And I think we did that and try and develop the idea that, okay, this is a specialty which needs a separate unit. And that will help. The second possible way of doing it is to, instead of trying to go straight to MCH, try and have shorter training programs like fellowships. So some of us have fellowships. You have it in breast. We have it both in endocrine and breast. We do combined fellowship training, shorter 1 or 2 years, which will allow them, people come a little more senior level, not able to get a seat through NEET. They'll still get the training and may still join an institute and start some training there. So this model is another way we can do. I think that these are the two which will help us to increase the numbers in our country. Thank you.
Thank you. So yes, improving awareness, making it more acceptable, making people aware about what this specialty is all about, increasing employability by incorporating or keeping breast with us, don't bring it away. Two important things that you talked about. So, Dr. Dalpati, one of the issues that all of us, the experts and the alumni have all expressed is the low recognition or low acceptance by the regulators, the National Medical Commission, the government in general. What can we do? How can we improve this situation? How can we approach the government of India, various state governments, National Medical Commission, Ministry of Health, and impress upon them that there is a need for larger number or greater number of departments of endocrine surgery, or at least units of endocrine surgery in various colleges.
So good. The good thing is actually now the NMC, at least we have a curriculum which has been placed after previously we tried to do the endocrine breast surgery combined name. They didn't accept. Even the breast also is an optional. First they gave diabetic foot also we included, then they took it out. Then only at least we must have endocrine surgery. That was our minimal requirement. So that was done. But next over the years, what will happen is, let me be honest. We are competing with not only general surgeons, now ENT surgeons, if you see, they are coming in lot of numbers. Suppose even in Madras Medical College, you see 30 MS ENT seats are there, 30 per year. So on any day, 100 MS ENT students are there in Madras Medical College. So if you see all over the state of Tamil Nadu, so many of ENTs, they don't have cases to operate like adenoid or mastoid, all these things. So they just try to creep in nearby structures. So next is easy even in the curriculum of Dr. MGR Medical University, that is the university that controls all medical colleges in Tamil Nadu. Thyroid is included in their curriculum, part of curriculum of ENT. So if we take per year, at least in a year, 150 to 200 MS ENT PGs will be coming out per year in Tamil Nadu alone. So what they do is they now even have a separate society, I think, Indian Society of Thyroid Surgeons, something like that, where they are ENT or the main. So previously we had only general surgeons who were resisting. Now even in corporate setup, this ENT persons will be, so it will be over a period of time, it will become more and more difficult. I'm not actually, what to say, I'm not having a disappointing thing, but the thing is, that is a fact, sir.
these are difficult or
Because moreover, another thing is we don't have pharma, though I'm sorry to say that other associations, all these things, they have a good pharma backup. If you want to conduct a conference or anything, even medical endocrinology, they conduct a conference, they have a good pharma backup. We focus only on quality and um, even if you see, I may be blunt. I have seen all these PG course more than 15 years. The same number of, we are not able to increase the number of attendees. I'm sorry to say, sir. We have still 15 years back, what was the number? Still we have the same. We are not able to increase the number of even the participants at these quality PG courses. Though we can say, if 5 of us let them come, that's okay for us. It's not that. If we want to spread it across to everyone, we need to increase the number of participants. We need to increase the, then only it will spread to other places.
we need strength of numbers. We need to increase the total number of endocrine surgeons in the country, and that will happen only when we have more training courses. Dr. Divya, National Medical Commission governed institutions have their set of problems. NMC has quite restrictive, very stringent criteria which need to be met to start a new course or a specialty department. INIs like PGI Chandigarh, where you work, have somewhat different system for these. And in your own unit and your program of which you have started, MCH Endocrine and Breast, is an example. Isn't it possible that we have a unit or a department of endocrine surgery and then MCH in majority of INIs? And what kind of efforts do you think are needed to ensure that happens?
I will repeat some of the things which has been told by Dr. Mishra, Dr. Paul, and Dr. Dalapati. It is first we have to create the awareness. It is not for the patient, it is for our.
Please keep the mic closer to you. Now the mic is working.
That's it. Okay. So the first thing is increase awareness among our own faculty and to make them like they have to accept it. The problem is of acceptance. Even if you do, there is lot of resistance. Then awareness among residents should also be there starting from the MBBS, because when they join MS course, they have like I have to become neurosurgeon, I have to become cardiac surgeon. They are not even aware of that this specialty exists. So the awareness should go to them as well. And even if we have the MS course, when the residents come to us by rotation, say some resident have come to us in third year. So they will be surprised to know that endocrine surgery has so many things. They were not aware of even staying in the same department. So the resistance is at a lot of places and they like keep saying against. So we have to break that barrier. That is the foremost important thing. And second thing I think important is we should have a structured program which should be uniform among all the institutes, so that like the residents have the better training and in the same format. And wherever say we don't have a robotic or endoscopic surgery to at present, then there should be some exchange program so that resident should not be felt left out. That will also give that we take care of them. So
Yeah, that this nobody can deny these facts,
Mm.
but specifically about the institutes of national importance.
Mm.
Do you have any idea? Because you've done this process yourself very recently. If there are other INIs, other AIMS like institutions which have a desire to start a unit or a department and then NCH program, what would be your advice to them?
So I still feel if there is awareness and there is demand, then no one can stop. If we are only saying that we have to start and then the people will come, then the resistance is already more, they will stay at a higher level. But if there is a demand by the residents also that they want to join this course, the resistance will dilute to some extent. And the breast course also, I think
because they are promoting at a very like rapid pace. Every month or every second month they have program or the workshops are going on. So we should have the similar structured program for endocrine and breast, and we should be doing it like more regularly, and it should be advertised so that more people should join. Even we should try to have say undergraduate students to attend it also, so that they are aware of that this specialty it exists, so they can also attend these courses.
Okay. Dr. Huda, so one of the issues that has emerged, overlap of specialities, specifically overlap with general surgery is always going to be there. I don't think this will ever be a thing of past. You being a professor of surgery and you would be facing this issue with other units in your department, what is the way forward? How do we carve out a unit specifically for endocrine and breast surgery?
So I think the most important thing over here is the leadership. Like in our institute, when the breast and endocrine unit was started, our director was a surgeon and he understood, he was very positive about it, that we have to have to develop a focus area of interest. And our head of the department was also of the same view. So it was very easy for us to make a unit and to start working in that unit. I think leadership is important, and then collaboration is also very important. Collaboration amongst our endocrine surgeons and collaboration amongst different specialities is also very important. I think if we take them as a threat, then it becomes difficult to survive, definitely. But if we collaborate with them, then definitely things become easier. I think these are the two things which are very important.
I think they're both very pertinent, very important ones. So Pooja, so one thing that has emerged from views from the experts is that we need to create more awareness. We are living in a era of social media and informal communication more than formal, the kind of communication media that were used 2 decades ago, 3 decades ago. What can we do both as individual surgeons, institutions, and also as the association, you being the secretary of Indian Association of Endocrine Surgeons, what can we do to send this message out widely about what endocrine surgery is, and then try and attract young trainees into our specialty?
So very valid point you have raised. In fact, I was thinking to start podcasts. You see, everybody is now listening to podcasts. So I thought, let the juniors interview senior faculties in endocrine surgery and let us put that on the social media, maybe small 5 minutes, 10 minutes. And there should be like career counseling sessions also for MBBS students, how to take. So I think that will attract them. In KGMU, I think in all colleges now, elective posting has started in MBBS students, and we ensure 2 weeks they stay with us. They have a very good time, and we take their feedback and we encourage and we ask them how many will take surgery and will come to endocrine surgery. So we ensure at least few of them have that motivation and desire. So exposing these MBBS students, involving them actively, plus doing what they see reels and they see all these podcasts and social media things. So we have to be very prominent in that. So I think that way. And then like in IAS also, we have started off now separate category for MS residents to compete, not with MCH candidates separately. So I think that also motivates them to come. So many people, I'm happy, AIMS, Delhi, I think 7, 8 PGs are coming, MS residents. So like that, if we encourage them from different institutions, so they get the exposure and see what we are doing. So I think that has to be increased.
Okay, so I mean, I think maybe beyond what we have all discussed, perhaps something which Dr. Divyas did mention, we need more frequent meetings. They may be simply online meetings, informal ones, but to stimulate some participation, both from practicing surgeons as well as from trainees. Dr. Vivek had an idea, and very pertinent one. He mentioned that today, if we want to search for a parathyroid surgeon in the country, the search engines would give you options of all ENT surgeons, head and neck surgeons. Why is it that we have lagged behind in this game? Why are the why have we not hired as SEO or search engine optimizer to bring endocrine surgeons as the first choice surgeons for parathyroid surgery, for example, or for that matter, of pheochromocytoma or any such thing? So this is something we must act, and it's not in interest or it's not the necessity of an individual. This is the need for the entire fraternity. So I think we will take this suggestion from Dr. Vivek further, that a group of us, or perhaps eventually the association, can work towards this. So we have heard from the experts. We have also asked similar issues and similar questions, as well as certain others, because I know that people practicing outside of the medical institutions have different, all these challenges, but it's additionally a few others: employability, remuneration, acceptance from both referring doctors and endocrinologists and physicians and the patients and society. So those are the additional things that we asked our alumni for. And then these are the responses. The responses we have received, but actually we also collected some data about who are these people who are responding to us. So of all the faculty, of all the responses we got, 6 of them had engagement with SGPGIS faculty, 14 have done MCH here, 3 have done PDCC, 4 senior residency. Not all who got these messages or mails responded. So that itself states some reason why there's so much, there's lack of enthusiasm amongst us. And the people who have stayed here for varying durations, it has ranged from 1 year to 5 or 6 years. And their current designations, people have stayed to the nature of practice. So majority of the alumni who have responded, they are currently working in academic institutions. This may not be truly reflective of all of our alumni, but it is true that a large majority of trained endocrine surgeons want to stay back in an academic center. A few of them are in corporate hospitals, and just a very few are in independent practice. But we also asked them that what was their preferred option of working. And those who responded, a majority wanted to work in an academic institution, which tells me that there are not sufficient academic positions available. And that is exactly what the experts have been also telling us. We need to create more training opportunities in academic institutions, which will result in more academic positions opening up to retain our academic minded trainees in academic setups. And eventually that will lead to larger number of trained endocrine surgeons practicing in the country. So that is, again, not unexpected. What we also asked them was what was the kind of practice they are doing, whether it is exclusive endocrine surgery, which was a minority, or is it endocrine, breast and general surgery, which is very few, or breast surgery exclusively. I know there are only 2 such people who responded to that. A vast majority are doing endocrine and breast surgery as a practice. And this is not only, majority are still working in academic institutes. So even those who are in academic institutes continue to do both. And only few of us have the luxury of doing exclusive endocrine surgery or exclusive breast surgery. In a way, it is a compulsion. Perhaps it will remain to be a compulsion. This is just to take some idea about what proportion of the practices of our alumni is thyroid surgery, parathyroid surgery. On an average, parathyroid and adrenal have been less than 10% in everybody's experience. thyroid surgery is the commonest endocrine procedure, ranging between 30 and 60% from the various respondents, barring those who are doing exclusive breast surgery. And breast surgery again is between 30% and 60% in the hands of those who are doing both endocrine and breast surgery. So these are the more important questions now on. We ask the alumni what are the challenges they are facing in practicing endocrine surgery in the country today. And then again, the quite well-known factors have emerged: lack of awareness for referrals, and then overlapping with other specialities, lack of acceptance by hospitals and universities or institutions to create units or departments, and few other things which are not so. And of course, ours is a rather niche or narrow specialty. So we will have to continue to dabble with or tackle these challenges as we go. What aspects of training at SGPGI in the opinion of our alumni benefited them most? The answers are in front of you. Majority responded that all of these: surgical skill development, academic and research exposure, mentorship and guidance, clinical decision making, and professional networking, they were of help to them. Of course, this is only part of the story. The rest of the story I would expect when our alumni speak out from the floor, they will bring out those issues. At the end of the tenure of training at SGPGI, in minds of our alumni, we asked whether they thought the training was too intense, too laid back, or just right. Well, I think majority have been kind to us. They have given a rather political answer. You ask the first year residents, whom I don't see here, they'll certainly say it's way too intense. And then in their minds, for the faculty, it's all way too laid back. Isn't it so? But jokes apart, this is something which we take it very seriously. I'm sure every teacher, every faculty, irrespective which institution they are working in, they want to make it just right. But that's a difficult balance to find. We must continue to discuss how to achieve that. Did the training at SGPGI prepare our alumni adequately for practice outside the institute? And a vast majority think yes. Again, I'm quite happy to hear that, but there's a possibility that we'll hear more about this aspect too when we talk to the alumni. And then, more importantly, we ask them for their suggestions. Okay, no, before that, we thought we asked them if an SGPGI endocrine surgery alumni network is helping them in their clinical practice. A vast majority do think yes, it is helping them, which means we have an active alumni network. And I must here to the few alumni which are here in the hall request, if you have not already signed up to be an alumnus of our SGPGI alumni network or association, please do that. It is, I mean, some of your colleagues have been contributing a lot to that alumni association. And those who are not already formally members of that, please do that. Dr. Ankur Bhatnagar is the secretary, and he has sent out numerous emails and letters and messages. I'll also share the same with all of you. And then the suggestions we'll hear from them regarding how to strengthen the alumni engagement in promoting departmental growth with contributions from the alumni. So this is where I would now request the alumni who are here to please speak out, tell us their suggestions about, number one, what can we contribute towards improving the training and practice situation of this specialty in the country. Can we pass on the microphone from one end to the other? How are we doing with time? We have half an hour. Yes.
We
Okay.
start. So I have two ideas while I was listening to all this.
There are a few people
Okay.
who are not SCPG alumni who may not know
Who I am, yeah.
Really.
I'm Dr. Ramya. I passed out in 2020. I did my MCH breast and endocrine surgery from SGPGI. And initially, when I took this seat, I got many calls from my friends who said, why did you leave surgical oncology and why did you choose breast and endocrine surgery? So I said at that time, SGPGI did not show up the seats in the counseling. So that's why I had to join surgical oncology and then I shifted here. Two things that I want to tell are, one thing is, in India, we tend to choose the branch which is popular. So if we finish MBBS, we tend to choose radiology if we have the option. Then we tend to choose medicine. Then it's assumed that surgical branches are slightly for the rankers who are on the lower rank. Unfortunately, we don't choose based on our interest. So that thing has to change. So we have to encourage people to pursue what suits them and what they're interested in. And second thing is the market demand. So breast is taking up because there's a lot of market demand and it's a lucrative career because of a lot of ways to earn money, number of cases, and the implants that are used and how the surgeries are easily agreed upon by the patient. So unfortunately, in endocrine part, we don't have that lucracy. But I mean, it may be wrong technically to say that, but we can advertise ourselves more by using the new technologies like the endoscopic surgeries, robotic surgeries, and microablations and VAB. So these can be our USPs, and we can repeatedly conduct programs in these. Because if we just say hemithyroidectomy, people will say, okay, I do all of this, what's new? So I think our USP should be adopting new technologies, which we already do, and we have to advertise to be these updated surgeons who are, that should be our USP, I think.
Thank you.
Sir, I think we have three problems as endocrine surgeons. The first one is all other departments are not very acceptive of us, other surgical departments and probably some non-surgical departments. Number two, patients are not aware of us. They don't know that endocrine surgeons are very particular about their training, and we tend to be more careful about parathyroids and recurrent laryngeal nerves. They don't know the fine nuances that we are more interested in, and probably other surgeons who do the similar kind of surgeries are not interested in. They might not want to stay back to get. I mean, we had that debate about blockade versus non-blockade. So a urologist, Dr. Smita, was saying that they'll take up the next day, whereas we would delay the whole process by going by the book, at least what we consider is the right thing to do. So that is the second problem. And the third problem is who is coming into training currently. Are these people who are interested? Because previously, when we took the entrance exam, it was people who were interested in endocrine and breast surgery who would have taken the entrance exam. Even the first 2 years of NEET, it was the same thing, that you were given the option to select two specialties that you were interested in. So it was definitely people who were, at least endocrine surgery was the second option, if not first, one of the two. But now it's just an open counseling where anybody who's taken the NEET exam can come through here, even if they're not at all interested in the branch. So the reason I came, I think I spoke about this to someone. It was sir used to work in Nellore, Pratik sir. The APSICon 2012, there were 4 papers from from his Nellore college about thyroid surgery. In the same best paper session that I was participating in. And I was like, wow, where are all these 279 thyroid cases? And in 1 year, who are these people who are operating? And then one of his PGs, he told me that we have an endocrine surgeon here. Sir does many thyroid cases a week, this and that. So that awareness.
The problems, you are also providing solutions, awareness, fine.
Good evening. I'm Goonj. I trained here from 2016 to 19 as an MCH candidate. As Gaurav sir said, I think we know the problems. As an alumni, I'll speak purely in alumni capacity. I really concur with Divya ma'am's suggestion. We need to probably meet more frequently, and everyone being busy and in different parts of the country and the world, I don't think physical meetings would be as convenient. So I'm very happy to contribute online and join online, and maybe we can club both endocrine and breast. I'm very happy to share the techniques that we are using where I work, and if there's any new research that I can help or contribute with, that would be my contribution as an alumni. So I'm very happy to join online, and I end up being here for the physical meetings anyway. So as luck would have it, I think there is a connection. There's an intangible connection which brings me here anyway. So if I'm here in person, I'll be there. But I think if we meet more online, there can be more exchange and more exposure to the trainees as well. Thank you.
Okay. Pass it down to.
Basically, there are a few things which is just not right with this specialty. No, let us accept the problem first. Then only we will find solutions. We are not guys who go and save lives day in and day out. What is our USP? We improve, basically, more or less, we work on improving the quality of life. Survival हमारे किसी प्रोसीजर से बहुत नहीं बदलता. Let us be true to ourselves. और ये गरीब देश है, अधिकांश पार्ट गरीब है. सरकारें इस स्पेशलिटी पे ध्यान देंगी, इसकी बहुत जल्दी मुझे उम्मीद नहीं दिखती. Even the 6 departments we are talking about, 3 of them, that is, to me, it is a sham endocrine surgery course. It is basically a general surgery course. They are providing degrees to students. And the number of those students is increasing. That has now become more lucrative than our other endocrine surgery courses. I don't want to go into that detail. तो सरकारों का ध्यान हमारी स्पेशलिटी पे नहीं है फिलहाल. Somehow आप कोशिश भी करिए तो हमारा काम कोई ना कोई कर लेगा, चल जाएगा. We have not reached a level where there will be demand for our specialty in all public hospitals. ये समस्या है. अवेयरनेस बढ़ाएंगे हम लोग, बट गवर्नमेंट, जैसे somebody touched upon it, that why have we not able to create more faculty positions, more departments? Even the department that are running MCH courses for years now, they have not recruited a single endocrine surgeon. Or maybe lately they would have recruited 1 or 2. So we have to actually somehow get the focus of the government on our specialty. How we do it, I'm too small a person to advise, but somehow we need that collaboration.
Good evening. I am Dr. Chitresh. I trained here in between 2012 to 15, and then I've tried a lot, everything, but I could not, adjusted in a endocrine surgery department. So I have 2 options to join a general surgery or surgical oncology. I fortunate to join the surgical oncology after tried in general surgery for too many years. So the problem is, endocrine, if we are endocrine surgeon, then we are super, exclusive, and we have something that we are doing all those things which somebody is not doing. We are doing everything. But when we combine the breast with us, so we increase our competition at the same time, because now we have doing the breast and endocrine. But for the sake of the opportunity to earn, opportunity to settle, breast and endocrine is the best. It is my opinion. But the problem is, I was the endocrine, we were the endocrine surgeon. After some time, we become the breast endocrine and general surgeon. After some time, we become the exclusive breast surgeon. Now we have breast and endocrine surgeon. So there are four types of endocrine courses are running at this particular moment. MCH breast surgery, MCH breast and endocrine, MCH endocrine only, and MCH breast endocrine and general surgery. So at least we should have a consensus that what we want to go forward. Breast endocrine is the best for me. I mean, it's open to all. So initially there was a confusion that what endocrine surgery is all about. Now the confusion is endocrine surgery same with the endocrine and general surgery and breast? Does the breast surgery is different from, and we all are same. We all are doing this the same thing. We are doing sometime thymus, parathyroid, thyroid, parotid sometimes. We all are trained. So, but consensus is not there. The four names for a same MCH curriculum is not, it should be stopped as soon as possible. But my humble request is we should come at one platform. The name itself.
Again, so no, I mean, there cannot be two opinions about this, unfortunately. So far, whatever little efforts have gone towards that have not succeeded, but we must continue those efforts. Yes.
Yeah, good evening, everyone. I'm Dr. Vishwak Chandar. Got trained here in 2018 to 21. Sir, in last decade, we had seen head and neck surgery and breast surgery specialties had grown glorious. One reason for that is their numbers have increased in the last decade. So how does their numbers got increased? It's because of most of the general surgery people, they took fellowships in breast surgery. After MS, they got trained in fellowship and now they have become the breast surgeons. That is the one reason why the numbers have increased. Similarly, most of the hospitals are running fellowship in head and neck also. So the one strategy is, as Hip sir pointed out, if we make the specialty name as endocrine and breast surgery as common, that would welcome most of the MS general surgery people to join MCH endocrine breast surgery course. So it's one way. The other way is people working in corporates and other specialties, they can try to open up their fellowship specialty in breast and endocrine surgery. So in that way, MS general surgery people can get into the fellowship, just like how fellowship in head and neck surgery and breast surgery had grown up in the last 10 years in so many corporates. So if our numbers are increased, automatically the endocrine breast surgeon exposure will be increased across the corporate. That would help a new a fresher who is just finishing the course to get a job, which we are finding it difficult at the present juncture. Thank you.
Okay, fellowships by
Sentence to say. We have been in the process of changing the course of our degree and department name from endocrine surgery to breast surgery for years. We have not succeeded somehow. I would advise something a bit more different. Please change it to breast, endocrine, and general surgery. I'm saying it after giving it a lot of consideration, because employability of endocrine surgeons has been an issue for years. And this at least improves the employability.
Okay.
You need not teach them general surgery. They are already general surgeons.
So, Pradeep, before you start, we have a tiny takeaway for all our alumni today. I hope you will wear these with pride. Please.
Yeah. Sir, I've listened to many of the things which have been said by the people who have established the departments here and outside Lucknow. I've also listened to some of my juniors who have been here. I passed out in the second batch. But when you look at the specialty, if you look at my hospital where I'm working, there are about 9 urologists. There are about 5 surgical gastroenterologists full-time working in that hospital. Now, all this.
So this is going to happen. This is there. All specialists are coming out. The specialists are coming out in every specialty. Their numbers are going to increase, and you will have to compete with them. Similarly, the other thing is, as a student, when you are taking a course, whether it is urology, surgical oncology, endocrine surgery, you should fix what is your idea. Why are you taking it? Nobody has compelled you to take it. I took it by my choice. There was only one department of endocrine surgery in the whole country conducting this program. I took it by my choice. I know the employability. I know what I have to do outside. And after going outside, I had to market myself. That is why somebody mentioned that from one college, about 10 papers were presented. Why? It's a sort of marketing you have to do. You have to ask, what is your aim? And based on that, you work. So as Ramya said, it all as far as the specialty is concerned, you can start the courses, but there has to be demand. So if there is demand, the private colleges, they see whether it's a demand for endocrine surgery. If there is a demand for endocrine surgery, they will start course. Otherwise, they will not start course. So demand comes from the students. The students have to come and take. If you see the earlier, we used to conduct separate exams for SGPGI Lucknow, SGPGI. You used to have for 4 seats, maybe 15 people will write. Whereas for a surgical gastro, 4 seat, 150 or 200 people will rise. There's a demand. So people will start. So it's basically, you have to decide what is your aim, what you're going to do, why you have taken the specialty. You go on that, you mind your work, and everything develops by itself. Thank you.
Please, like to Nikhil. Dr. Nikhil.
Thank you, sir. Actually, I did my PDCC years back. That time we didn't have MCH course. So I was hearing the people, what they were saying. And I agree with Pradeep that if you really want to go in for this branch, then you should go in for it. And yes, for me, because I did not do MCH, so it has given me a boost for my general surgery training also, because the places where I had visited, where I had taken my training, sort of training in thyroid and things that I got out here, has certainly boosted my practice and everything. So I'm certainly very happy after having done the 3 years residency and PDCC out here.
Okay, maybe I'm interrupting this flow, but one fact that undisputed fact, all the trainees of endocrine surgery, not restricting only to SGPGI, have established themselves well in their practices, academic or otherwise, without exception. It takes a little while. It may be the waiting time may be longer for some compared to the others, but eventually everybody has found their niche. It is the initial hiccups which make everybody a little scared, but the discussion point really is, how do we improve or how do we expand this? The few that we are training right now, they're doing quite well, but the numbers are not growing. Okay, Dr. Deepen.
And one thing I would like to say, it's almost 16th PG course of endocrine surgery. And when I was in MS program at KGMC, and this PGS course, which was in 2007, means at 8th PG course. So I attended in second year, and this course really inspired me to join this endocrine surgery program in MCH. And one inspiration which came, Pooja ma'am is my senior, and she joined this course. Dr. Sudhi is my senior, my batchmate, but she joined this course 1 year back. And these two things also inspire us to join this course. In same way, I am thinking, because I am currently working in Autonomous State Medical College in Gonda.
And this is very initial phase of medical college, because just district hospital, these are converted into medical college. And I'm working in general surgery department, and there we have lot of resident, non-PG resident, and they are all MS. Lot of interns are there, and there we have to just working general surgery work along with breast and thyroid work. And this is this surgery can be done in periphery very safely, provided we have very good general anesthesia and we have anesthetists. And in district hospital we are doing breast and thyroid surgery. One thing I am saying very proudly, and these general surgeon, they are seeing the quality of work, they are inspiring, and maybe I will inspire few residents to join this course. And regarding the uh, in financial gain from this specialty during work, really sometime it is difficult. And in tier 3 city you have to also work of general surgery to survive, because only doing endocrine surgery in these city will not suffice. Thank you, sir.
Dr. Vivek, 2004, 5 joining alumni from this place, practicing in Delhi. Lot has already been said, but few points which I would like to contribute. Before that, on a lighter note, I would say at times I am the costliest surgeon of India, charging 1 lakh surgical fees for a half an hour surgery, parathyroid focused parathyroidectomy. So don't get disheartened. It's not that poor a branch. Then, yeah, coming to some concrete suggestions, as I said, presence of social media has can really play a role, because I'm getting at least one call every day because somebody has searched me on net. That is when I have not made my presence, not made an effort to make my presence on web. So if I do that, probably numbers can really grow to the extent that I cannot handle. I'm sure about that. Second thing is DNB programs in surgery, which are running in a lot of corporate private sectors nowadays in general surgery. They have this inbuilt rotation to different specialties for a few weeks, like for plastic surgery, urology. So endocrine surgery has not yet been included. So if I don't know if somebody can reach the NMC authorities and put this thing also into the curriculum, that can really boost the awareness. Then, of course, third thing in practice, I can talk about private practice only. So once you are into practice, your work will demonstrate. It's just matter of time, and you'll definitely get your fair share. Competition is not to be considered at all. There are thousands of general surgeons competing within themselves and surviving. So after an extra training, you got to survive. There is no reason you'll not survive. It's just matter of time and maybe a little bit of finances here and there. So I think that's all I have to say.
I'm Kulranjan Singh, Amrish Puri of today's, this afternoon. I heard a few, I think we're getting, we should be more optimistic. I don't see a problem with our employability at all. Tell me one alumni from any of the institutes who is not doing well, maybe after a time lag of 5 years. It's just that our generation has lost that patience. We want everything on day one after passing out. If we look at our seniors, the way they went through that hierarchical, the steps that they crossed to reach the stature today, I think we as youngsters want it too early. So patience is the key. And all those people who were talking about employability, if you can get me one person and tell that he's not doing well at 5 years down the line, then I think we are in the wrong place. But I'm sure no one can come up with the name who is not doing well and who wants to do well actually. अगर किसी को नहीं करना, he'll not do well anywhere in any branch. And if you look at Lucknow per se also, यहाँ पे 100 neurosurgeons, 100 urologists, take care. If they can survive, why can't 5 to 10, 15 endocrine surgeons survive? So that survival instinct is something different. It doesn't have much to do with our speciality. If you look at KGMC per se, there is a endocrine surgery department, and we have 2 alumni in general surgery department who are recognized as endocrine surgeons within and outside KGMU. So that also is not a good thing to say that कि कोई उस तरह से recognition नहीं है. Some people की faculty post नहीं है. आज की डेट में सैफई में faculty post है, no one to take it. आगरा में endocrine surgery की faculty post है, no one to take it. RML has been lying vacant for years. So these things are there. It is just that we have to keep our eyes open. और एक प्रॉब्लम बीच में आई थी, आई थिंक द प्रॉब्लम वाज दैट कि एंडोक्राइन सर्जरी वाज अ सेकंड चॉइस फॉर एवरीबॉडी. शुरुआत में पीपल हु वर मोटिवेटेड फॉर एंडोक्राइन सर्जरी दे केम इनटू द फील्ड, बट बीच में हमारा एक सेगमेंट बहुत सारा ऐसा था कि हु टुक एंडोक्राइन सर्जरी बिकॉज दे डिड नॉट गेट द फर्स्ट चॉइस. एंड इट इज दिस लॉट एक्चुअली वेयर ऑल दिस pessimism or them not being so positive comes in, क्योंकि उनका कभी पहला पैशन था ही नहीं, and then they don't have that thinking I have to move forward with this. So that was something which was on our part. I think once we choose the specialty, we have to work for it. Another thing, what I have noticed ki endocrine and breast should go together. And I think even if breast is not added in our degree, we have come a long way. If TMH has recognized MCH endocrine surgery as one of the degrees which they would consider for a breast faculty, I think that is a recognition big enough. Dr. Dilip has been there. It is a recognition big enough for us to be considered as endocrine and breast surgery. Dr. Vishwak, I think there was no dearth of surgical oncologist or breast surgeons in Delhi, but he being an MCH and endocrine surgery alumni from SGPGI and being accepted there and doing well and रोज नए झंडे गाड़ते हुए, I think that recognition of breast is already there with our specialty. We just need to take it a little higher. So breast आए ना आए, I think we have come a long way, and this trend will continue. जहां तक सीट बढ़ाने की बात है, in KGMC the administration was kind of pushing us कि आप 5 सीटें कर दीजिए. Currently we have 2 seats. We have recognition for 5 seats. But the 3 of us, Anand sir, Pooja ma'am and I, we put our foot down. कि we will not increase the numbers just for increasing the numbers. We need to also give quality training. ये नहीं हो सकता कि हम 5 का 5 हर साल बाहर भेजें, but they are not competent enough कि वो market में जाके फिर KGMU या endocrine surgery का नाम, they are kind of botching it up. So numbers are important, but what would probably speak is the quality.
Thank you.
Yes, I think I'm taking too much time. I'm sorry.
Points, all very correct. I'm reminded by Abhishek that we have to now wrap up. So Dilip, as the last feedback to provide, and then
Shalik.
Shalik.
So
He is
I'm
also here, so we
yes.
have to now plan for the next session.
So good evening, everyone. I'm Dr. Dilip. I am presently in Tata Memorial Center as Associate Professor of Breast Surgery. So I completed my training MCH from 2019 to 2022. Ramya ma'am aptly said there should be demand. And so how do we create this demand and awareness? I have one small point. If we can, because my interest shaped or was more towards breast oncology for 2 facts. The one is a personal fact. The second one is I had a posting in surgical oncology where I used to see these breast cases being operated. So that where the interest stemmed. So if we can take these MS general surgery candidates into a compulsory rotation into institutes like SGPGI, CMC Vellore, KGMU, into endocrine surgery units for about 15 days, 1 month of rotatory posting, I think we will instill that interest in them. So if we can push that agenda into the admin or into the general surgery department to send those students into the specialty units in during their rotatory compulsory rotations that they have in a specialty rotations. So probably we will have a lot of awareness coming out. Now they will know what exactly endocrine surgery is, because I did not have a rotatory posting. I did not know exactly what I was taking up is in endocrine surgery. So, but when I come here, it's a whole new world which has opened up. So it's really very fascinating field, and I'm now missing that I'm not doing endocrine surgery. So I would like to see it happening one day. So that's my small advice, sir.
Thank you. Sorry, we have to wrap up now. So only such people.
So just to say few words, like we all are working in very, very different scenarios. Few of us are working in a very high volume centers, tertiary care centers, few in a medium, and few are solo practitioners. So the thing is, one thing is common among that we all are breast and endocrine surgeon by heart. The thing what I just want to put so that we can grow better as per my view, uh, uh, we should celebrate each and every a small win we should celebrate, because it is uh, they are working in their own scenario. We don't know what are their challenges. So it may seem a bit innocuous कि अरे इतना छोटा सा effort था या कुछ, but that was an effort in the field of this breast and endocrine surgery. So we should encourage each and everyone.
Your words are, you are doing exactly all that which we all have been talking about. We need more such efforts. Thank you.
Thank you, sir.
Shalik, you want to say something? Then we.
I'm Dr. Shalik. Right now working in Kannur Medical College in Kerala. But I don't have much to say, just add 1 or 2 points, that's all. After MCH, after going back Kerala, it was kind of difficult to get a job as a specialist, because maybe the same applies to oncosurgeons as well. There are many of the hospitals take is that if you can do thyroid, breast, all these patients by a general surgeon or an ENT, why they should pay extra for that is a kind of attitude. And many of the established surgeons won't allow you to get a job there. But so I had to join in a general surgery department. And what I feel is you establish yourself as a in a general surgery department and slowly develop your own volume of cases with the quality of work, and the difference in the quality of work will be shown by the training we are given so far. So I think we'll do a better work in a macro environment, and we'll do our own department and bring glory. That's what I feel.
Thank you. So yeah, so I feel a lot of very different kind of perspectives have emerged from hearing from all the alumni. But I would like to remind, and I'll end this session by sharing the optimism that so many of the colleagues, so many of the alumni have expressed. It's a fact. There's no single endocrine surgeon with a training in the country today who has left or who's not well established after 2 years of starting the career. Not one. And it is not only SCPGI alumni, CMC, Madras Medical College, AIMS, Delhi, whichever. So this pessimism emerges more out of 2 facts in my mind: a need or a desire for instant success, which is absolutely not possible, not for any specialty, barring perhaps a few diagnostic specialties. So yes, there's a need for some career counseling and some reality check for everyone, including the new students. And second, out of the fact that the number of institutions offering MCH or training programs in this specialty has rather stagnated. And I fully agree, each individual institution cannot continue to increase the number of seats because that will certainly compromise the quality. What is needed is to add new institutions to offer similar quality training. You cannot overnight increase the production of one factory. You have to establish another factory. So, I mean, I'm not saying MCH producing factories can never be made, but whatever you want to produce has to be the end product of a well thought of complete process and not just by increasing productivity of one individual institution. So I'm sure we will continue to discuss these things even later this evening when we interact more socially. If there are any thoughts regarding specifically about increasing or improving training environment opportunities and employability or practice of endocrine surgery in the country from anyone, please. Okay, and then we end this.
I may not be able to join this. So what I think, rather than increasing the MCH seats, it would be good. Like there are a lot of MS, post-MS surgeons who are looking for like their MCH. They may not get MCH. Not all MS get MCH. So they look for fellowship programs. So we can affiliate some and plan some curriculum where any solo practitioner, suppose if I want to attach some MS to me, they can work with me for some time. I'm not giving any degree, but the logbook will be prepared where they know that they have done such type of cases. So at least they will be now more inclined. So like the one who has come with me. So now he's inclined, he's attached, therefore he got attracted, he came here. Now he's more inclined to do MCH. He's prepared. It is not his second choice. It will be his first choice. So these small clinical attachment programs we can encourage among our alumni and fraternity.
Thank you. Dr. R.B. Singh, you wanted to say something. So, okay. So thank you all very much for your inputs. We will now move into the last session of day. That is our Foundation Day session. I thank all the panelists, the experts for their words of wisdom. Thank you all very much. Please remain in the hall. We'll straight away start with, as soon as our director arrives, we'll start the next part.
now my privilege to invite our esteemed guest for the evening onto the dais. Professor Aditya Kapoor, Acting Dean, SDPGIMS. Professor Shaleen Kumar, Acting Director, SDPGIMS. Our chief guest, Dr. Marudu Pandian, incoming President of ASI and past President of IES. I would request Professor Gaurav Agrawal, Head of the Department, and Dr. Sabha Ratnam, Organizing Secretary, to kindly escort the dignitaries on the dais.
I would request my resident colleagues to please welcome the chief guest as well as directors, sir, and canteen, sir, with the bouquet of flowers.
May I now invite our esteemed guest, along with Professor Anjali Mishra and Professor Gyan Chand, to join us for the lamp lighting ceremony, symbolizing knowledge, wisdom, and purity with a multi-faith surgical prayer.
महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
الله لا إله إلا هو الحي القيوم لا تأخذه سنة ولا نوم له ما في السماوات وما
एक ओंकार सतनाम करता पुरख निर्भव निर्वैर अकाल मूरत अजूनी सैभम गुर प्रसाद जप आद सच जुगाद सच है भी सच नानक होसे भी सच.
Thank you, dignitaries. Kindly be seated with the divine blessings invoked. May this evening inspire us to carry forward the legacy of excellence and innovation. To formally welcome everyone, may I now invite Professor Gyan Chand to deliver the welcome address.
Good evening, everyone. On behalf of Department of Endocrine Surgery, it is my proud privilege to extend very warm welcome to all of you on the occasion of 37th Foundation Day of Department of Endocrine Surgery. The Foundation Day is the moment of pride for all of us to reflect the remarkable journey of our institute and the department, to celebrate our achievement and ourselves mission to excellence of patient care and research. The Department of Endocrine Surgery has been an integral part of this journey for growing into one of the leading centers in the country to management of the endocrine patients, including the thyroid, parathyroid, adrenal, pancreas, thymus, and other organs. This has been possible just because of the vision of our founding faculties, dedicated teachers, our staffs, our enthusiastic students and residents. We are privileged to have among the today our respected director, sir, distinguished faculty, dean, president, secretary, and president ASI, colleagues, friends, to join this celebration of this milestone. Your presence truly inspires us to add the joy of this occasion. Today's program has been thoughtfully designed to showcase of our academic and clinical work of our department for sharing the knowledge and engage in the meaningful discussion that will help us to save the future of endocrine surgery. Once again, I extend heartful welcome of all of you. Let us celebrate this day of pride and enthusiasm to continue our journey towards the excellence. Thank you very much.
Thank you, sir. It is now my privilege to invite our respected Acting Director, Professor Shalin Kumar, to kindly address the gathering.
Good evening, ladies and gentlemen. Professor S.K. Mishra, our current Gaurav Agarwal, Professor Gaurav Agarwal, the head of department, Dr. Aditya Kapoor, our distinguished colleagues, Sabaratnam, ladies and gentlemen. I am representing the director today. So, our director, Professor Bhiman, has taken a refreshing stand that every department will celebrate its foundation day in its fullest fervor and form. But the Department of Endocrine Surgery needs no inspiration. Founded, I think, close to 34, 37 years ago, with Professor S.K. Mishra in the lead for the better part of 2 centuries, 2 decades, almost 2 decades. I don't know the exact dates, 2 decades. The department has started from, it was a disruptive concept in the landscape of Indian medical education, the first of its kind. And today, I understand that it boasts of no less than 25 academic departments, Dr. Gaurav, 25 academic departments in the institute, in the country?
No, not yet. We're just about 8.
8, but about 70, 80 alumni?
Yes.
Right. So that's a lot. That's saying a lot for this specialty. And the specialty stands very tall within SGPGI for all the work that they do, with some faculty members there being amongst the top 2% of the researchers, most quoted researchers in the world, in that category as well. It's no mean feat. So I understand now, this time they have chosen a topic. This postgraduate endocrine course, surgical course, happens once every 2 years. And they talk about precision, they talk about precision in endocrine surgery. I think increasing the precision of procedures in endocrine surgery. And that is essentially about quality assurance. It's essentially about getting it right. I think there would be audits, I'm sure, and then lessons to be learned, trials designed, tested, and improvements made, something to that effect. Is that right? Okay. So I wish you all have a pleasant series of deliberations. I think there's much more to come. And once again, on behalf of the Institute, I welcome all of you, and I hope you have a pleasant stay.
Thank you so much, sir. May I now invite Professor Aditya Kapoor, sir, to share some words with us.
Hi, good evening, everybody, dignitaries on the dais and Professor S.K. Mishra, sir. Gives me immense pleasure to address this gathering at the 16th postgraduate course in endocrine surgery, organized by the Department of Endocrine Surgery under the leadership of Professor Gaurav Agarwal. At the outset, I'd like to extend my warm greetings to everybody present in the hall, eminent faculty members, students, invited guests from India and abroad. Now, this course, which I think Dr. Mishra started and then the department has been doing so religiously over the last so many years, it has evolved into one of the most respected academic platforms in the field of endocrine surgery. Over the last 15 editions, I think, 15 editions, it has consistently provided a forum for disseminating knowledge, training young surgeons, and building collaborations that have transcended not only institutional but international boundaries. And a good testimony to that is I see Professor O'Neill and Walsh dressed in very, very elegant Indian saris and carrying it off with such elegance and grace. So that's a sign of international collaboration as well, in my view. So the significance of this beautifully designed course does not lie only in its academic breadth, but also in its vision. I was going through the program that Dr. Gaurav sent me. There are recorded live operative workshops, debates, panel discussions, quiz, poster competitions, and focused modules on thyroid cancer management, which truly reflect the evolving landscape of endocrine surgery in the country today. And as we celebrate the 37th Foundation Day of the department as well, I take this opportunity to acknowledge the pioneering contributions of this department. Our institution has always been at the forefront of specialized healthcare and academic excellence, and the Department of Endocrine Surgery over the last few decades has not only provided exemplary patient care, but has also been a cradle for advanced training, innovative research, and global collaborations. Its alumni are spread across leading medical institutions, with quite a few of them having founded their own departments, carrying forward the legacy of excellence which Dr. Mishra and his subsequent successors have cultivated in the department. I wish this meeting great success and extend my best wishes to the department, and I hope you have a wonderful academic feast. Thank you, everybody. Thank you.
Our director, Professor R.K. Dini, could not be physically present this evening, but he has conveyed his blessings through a recorded message. May I request the AV team to kindly project the message.
Students together at the 60th postgraduate course in endocrine surgery 2025, organized by the Department of Endocrine Surgery. At the outset, I extend my warm greetings to all the eminent faculty members, invited guests, alumni, residents, and the delegates who have joined us from across India and abroad. Postgraduate course in endocrine surgery has evolved into one of the most respected academic platforms in the field of the endocrine surgery. Over the past 15 years, it has consistently provided a forum for disseminating knowledge, training young surgeons, and building collaborations that transcends the institutional and the geographical boundaries. The 16th edition is yet another milestone, blending tradition with the innovation, and I commend the organizing committee for curating such a rich and comprehensive program. The significance of the postgraduate course in endocrine surgery lies not only in the academic breadth, but also its vision. The carefully planned sessions ranging from the recorded live operative workshops debates, panel discussions, and quiz poster competition to focused module on thyroid cancer management. It truly reflects the evolving landscape of endocrine surgery. As we celebrate the 37th Foundation Day of the Department of the Endocrine Surgery, I take this opportunity to acknowledge its pioneering contributions. SGPGI has always been at the forefront of specialized healthcare and academic excellence in the country. The Department of Endocrine Surgery has over the decades not only provided exemplary patient care, but has also been a cradle for advanced training, innovative research, and global collaboration. Its alumni are spread across leading medical institutions, carrying forward the legacy of excellence. This year themes bridging tradition and technology, advancing precision in endocrine surgery is timely and forward-looking. Surgery today is not just about skillful hands, but about integrating cutting-edge technology, molecular insights, and multidisciplinary care. The sessions in thyroid cancer, parathyroid disorders, adrenal surgery, and endocrine imaging will ensure that the participants are well equipped with the most recent updates, while the debates and the case-based discussion will stimulate critical thinking. I'm also pleased to note that the active involvement of young residents and trainees through poster presentation, podium sessions, and quiz competitions. Such platforms are essential to nurture the spirit of inquiry, innovation, and teamwork among the next generation of surgeons. I urge the younger colleagues to engage actively, ask questions, and carry these learnings back to their institutions. I wish to emphasize that our collective responsibility extends beyond academic discussions. We must ensure that the knowledge gained here translates into better patient outcomes, safer surgical practices, and more equitable healthcare delivery. In conclusion, I congratulate the organizing committee for their tireless efforts, and I thank the distinguished faculty for their commitment to teaching and mentorship. I warmly welcome all delegates to Lucknow, a city known for its heritage, culture, and hospitality, and I wish postgraduate course in endocrine surgery in 2025 a great success. May this event inspire us all to strive for excellence in endocrine surgical care and education. Thank you very much.
Thank you, sir. This evening is graced by the presence of our chief guest, Dr. Marut Pandey, past president of IAS and incoming president of ASI. Sir, may we request you to kindly address the gathering.
Good evening to all of you. Respected organizing chairman and HOD of endocrine surgery, Dr. Gaurav Agarwal, respected director in charge, Dr. Salim Kumar, and dean in charge, Dr. Aditya Kapoor, the organizing secretary, the dynamic person and the meticulous planner, Dr. Sabaratnam, and senior member and founder pillar of this department in AGPJ, Dr. S.K. Misraja, the faculty members of endocrine surgery department, Dr. Anjali Madam, Dr. Gyan, and all other faculties and postgraduate students, and all alumni of this AGPJ, all other delegates and my dear students. At the outset, I'd like to thank Dr. Gaurav and Dr. Sabha for having invited me to this event. I have been attending this program for the past 10 or 12 years continuously, except for 1 or 2 times when I was occupying the post of Dean, Madurai Medical College. At that time, I was not able to attend. And this is one of the premier institute in India. And there too, the endocrine department is conducting regular academic programs. Though I am occupying the post of Association of Surgeons of India as president elect, I am happy to call me as a delegate of this CME because I love this program very much. And even today, I could enjoy the scientific programs, especially the debate on pheochromocytoma. Dr. Kulranjan and Dr. Ramya Madam were arguing for their favor. Such nice programs are being planned in this CME. And I could meet and greet many stalwarts of endocrine surgery, like Dr. M.J. Paul, Dr. Amit Taharwal, Dr. Anand Misra, Dr. Talabadi, Dr. Pooja, like that, the list goes on. I could name many. For want of time, I'm cutting short. And as far as the ASA is concerned, all of you know the Association of Surgeons of India is a second largest body in the world, next to American Association. We are having 40,000 members in our fold. And the main two objectives of ASI, number one is academics, and number two is conducting some social welfare activities. Now, as far as academic programs are concerned, we are conducting ASI time on every third Wednesday between 9 to 10 p.m. during the months of February to April, wherein the senior experts in their respective field will demonstrate some smaller procedures by video demonstration only, like node biopsy or doing circumcision or ICD for the young postgraduates as well as for the younger colleagues. Like that, one of the flagship program in ASI is RRC, Regional Refresher Course, wherein the postgraduates will be undergoing 4 stages of clinical exam. First 2 stages on offline and other 2 stages in online exam. The winner will get not only a cash award of 3 lakhs, but also have a chance of visiting and having training in international organizations like Malaysia, Sri Lanka, Japan, and UK. So that much of academic programs are being there in ASI, as well as the social welfare programs are also being carried out, like free surgical camps and blood donation camps by the ASI. Remember, this year during Surgeons Day celebration on June 15, we have collected more than 8,500 units of bags, which was donated to the government hospitals. So such programs are being conducted in ASI. I request young colleagues to become the members of ASI at this juncture. And really, I'm very happy to participate in this program. I must sincerely thank the administration, the Dean sir and the Director sir, for having full support to our Department of Endocrine Surgery. Like that, the organizing team also made their full effort to bring it into a successful program. With this few words, I wish this program, CME program, a grand success. Thank you for the opportunity given to me. Long live the ASI. Thank you.
Thank you, sir. I now request our head of the department, Professor Gaurav Agrawal, to kindly present the annual report of the departmental activities.
Thank you very much. Chief guest of today's function, Professor Marthu Pandian, the incoming president of Association of Surgeons of India and the past president of IAES. Acting director of our institute, Professor Shaleen, who's just left, acting dean, Professor Aditya Kapoor, invited faculty of the 16th postgraduate course in endocrine surgery, both who are present here in person and those who have joined us remotely. Our esteemed overseas faculty, Dr. Christine O'Neill, Dr. Walsh, and others, my colleagues in the department, faculty colleagues and residents of the department, nursing staff, paramedical staff, other personnel, support staff of the department. I must also specifically mention the leadership of Indian Association of Endocrine Surgeons, President Dr. Anjali Mishra, Secretary Dr. Pooja Ramakant, and the leadership of UP chapter of ASI, Association of Surgeons of India, Dr. Nikhil Singh, who's here, President, for having co-bashed this course or sponsored this course to some extent, and their support. And ladies and gentlemen, I welcome you all to this 37th Foundation Day celebrations of our department and the inauguration of the 16th postgraduate course in endocrine surgery, which we are all witnessing today. The department's Foundation Day is an important event in our academic calendar, and not only it gives us an opportunity to introspect, reflect what all we have done, it also helps us plan further to make our departmental activities even better in the coming year. And I would happy to share what all we have done over the last 1 year with you today. But first, for the benefit of those guests and new members of our fraternity, this department was founded this day in September 1989, actually 7th of September 1989, with joining of the first faculty, Professor S.K. Mishra. Ours was the first academic department of endocrine surgery in the country that offered a structured training back then when it was an absolutely nascent subspecialty of surgery, of general surgery. Then we started the first postdoctoral certificate course in endocrine surgery in 1979, which was later replaced in 2004 with a MCI recognized MCH program. Again, the first in the country. And from that single faculty department with just 4 beds and 1 operating sessions, which we had twice a week, we have grown from strength to strength. And currently, I may say that we are the largest endocrine surgery department in the country and perhaps the world. In regards to the number of faculty positions, number of trainees, the infrastructure that we enjoy. And we have been able to maintain our leadership position not only in the national but also international scenario. We have recently also started the PDCC course in breast surgery, which breast surgery and breast training has been an integral part of our functioning ever since the department was founded in 1989. All this has been possible due to the untiring efforts of the past and the current faculty members of the department and the support that we have all received from our peers from various other Indian and international institutions, and the successive directors, deans, and the various administrators of our institute. I joined this department as a trainee in 1994 and subsequently as an assistant professor in 97. And I find myself particularly fortunate to be leading the department over the last three years with an exceptional set of co-workers, colleagues, and trainees with me. I'll now be presenting a brief report of the activities and achievements of the department during the past 1 year. And it gives me great satisfaction to report that there's been an overall qualitative and quantitative improvement in all spheres of our working of the department. In November 2022, my request for starting a second unit in the institute was very kindly accepted by the administration. We were given the 3rd floor of the G block to develop the 2 wards of ours. We completed the construction and renovation of the work of the 2nd ward in the B tower, which houses the unit 2nd today. And that ward was started in March 2023. Renovation of the other ward took longer. And during this past 1 year, we've now shifted altogether to the 3rd floor, vacating our older ground floor ward. And I mentioned this all to specifically for the interest of our alumni and all those who have followed the department's progress over the years. we have a full-fledged floor to ourselves now. The other two significant events and progress that have occurred during this last 1 year, after a long hiatus of almost 11 years, we now have one addition to the regular faculty of the department. Dr. Abhishek Krishna has recently joined. So currently we are in all 9 faculty members, including the 4 contractual assistant professors, and more faculty appointments are underway. We have, as I said, shifted our ground floor ward to the 3rd floor. And so now we have a total of 60 beds. All those alumni who are here, I'm sure they remember those tough times accommodating all the patients in the 28 beds we used to have. Fortunately, that has eased out to a little bit, but then your successors have upped the ante. Even now 60 beds are falling short at times. We have amongst the best bed occupancy rates in the institute. And functionalizing the diabetes foot unit in the Advanced Diabetes Center is now a priority, which is just around the corner. With coming up of that unit, we will have more focused and perhaps more quality care for our diabetes foot patients. During this period, some people have left, including some of our senior ward staff who have retired. Dr. Fareen and Dr. Sushoban left after completing their tenure as the bonds assistant professors. But we have inducted a whole set of new and more enthusiastic workforce to our department who are now providing services to our patients. This might come as a surprise. Often we do not recognize the strength that we have. The total strength of our department today stands at 130, including all the faculty, residents, research staff, office staff, but most importantly, our nursing, paramedical, and technical staff, and the support staff that we have. So even this is not sufficient. We have to have more, not just numbers, but better trained staff, which we are trying to get. Over this last 1 year, we have completed the renovation of our operation theaters. Currently, we are utilizing 2 major OTs plus 1 minor OT at its fullest capacity, 5 days a week. Besides, we have 1 session per week in the robotic OT. The 3rd major OT, the picture of which you can see here, has been prepared completely, and over the next 1 or 2 weeks, we expect to start functioning the 3rd OT as well. But then having space and beds is not sufficient. Ours is a technology intensive specialty. The long pending equipment procurement and repairs are being done, and more is under process. We have the technological backbone that we require to practice the whole spectrum of endocrine and breast surgery. And over the last 1 year, we've been able to procure 3 laparoscopic surgery equipment sets, energy devices, ICG fluorescence guided surgery systems, intraop neuromonitoring system has been there for some time, ultrasonography and color Doppler machines, microwave ablation system, intraoperative gamma detection probe, which again has been there for some time, and various other things that we require for conducting our clinical and operative work. So the department has been functioning quite well with the 2 units, the 9 faculty, 10 trainees at this moment. And we've been continuing with our focus on quality and satisfaction of all the stakeholders. Good administrative and governance practice that I have inherited from my predecessors. They help us in our day-to-day working. We have a system of shared decision-making and shared responsibilities. My faculty colleagues, all of them, Professor Anjali Mishra, Professor Gyan Chand, Dr. Shubharatnam, Dr. Abhishek Krishna, and all others, they are helping me discharge the various administrative duties. They have almost independently been taking care of various aspects of this work, including taking care of the residence roster, academic schedules, and each one of them have almost an independent charge of OPD, OTs, equipment purchases, etc. And then we have this firm belief in equal rights, equal opportunity, equal responsibility for all. And I'm happy to say that all my colleagues have helped me maintain this principle or practice this principle very well. Our grievance redressal system is also functioning well, and we are trying to strengthen it even further. The 3 academic programs we offer today, the MCH Endocrine Surgery, which all of you are aware, has been running since 2004. We now have in place an NMC competency-based curriculum, which was prepared in the year 2023. I must acknowledge contribution from my colleagues from other departments, other institutions, specifically Professor M.J. Paul from CMC Vellore, Dr. Dalpati from MMC, Madras Medical College, and Professor Anand Mishra from PGMU, who were part of the committee constituted by the National Medical Commission, which I convened. And we prepared the model curriculum for MCH programs for the country, which NMC has finally approved and put up on its website in January this year. So something which was aired, a thought which was aired by many alumni and experts earlier this afternoon, that we must have a uniform curriculum for the country. This is one step in that direction. Hope we will be able to implement it well. Our PDCC breast surgery program is working well. We have a competency-based curriculum again available for that. And our proposal for approval of the National Medical Commission for this program is under consideration of NMC. And I am hoping that within the next 1 year, we will have NMC recognition of this program as well. We have in use, we've been using an objective academic performance and attendance monitoring system, which has helped the department's academic program run smoothly. And in recent few months, we have conducted another board of studies meeting to ratify some of our quality initiatives and also revise or update our list of examiners and experts, etc. So in context of the clinical practice and surgical services that we have been offering, let me now share some aspects and facts, some aspects of our facts and figures relating to these. We function only because we are supported very ably by these specialities or sister specialities, including endocrinology, radiation oncology, nuclear medicine, neurology, and various other departments, anesthesiology, and various other diagnostic departments. Important aspect to our functioning has been that more and more of our patients today are benefiting from various government initiatives to support patient care, including more patients are being financed by the government financial schemes, including the PMJY Ayushman Bharat scheme, the Pandit Deen Dayal Upadhyay scheme for government employees, and the various Chief Minister and Prime Minister discretionary funds that we benefit from. In context of the numbers of patients we treat, the numbers have been increasing consistently. The total number of new OPD registrations is expected to go up. Same is the case with the follow-up OPD cases. In context of or in regard to the admissions to our wards, earlier this year we had some disruptions owing to various conditions beyond our control. So maybe that is the reason why we had a slight drop in the total number of admissions. In terms of number of operative procedures, we have progressed slightly. Relating treatment of benign thyroid disorders, the total number of new cases, follow-up cases, and surgical procedures have progressed. The same is true with differentiated thyroid cancers, medullary thyroid cancers, anaplastic thyroid cancers. For surgery for hyperparathyroidism or parathyroid surgery as a whole, the numbers have improved by about 8%. And then we are registering more patients, seeing more follow-up patients in recent years. And the same is the story with surgery for adrenal and paraganglioma conditions. There has been slight increase in numbers. For benign breast conditions, the number of new cases and follow-up cases has been increasing, but we are more selective with surgical treatment of these cases. And one of the quality indicators as per international guidelines is the minimal number or limited number of surgical procedures that we may do. Majority of such patients we are able to manage non-surgically. The total number of breast cancer registrations has increased. Number of follow-up patients of breast cancers we are doing is increasing. The number of curative procedures, breast conservation and oncoplastic procedures has increased. The number of diabetic foot patients is also increasing, and this I expect to take a major leap after we functionalize our diabetes foot unit over the next few months. So all in all, we've been functioning well in all areas of our clinical functioning, and then certain state-of-art services that we are offering. They include robotic endocrine surgery, oncoplastic breast surgery, 3D endoscopic endocrine surgical procedures, sentinel lymph node biopsies, intraoperative neuromonitoring, IOPTH, immunofluorescence guided surgeries, and only recently we have started microwave ablation for benign thyroid nodules and certain low-risk breast conditions. This is another area of focus for us: endoscopic and minimally invasive endocrine surgery, endoscopic thyroidectomies, parathyroidectomies, minimally invasive parathyroidectomies, laparoscopic and retroperitoneal peritoneoscopic adrenalectomies, and VATS thyroidectomies. We've been conducting these all, and we are doing more and more robotic endocrine surgeries, thyroid, parathyroid, adrenal, in a few endocrine pancreatic tumors as well. And this is a picture showing some of the steps of robotic thyroidectomy procedures and certain other robotic procedures that Dr. Gyanchand has been doing. Recently, we did, just out of interest for the endocrine surgeons, we performed a combined operating bilateral retroperitoneoscopic adrenalectomy procedure where we did adrenal conserving or adrenal preserving procedure on one side. We utilized ICG to document well vascularized remnant. So this COBRA procedure, though it's not a new procedure for in context of the word, but this was our first one. And then recently, Dr. Gyanchand also performed a endoscopic nipple sparing mastectomy procedure. And as I said, just yesterday, we used our newly procured microwave ablation system for ablating one benign thyroid nodule and a low-risk breast lesion. So this is nothing new for people who've been aware of the department's activities, our teaching and training activities. The backbone of these is the structured and mentored teaching and training of each and every trainee. Every trainee is provided a mentor who supervises and monitors the academic and research activities of the trainee. We have a comprehensive academic program covering all the facets of endocrine and breast surgery. We also take due care of initiating our new trainees into the system. We conduct the induction program, and then we also prepare a handbook, resident handbook, which is updated annually. This year's handbook today we'll be releasing or unveiling that a little later. We also have a system of a well-maintained logbook, midterm and preparatory exams with special attention to areas of deficit. Currently, we have 9 MCS students and 1 PDCC breast surgery student. We have 1 PhD student enrolled in the department. We have 1 further research staff. Hopefully, we'll be inducting a few more in coming days. We have had 2 overseas and inland observers on short to medium term in last 1 year. And we have held number of CMEs and continuing nursing education programs organized throughout the day. During last 1 year, we have had visiting professors, Professor Pon and Du visited us, and Dr. James Lee from Melbourne also visited us last year. We have currently visiting professor with us, Dr. Christine O'Neill, and we have had observers, Dr. Vidhu Shekhar from RML Institute, and Dr. Sudhi came back for a vacation with us, as she's put it. But such a revisit or refresher visit always is always welcome. We cherish the uh, the visits of our alumni to our department. We've been conducting a few workshops and resident training programs, and these include a recent training program for microwave ablation and various other niche areas of functioning of endocrine surgery. There've been a few not so happy moments which we have observed during this year. As some of you would know, Professor S. Vittal, the founding president of Indian Association of Endocrine Surgeons, he passed away in November last year, and we remembered him, paid homage to him in one of our morning academic sessions. And recently, we celebrated the superannuation of one of global mentors of endocrine surgery, Professor Lee Delbridge, who retired after at 75 years of age recently. On research front, we've been doing okay. The total number of extramural grants till date have been 32. Currently, 4 are ongoing. Total number of 70 intramural grants have been carried out by various faculty members of the department. Currently, 7 are ongoing. Of the various research grants that are ongoing today, they are worth about 2.2 crore rupees. Till date, we have had more than 600 publications. And in the last 1 year too, there have been sufficient number, quite a few, 20 odd publications, peer-reviewed journals plus 4 book chapters, making an overall number of 600. And it's not just the numbers that we are bothered about. We also have an eye on the quality of these publications. Many of our publications are frequently cited, and these have resulted in quite a high index, H index of some of our faculty members. I have been fortunate to feature in the top 2 scientists in the world list for the last year too. All in all, the faculty members of the department, we have delivered more than 40 invited lectures and talks and orations in the last 1 year. Our residents have been bringing prizes consistently to us, and this is a reminder to all of you who are here that these are not sufficient. We need more. On national and international arena, in the Indian Association of Endocrine Surgeons, Association of Surgeons of India, Association of Breast Surgeons of India, Asian Association of Endocrine Surgeons, our residents have won Best Paper, Best Poster awards in last 1 year. And one creditable mention that I must make is one of our trainees, Dr. Samprati, presented a podium paper at the American Association of Endocrine Surgeons. Again, I think this is the first for our department to share. So I'm sure again, majority of people in the all know that we have been doing number of community awareness programs, mostly centered at breast cancer awareness. Last year has been no different. We have conducted at least 30 public awareness events in last 1 year, and these have included, the most significant of them was initiative taken by Dr. Sabha to reach out to women participants or women Shraddhalu who came to the Kumbh Mela. Kumbh, for the benefit of our overseas guests, is the largest congregation of humankind anywhere in the world, which happens once every 12 years and is held not so far away from our place. So we reached out to women, conducted a breast cancer awareness campaign during that. I hope it is. And we've had few other initiatives, both in hospital and elsewhere, including some innovative slogan making and emojis making competitions for nursing students and various students of the institute. This is the happiest and most favorite slide of mine. We believe that a department that celebrates together, grows together. We've had numerous recent occasions to celebrate. So we suggested that we must celebrate even the smallest of them. I'll remember that, and in the next year, probably my report would have 10 times the number of pictures that you see here. But indeed, I have no complaint. All my department colleagues, nurses, residents, staff in general, and faculty colleagues have given us enough number of celebrations together, and that is what is making our department a happy department. So all in all, it's been a satisfying year for all of us here in the department with much progress and achievements, and of course, a small share of disappointments too, which I hope we will take care of in coming days. I thank you all for your patient hearing and for sharing this occasion with us, and for our uh, specifically for our guests from overseas, uh, some of whom are not here all at this moment, the faculty of the 16 PG course who have traveled from all across the country, and the delegates, the alumni. Thank you all very much for coming here and sharing this occasion with us. Thank you.
Thank you, sir. This is indeed a moment of pride for us. We now move to the unveiling of the Residence Handbook and the department website, reflecting our commitment to the structured learning and innovation. I request our Chief Guest and Acting Dean, Professor Aditya Kapoor, sir, to please come.
Request Dr. Abhishek Krishna to join the stage.
I would like now for the international faculty to please come up on the stage to receive their prizes. First, I would like the chief guest to present a token of appreciation to Dr. Joanna Walsh.
Good evening, everyone. At the outset, respected chief guest, guest of honor, respected director, dean, esteemed faculty, alumni, residents, delegates, staff, family members of SGPGI, ladies and gentlemen. On behalf of the organizing committee of PGES 2025 and the Department of Endocrine Surgery, SGPGIMS, it's my proud privilege to deliver the vote of thanks on this memorable occasion of our Foundation Day. At the outset, I extend our deepest gratitude to our chief guest, Professor R.K. Dhiman, Director SGPGIMS, Professor Dr. Shalin, Director in charge, Professor Dr. Aditya Kapoor, Dean in charge, for their gracious presence and inspiring words. We are equally indebted to our guest of honor, Professor Dr. Marudu Pandian, who has been my teacher from 1998, for his constant encouragement and support, even in IAS activities as well. Then I thank Professor Gaurav Agarwal, my teacher, who has given me the opportunity to conduct back-to-back PGES. This is the second time I'm conducting. Thank you so much, sir. And the 7th conference with him as organizing secretary, that I find like I have done something in SGPGI. I thank my unit chief, president of IAES, Professor Anjali ma'am, for tolerating me in the unit, as well as she's been my mentor and like